large. In the early stage, there you can see that there may be just could be apathy. Then there may be impairment in the memory, echinacea. Then they may present with seizures. In the late stages, headache, incontinence, visual disturbance, endocrine disturbance, anosmia on examination, and sometimes you see Foster Kennedy syndrome. The blood supply is anterior posterior ethmoidal artery, meningeal branches of ophthalmic artery, anterior branch of middle meningeal artery, and some branches of anterior cerebral arteries. You can see from these pictures. The consideration about surgical approach is for early devascularization, preservation of every single vein as every single vein counts, and no or minimum brain handling, dissection of neurovascular structure, use of endoscope whenever required, and basal repair. Of the most common and the earliest approaches was the subfrontal approach, which may be just unifrontal, bifrontal, extended frontobasal, interhemispheric. It may be supraorbital, or it may be pterional, frontolateral, and endonasal. Now, the frontovasal approach is a direct approach. You have the advantage of early devascularization, removal of tumor from the ethmoid and other sinuses, and can achieve Simpson grade 1 excision. Drilling of the bone on the both sides you can do, so you achieve grade 1 excision. The disadvantages are exposure of sinuses, sacrifice of superior anterior part of the sagittal sinus, venous injury could be there, CSF leak could be there, and so leads to infection and meningitis. The pterional approach is the most familiar approach, which every neurosurgeon knows and does. And there's shortening working distance, early opening of basal cistern, so the brain is lax, and you do not handle the brain much, and early devascularization. Contralateral can also be removed if we can cut the fox. Sorry. Can cut the fox, and use of endoscope. Sometimes you can use the endoscope also. It saves times, preserves contralateral. So the advantages are it preserves the contralateral frontal lobe, frontal air sinuses, olfactory tract, superior sagittal, at least of the opposite side, if not the same side sometimes, superior sagittal sinus, and the venous drainage. The endonasal approach is no brain retraction, no brain handling, but the disadvantages are a lot. CSF leak and it may lead to meningitis, which may be very dangerous and devastating, destroying the normal anatomical structures, large tumors, extension in the frontal lobe or sinus, anterior cerebral artery, if it is cuffed, or the cortex, they are contraindicated. Some of the cases I'll show you. This lady was operated in 2006 with bifrontal craniotomy, and then again she came in 2012 with decreased vision in left eye, almost lost with optic atrophy. And because she had more of the tumor in the sinus and hyperostosis, transnasal phase was done and decompression of the optic nerve was done. Again, she presented in 2020 with the right side this time. Left side she had already lost, and the right side diminished vision. This was the tumor in 2006, which was totally excised. You can see that there is nothing you can see in the ethmoid sinus here in the post-operative period. Then she came in 2012, where the tumor mostly in the ethmoid sinus and in the sphenoid sinus reaching, and this was transnasally done. Then this was the post-operative period. This was in 2020. She came again with more of this tumor here with hyperostosis. which was totally excised transcranially with bifrontal craniotomy, because it was done in 2006 also. Another patient presented with the symptoms of headache, vomiting, right hemispheric. This was a large tumor with so much of enhancement. Although cystic component was there, and so we did a bifrontal craniotomy in this, and this turned out to be hemangiopericystoma. So I'll not go into the detail. What has happened? Just a minute. And this was the post-op. You can see the other side, total excision was seen. This was another patient with uniformly dense enhancement and a bifrontal craniotomy. This female patient with these symptoms, with the frontal lateral approach, she was operated in a large tumor. You can see the post-operative these. Another patient with loss of smell, headache, vomiting, again frontolateral approach, you can see. And when you operate with this approach, frontolateral or sometimes trigeminal approach, you are so familiar with this, with no brain handling. You see this, there's nothing. This is another patient with unilateral olfactory groove meningioma, and this was operated by, I think, supraorbital approach, and the total excision was achieved. This is a doctor, and he was operated by trigeminal approach, and the total excision was achieved. Now the thing is, like any other tumor, you initially, this was the frontolateral approach, and initially you need to just debulk like any other tumor, devascularize, and gradually separate it from the brain and take it into the operative field. And then you need to preserve all the neurovascular structures, and then you cut the basal dura and drill the bone, remove if there is any extension in the sinuses.
Hemant, you have to conclude now.
I have 55 seconds left. This is, let me take out the tumor first. So that is how it is. And then you are coagulating and then cutting the dura in the base. You can see. And small bits also being cut. So we conclude that the trigeminal approach for the olfactory group meningioma is atraumatic with preservation of all anatomical structure and has least complications. We invite you for the NeuroVascon meeting to this year from 27 to 29 September at Jaipur. Thank you very much.
Thanks, Hemant, for keeping up, finishing in time. I am sure there will be a lot of discussion. We have two endoscopic surgeons sitting there as moderators, and also interhemispheric approach of heart has to give comment. So we'll have discussion at the end. May I call my co-chair, Tripathi, to talk on unplaque meningioma, surgical decision making. 9 + 1 minute.
Good morning, Chairperson, my friend, Professor Suresh Nair, the President of IMS. And good morning, everyone. Thank you, Atul, Abida, and wonderful team for organizing this. And welcome all our Japanese faculty to this wonderful meeting. We really heard this song yesterday. We were thrilled. We'd like to hear some more this evening. So I thought I'll speak something different, because this is a different meeting, especially when Atul is at the helm of the meeting. And this is a very different entity. I'm sure all of us have encountered. Fortunately, this is less frequent because the only 2.5% of meningiomas are on plaque. You call it on plaque, N plaque. I'll call it MEP. And predominantly in females, almost 6 times more common in females. And some series, they present 100% female patients. Typical location, as we know, is spinoorbital or sphenoid wing. They're different from the standard sphenoid wing meningiomas. Convexity is rare. And many times on investigation, on CT MRI, this is differential diagnosis, meningeal sarcoidosis, osteomas, tuberculomas, fibrous dysplasias, so many other things that are confused. So today I will talk only very specific because of the time, convexity MEPs, which are again very uncommon amongst all MEPs. That the correct diagnosis is different. Now, only thing is compared to the sphenoid wing involvement, this is slightly easier accessible. The total resection is difficult and risky because you don't get that arachnoid plane. In some series, hardly 1/3 of the cases were totally excised. So there is a chance of recurrence always, and of course, radiation. Now, the dural attachments, very typical of MEPs or unplaqued meningiomas, attachments are extensive and you don't know where to stop. It is danger outside because it crosses the bone, goes to the below the scalp, and you can sometimes feel scalp swelling, and also goes into the brain, but breaches the arachnoid at many places. So we don't know whether to remove that part of tumor or leave it behind. And you know that if you leave it behind, you can have a recurrence, and if you remove, there will be damage. The standard dilemma of surgeons, especially neurosurgeons. But unfortunately, or fortunately, they are grade 1. But they do not behave as grade 1. I'll show you some example. There's some references. Now, I already said the decision making is difficult, whether you want to remove or leave behind. Now, sphenoid wings, again, many of these cases are conservatively treated unless the patient is going blind or multiple cranial nerve involvement and a mass effect. But motors, especially the ones involving the motor strip, there is no alternative. You have to go in and remove the tumor. And subtotal excision, of course, a problem of recurrence. Some examples of convexity. Now, some meningiomas are globular variety and some are flat variety. And some, they don't know boundaries. They can cross sinuses, they can go to the other side of the midline. And of course, when you have a sphenoid wing, involves orbit, temporal side, and also the extends further. Now, this is one example. I will show you better pictures in my next picture. But what I want to show you here is they look globular. They look like a normal meningioma. They're bone involvement. And this gentleman we operated, at surgery, we had to discard the bone. Now, that is one dilemma, what you do. You discard the bone, do you do a primary cranioplasty, or you wait? Because this tumor was invading the sinus and we left behind. Fortunately, the quality of life thing is very important here. And I want to run the video if I can. And you can see that he's very comfortable back home in a month's time with a surgical cap showing that he had a bone was discarded. And we were going to do a cranioplasty very soon. And he's from Mizoram. He gone back home and lived happily ever after, but not ever after. Unfortunately, just before I came to Mumbai, his daughter informed that he's got a recurrence because he's got a leg weakness. So this is this MRI preoperative. You see the extensive involvement of the bone. There's a scalp swelling. And this is the typical convexity unplaqued meningioma. And although they are benign WHO-wise, grade 1, they are really not benign for the patient. So this is the immediate post-op, and this is now, the day before I came here last week. So there is a recurrence, and he's got a leg weakness. Now, what do we do now? I gave steroids. I want him to come back and do the surgery. The only thing is, he's 75. So we have other things to consider. So my point of emphasis today is, of course, there are trials of chemotherapy. Of course, radiation is very important in these kind of cases. And Manjul is there. I probably give us some more information on that. Molecular therapies are ongoing. AKT, AKT1, mTOR inhibitors, like these medications are they're experimental, but how much they can control the tumor recurrences? We have to decide. We had a very small series, and from the small series, we got only 21 MEPs. Out of that, only 6 were convexity. I couldn't excise all of them. Only 2 had total excision and 4 had subtotal excisions. And then there were 2 recurrences, and we were giving radiation, waiting and giving radiation, but substantial residuals, we gave radiation upfront. And there was severe neurological deficit. I remember this gentleman who is an air traffic controller in Calcutta, and he had extensive unplaque meningioma on the left side of his, involving almost the whole hemisphere. So it took me 3-4 hours to remove the tumor and the bone and everything. And then he had a significant deficit on the other side, unfortunately, and he had to stop working. So these are the decisions that we have to make. And the conclusion is surgery for MEP is a challenge. Total excision is risky. They're mostly grade 1 tumors in classification, but they behave differently, and because of the nature. And the recurrence is quite common. Subtotal resection may be a better alternative, and quality of life is an important objective in benign pathology. I'm sure all of us understand it, all of us practice it, but sometimes patients do suffer because of various reasons. So I think I've conserved time, Suresh. Thank you very much for listening to me, and I'll conserve 3 minutes for my next speaker.
Tripathi, for finishing in time. It's so great. And the next speaker is not there, but I have just done, if Professor Ohata can give the talk on tuberculum meningioma, he is giving. Okay, so he will be talking on tuberculum meningioma, I know. But before that, we have the next speaker, Sumit Sinha from Delhi, Max Hospital. He is going to talk on his favorite topic, surgical minimalism in skull base. Sumit, 9 + 1 minute.
3 minutes for the last speaker. Yes, sarak jayega. Okay. Yes. Okay. Thank you so much to the organizing committee, and I'm here again to share my experience of this one of my favorites, as Professor Nair told. I would not like to go into the details of other straight away delving into the topic. I have no financial disclosures. So the keyhole. So the keyhole, I would say this is not about the size, as I always used to say. This is about the philosophy of the surgical approach. It is no doubt this is an epitome of ultra micro neurosurgery, which is in the present era, the most important thing that one as a beginner neurosurgeon should learn about. The intricacies of microneurosurgery, and this is what the keyhole is, the ultimate aspect of it. So I would like you to take you through the subsequent slides and of various keyhole approaches that I use in my surgical practice, and out of which the most formidable ones is for the petroclival meningioma as well. Keyhole approaches for these formidable lesions as well, which may be subtemporal approaches or retroseg approaches, expanded retroseg approaches, and the rationale of these keyhole and the other keyhole approaches, we all know about it, because these are minimally invasive procedures, and they are less time consuming in doing the bony work, better cosmesis, of course, and less muscle dissection, and wound healing and post-op stays better. One of the examples of this petroclival meningioma, after the surgery, this is the immediate post-op CT scan, and this is the patient in the post-op follow-up. After 2 months, he had preoperative fifth nerve symptoms, which recovered completely at 6 months. And this is the patient after 6 months in my office in the OPD. So this is complete tumor removal, and patient is doing well in the follow-up. Another petroclival meningioma operated through the keyhole. The angle of attack is this, as you can see, subtemporal approach. This is the skin incision, and this is the size of the craniotomy. So you have to keep certain principles in mind while doing a craniotomy through a keyhole approach, like NeuroNav is a must. And once you open the dura, you have to float through the arachnoids. You have to drain the CSF. You have to be patient for some time, maybe 5 minutes, 8 minutes. And once the CSF is drained, then your job becomes easy throughout the surgical procedure. This is the post-op CT scan, immediate post-op, and this is how and the intact ocular movements of this patient after the excision of the tumor. I hope I do have time for a short video clip of this keyhole approach. This is large tumor, which is taken out through the keyhole, the bony landmarks of the keyhole, and the angle of attack is again subtemporal. Rest of all these steps are the same as we would do in a conventional Kawase approach, but the size of the craniotomy is, this is the drilling of the Kawase rhomboid and opening the dura, attacking the tumor. This is the tumor there. Decompression, devascularization, and dissection. These are the 3 Ds of any meningioma surgery, taking care of the pristine arachnoid, and sharp dissection here of the tumor from the neurovascular structures, and taking care of sweeping the arachnoid away from the tumor tissue. This is the posterior cerebral artery over there. You see, this is the brainstem beneath the tumor, decompressing the tumor more, and this is the PCA. Remember, take care of these small teeny perforators, which can take the life of the patient and make the post-op harrowing. Decompressing the tumor, basilar artery, and lifting the tumor, rolling the tumor away. This is retrogas 5th. And this is the complete tumor removal at the end of the surgery. And during the surgery as well, you take inside the endoscope, which is a beautiful tool. We all do have it. And what you can do is you can inspect and see any residual of the tumor, the immediate post of CT scan. And this is after the surgical procedure, intact patient. Keyhole retroseg approach, yes, you can use the endoscope for your various advantages in during the surgery, drilling the internal acoustic meatus in acoustic tumor, looking backwards into the brainstem when you have 30 degrees, 45-degree angled telescope to remove the tumor from the blind areas of the straight light of the microscope. So removing the tumor from the Meckel's cave, as you see in here, and visualize the supratentorial structures after removal of the tumor tissue. So this is how we take advantage of this acoustic neuroma surgery through a keyhole retroseg approach. You see, this is the follow-up MRI after 1 year, and intact hearing, SDS 60% after the tumor removal, and patient is doing fine. Happy facial nerve. With this keyhole approach also, I mean, nothing is compromised, believe me, and if you take care of, this is especially for the young neurosurgeons sitting out back there, if you take care of certain principles which I just enumerated, you have to realize the potential of this keyhole approach. Petroclival meningioma, another one done through the keyhole retrosigmoid approach. The position of the patient is a must, and the neuronav helps in locating the keyhole approach. And intact patient after the surgery, intact lower cranial nerves, intact external ocular movements, and this is during the just immediately after the surgery. Expanded keyhole approaches, expanded retroseg approaches. I want to show you a short clip. This is one of the petroclival meningiomas I did through the keyhole retroseg approach, and again, it is sailing through the arachnoids. The entire keyhole surgery, or any surgery as a matter of fact, the skull-based surgery is through the arachnoidal planes. And this is what I do, cut the tentorium in order to have an expanded retroseg approach. And this is all the tumor is there. Once I cut the tentorium, you get a wide window. And we all know this is expanded retroseg approach. And then the usual dissection of the tumor tissue from the brainstem, gentle dissection and decompression. And this is what the dissection of the tumor tissue from the neurovascular structure. The sharp dissection is being done. Superior cerebellar artery over there, taking care of these structures is of paramount importance. And taking the endoscope, you see the 6th nerve going through the duralis canal, and complete tumor excision of the tumor tissue. Supraorbital keyhole, another beautiful approach. This planum is sphenoidal meningioma done through the SOCA approach, and this is the post-op scan. No trace of tumor tissue. And this is one beautiful girl who had her marriage about 3 weeks after the surgery. She was very, very concerned about the cosmesis. And you see, this is the cosmesis which we can do with a keyhole approach. The scar is barely seen immediately after the surgery even. Medial sphenoid wing meningiomas, all these skull-based meningiomas or tumors, in fact, they are accessible through the keyhole approach. This was one such tumor, immediate post-op CT scan, complete tumor removal, and this is the scar this was done through the keyhole pterygium craniotomy. And just to show you there is no dearth of space. Once you go inside and follow the principles of the keyhole approach, the rest of these steps are absolutely the same as you do while you do on a conventional approach, separating the tumor from the optic nerve and the carotid artery and following the principles of all the principles of microneurosurgery. And this is how you do it. I'm afraid may not have time to show the entire clip, but I want to show you this focotentorial meningioma, which was done through the Poppins approach. And this was done through a small 4 by 2 centimeter craniotomy in the intrahemispheric, posterior intrahemispheric approach. This is the tumor tissue. This is the great veins over there, sharp dissection, water jet dissection, all the principles of microneurosurgery. And these are small veins and arteries. There you have to be taken care of, absolute paramount importance of these arteries and veins in order to have a beautiful outcome after the surgical procedure. And you can do it with keyhole. Everything is possible. This is what the post-op MRI and CT scan, and this is the patient after the surgery in the follow-up. So I have my experience and I have my failures, I have my complications while learning this approach. I've been doing this approach for about now maybe decade and a half, close to 1,000 cases, because this is the data, slightly old data, and still learning. So the take-home message is to the younger neurosurgeon sitting up back there is, yes, keyhole requires special skills. It's not a new perspective. It's been there in a while. It requires working in a narrow corridor. It requires a thorough knowledge of the anatomy. They are absolute important things to be taken care of during this keyhole approach. It is a lesser morbid, better option. Absolutely no need for vast, immense skull-based bony work to do for these lesions. We can do it quite well with a keyhole approach. It is maximally curative approach. And of course, cadaver learning is must in order to practice this approach, and endoscope adds to the effectiveness. Well, thank you so much. And I do invite you next year for a meeting, World Neurosciences Conclave in Delhi. That is from 20th to 23rd March. Please do come, and I will disseminate the information to you on your email IDs. Thank you so much.
Thank you, Sumit, finishing in time. And my friend, Professor Ohata, is preparing his talk and is ready. And he has been kind enough to replace the speaker, Rupesh, who was supposed to be talking on tuberculum meningioma. But I know Professor Ohata has a large series. So he will talk on about tuberculum meningioma. Thank you very much, Professor Ohata, for in last minute agreeing to present on tuberculum meningioma. Stage is yours. You get 2 minutes extra for that. Yeah.
Thank you very much for the sudden. I love India because it's and what happened in India is unpredictable. So I'm so happy to have a chance to talk about my favorite topics. So 10 days ago, I gave a talk in the same topics in Oxford University. My time is 45 minutes. So this time, 10 minutes, right? 10 minutes. So I want to reduce my slide. So this is my favorite topic, spectrum cell meningioma. This is only one skull-based tumor where we can remove tumor totally. This is a good tumor. So we must do tumor total resection. Is very important. So this is a schematic drawing of this particular pathology. Tumor origin between two optic nerve, and sometimes anteriorly, sometimes posteriorly, and it's not a symmetrical tumor. It's shift to some side. This is a schematic drawing where tumor origin, the anterior side is close to the same to the pronosphenodal meningioma. And this is real tuberculum cellular meningioma, tumor origin between two optic nerve. If the tumor origin is close to the jungle cellar, this is a total different tumor. If we access the terionaro or subfrontal approach, no space to enter to this space. So this is schematic drawing. If the tumor grow, it start to involve the ACOM complex and the perforators. And sometimes, of course, as you know, tumor embedding to the both optic canal. So the relation of the tumor, you must understand this schematic drawing before the operation. This is one of the difficult one. In this case, of course, transsphenoid endoscopic approach may be better, could be selected. I want to show one case. This is a small one, but small one is not easy. In this case, I select the front lateral approach. In this case, I surprised because the tumor, optic nerve located between tumor and the surgeon. In this case, I'm happy because the tumor is very soft. I remove the optic canal, and the tumor is very fast. So I remove the tumor totally. If the tumor is soft, we can remove this kind of operation. So unilateral approach is good if the tumor is small and soft. So this is the final. I remove the tumor totally. And next, I want to show this is a midline tumor. So I favor to use bifrontal approach. This is too much exposure for all minimally invasive scalp-based surgeon. This is but very important to keep the olfaction. Olfaction is important. If we don't have we lost olfaction, we cannot enjoy the Indian cook. You know, this is why we subfrontal approach sometimes cause loss of olfaction, anosmia after the operation, because frontal lobe sink, not a sink, and it's cut to the both olfactory nerve and patient loss olfaction. So the purpose of why I perform the bifrontal approach is to dissect contralateral olfactory nerve to triangle. We must keep entirely intact the contralateral olfactory nerve, but we can cut the ipsilateral olfactory nerve, because if you use a subfrontal approach, olfactory nerve located between tumor and optic nerve. When we unroof the optic canal, olfactory nerve is on the way to the durig. We must cut, and then we can widely open the both medial side of optic nerve. So the very important, this is the midline tumor. Midline tumor should be accessed along the midline. And then we can safely preserve the optic nerve and the pituitary gland and the olfactory nerve. This is a relatively small one, not large. In this case, I dissect the olfactory nerve, perfect preservation, and I unroofing the ipsilateral olfactory optic canal, and I start to remove the tumor. This is a right side optic nerve. This is a contralateral olfactory nerve, optic nerve here, and this is very safe. It is a midline approach. We can observe the entire part of the interface between tumor and the optic canal, and we can preserve the entire part of the tumor. This is optic nerve tumor embedding, crossing the optic nerve. We can remove the tumor through the lateral side, mobilizing the optic nerve. This is the inferior part of the tumor. We can remove entire part of the tumor because we have wide space. This is the right side optic nerve, mobilized and tumor dissection completed. This is the unroofing of the contralateral optic nerve. Anyway, we can preserve the entire function of the patient. This is a large one involving the ACOM complex. I guess most of the participants agree to use a bifrontal interhemispheric approach in this case. This is a tumor. So this is an interhemispheric approach tumor because tumor involving the both complex involving the aids and perforators. This is right frontal lobe, left frontal lobe, widely exposed, and we can perform the internal bulking first, and entire tumor resection is from lateral side to midline. This is a contralateral optic canal. We can safely open the optic canal. And then this is ACOM compress, optical chiasm here. It's right A1, right A2, left A2. Finally, we can reduce the size of tumor as much as possible. And we leave the small piece like this, and the tumor now, let me say 20 years passed after this operation, and no recurrence at all. Well, tumor is completely devascularized, all structure kept intact. So this is outcome. I want to skip the, now this is a long-term outcome of visual function. If we can, in this approach, we can preserve the all perforators, optic nerve function improved even after 1 year post-operation. It's continued to improve. This is my result. Present as my improved rate of the visual function is the best. Unchanged visual function unchanged is 17.6%, and the deterioration found in 0 case, zero. This is the best. I intentionally published this book because public paper, because I know era of endovascular technique is coming. This is a best outcome of open craniotomy. If regardless the size of the tumor, this is my outcome. You select, if you use endoscope, you select the case, you use endoscope, just a small case. If the tumor involved in the ACOM complex, you never use the endoscope. Outcome is better, of course, in the endoscopic surgery. So this is if endoscopic surgeon overcome this outcome, including entire tumor, entire tuberculosis meningioma, I totally agree to endoscopic neurosurgeon. Thank you very much.
Thank you. Thank you very much. And now it is the turn of the discussants to come up. We will go down and let all the speakers stay there in the front seat so that they take over. Please, Amano and Avadesh, please come and take over. We have two endoscopic surgeons. May call Atul also, please.
Good morning. Our discussants are Dr. Avdesh Jaiswal and Dr. Kosaku Amano, and all the speakers are here. The house is open for the discussion. For any speaker, you can just name the speaker and then your question over it.
So I should turn question to the
Yeah, please.
presentation. Okay, so I want to ask the Dr. Sumit. You do the keyhole surgery using a microscope, and at the end of surgery, you use endoscope. And how about keyhole fully endoscopic surgery? Because I mean, I'm a pituitary neurosurgeon, but in Japan, some doctor like Goto, he used a fully endoscope in keyhole surgery to the posterior fossa.
Hello. So, well, I mean, there are various types of assistance with an endoscope or totally independent endoscopic keyhole surgeries. So what I do is mostly in these skull-based tumor, which are massive and formidable tumors like petroclavels, I take inside the endoscope quite frequently during the surgery and definitely at the end of the surgical procedure after detection in order to see something attached to the clivochondral junction or my predominant endoscopic use in these type of cell-based tumors is to verify my microscopic findings, mostly. Sometimes I would say about 30–40% of the times, I do also do the dissection with the endoscope. Now, why I say sometimes is because there is a reason to it. I don't have an endoscope holder, and also I don't have a good endoscopic assistance to, someone to hold the endoscope for me. So I keep the endoscope in one hand and do the other thing with the suction. So like, for example, taking out the tumor tissue from the internal acoustic meatus, which I showed in my video, was done by me only. So these are some of the disadvantages of working in like a corporate sector where you don't have a good assistance, or if there is good one, it is difficult to keep him up with you for long, actually. So this is what I do in my practice. But yes, definitely, you were very right, like Dr. Goto does the endoscopic, fully endoscopic, and it is very much doable, provided you have the technology and know-how for that.
Thank you. Actually, well, we need a holder and a good assistance. Yeah. Can I ask Dr. Ohata? You recommend you compare the endoscopic surgery for the tuberculum zero meningioma. And recently, of course, I do the endoscope TSS and open surgery. And some in Japan, endoscopic TSS surgery only do that. They say aggressive, but that's so invasive. I think recent tuberculum zero meningioma, some case, you said caudal side of meningioma, it's so difficult. And recently, I often use the combined surgery, even for the tuberculum meningioma, and we have a good result. What do you think about combined surgery for the tuberculum zero meningioma?
Yeah, it's a depend on the case, of course. And the combined spouse, the goal is minimize the invasiveness of the patient. If the case selection is good, so surgery may be good. But case of meningioma, its tumor has spreading it's like Mount Fuji. There's a sleeve, and we cannot predict the margin of the tumor. It's very difficult. I published the paper. If we can predict the relation of the tumor to the optic nerve and the internal carotid artery, accurate rate is just 60%. We have a double-blind study, and we asked the radiologists preoperative study and compared with operative study, and the accuracy is just 60%. So it's so difficult to appropriate approach selection. This is my comment. So that is why I prefer to use, if we have a confusion because the tumor morphological feature, we should select the transcranial approach. Of course, endoscopic small craniotomy is good enough in selected case.
My question, Dr. Ohata, do you ever use endonasal endoscopic approach for tuberculum meningioma?
Which meningioma?
Have you ever tried endonasal endoscopic approach for tuberculum meningioma?
Tuberculum meningioma?
Yeah.
Yeah, in some case it's good, but you must carefully analyze the tumor morphological feature relating to the optic nerve. If the tumor grow above the optic nerve, you cannot reach that part. Can you understand? Partial resection is good for the endoscopic endonasal approach.
Yes, we at our center also we are used to do endonasal endoscopic approach for tuberculum meningioma a few years back, but now we have completely switched over to transcranial approach. Many times we use mini-terminal or supraorbital keyhole approach for all these cases, and it avoids unnecessary handling and a lot of making flap and everything, drilling bone through the nose. So the results are very good with the tuberculum meningioma for this supraorbital keyhole approach, or mini-terminal, or sometimes crenal and bifrontal approach also, depending on the size of tumor and encasement of the vessels.
Yeah, I have a comment to make. See, the endoscope at present is a very incomplete tool. This is because the endoscope is not 3D. The endoscope, the present 3D endoscope, the tip cam, and maybe a few other companies, it's not true 3D. We are using Escolab's 10mm laparoscope, which is true 3D, but it's too big. But for cranial assist and sometimes to inspect things after you've done the surgery, it's a fantastic tool. The second thing that is not around with the endoscope is that somebody has to hold it. And it it takes off the dynamics. So if you have a holder, the present holders are not good. So we designed a back drivable cobot, which is what is required actually, so that it has to become like a microscope. So unless these two things are done, pure endoscopic surgery is always a disadvantage when you compare it to exoscope or microscope. And I'm sure there is a time when this will come, when endoscopes will become shorter, more three-dimensional, true three-dimensional, AI assistance, and with imaging and things like that. And then it will be, I believe, it will replace the microscope completely.
I'm sorry I didn't participate in the entire discussion, but I heard Dr. Ohata's lecture.
Michael,
I heard Ohata's lecture and I heard the discussion on use of endoscopy. And I also know in front of me some masters of endoscopy are sitting. You agree, Manjul? I will comment on tuberculum meningomas. Tuberculum meningiomas is completely a transcranial operation in my view. Doing transnasal surgery for tuberculum meningioma is not such a great operation. I know all the endoscopic surgeons will disagree with this. Avdesh is getting excited, but I can say tuberculum on the basis of Manjul, largest experience in the world on tuberculum meningioma of more than 350 cases. Tuberculum meningioma should be removed by unilateral subfrontal approach. There is no need to do any orbital or any lateral or basal or sphenoid wing resection. Expose the optic nerve, debug the tumor, identify the anterior cerebral artery, identify and save the perforators of anterior cerebral artery, which is the most critical part in this operation. In tuberculum meningioma, if you ask me what is the danger, danger is damage to the perforator of anterior cerebral artery. And that perforator can be saved by transcranial route first in the operation. Anterior cerebral identify, save the anterior perforators, and then dissect the tumor. Any kind of exposure from the nose will get to the anterior cerebral artery much later in the operation. And you can, if you damage one perforator, the entire operation is finished. So I am absolutely convinced that doing anything from the nose for tuberculum meningioma is not a good option. This is my view. I don't, here I am not using any aggressive words because, I am little bit defensive.
Sir, I perfectly agree with you. We have also changed our strategy and now we do almost every tuberculum meningioma with transcranial approach. Maybe using endoscope may not be. But one thing I would like, in addition to what Dr. Aip has told, the endoscope, if you use in transcranial cases, it takes 4 millimeter your space in the operative corridor, which reduces your freedom of movement if you do not use endoscope. So for meningioma surgery of intracranial fossa meningioma using transcranial approach, I think microscope is the best.
So already discussed about this, but does it really means even in a single case it is indicated the transnasal, as Professor Ohata said, in particular tuberculum meningioma when the optic nerve is anatomically slightly above that, then you can go transnasal. But as you said that with your experience, you have switched back to turinal. So even in a single case, is it indicated, Professor Ohata? The transnasal approach for tuberculum meningioma, even in a single case, is it indicated or all cases to be done from transcranially.
Many type of the traumatic cellular meningioma. As I said in my talk, first part of talk, I showed some tumor origin from the diagonal cella, not tuberculum cella. In case of diagonal cella meningioma, so transperineal approach is good in some case. Because if the optic canal is prefix type, and there's no space to enter to the tumor through the transcranial approach, endonasal approach is better. This is my, so depend on the shape and origin, we must select the appropriate approach. This is my opinion.
My opinion is that in my case, 90% is a transcranial. But recently I used the combined because transnasal at first devascularize the tumor. So, and we can observe from upward and downward both. So very safe, feel so relaxed. So recently I often use a combined surgery. Of course, large one. Small one is only TSS or transcranial. But in my case, more than 90% is transcranial, as Dr. Goel said. Yeah. So if someone who can do the transnasal neurosurgeon, only the 1 hour or 2 hour open the dura and revascularize. That procedure make it easy to revascularize and detached and no bleeding. So I recommend.
I have, in my view, tuberculum celli meningiomas are never heavily vascular tumors. Never. They will not be hugely vascular tumors. Maybe here and there. I don't think one has to worry about vascularity in tuberculum celli meningioma. They are not vascular at all. If at all, they may be firm sometimes. If at all, they may be calcified sometimes. If at all, they may be ossified sometimes. But and they may be encasing the vessels, but they are never heavily vascular tumors. Has anybody seen heavily vascular, like bleeding control, like glomus jugular tumor or this kind? And never. These tumors are not vascular at all, never. So worrying about vascularity and devascularizing. For devascularization, you're opening the nose, you're removing the entire base of the skull, you're subjecting the patient to the risk of CSF leak, you're and you're prolonging the operation for 2 or 3 or 4 hours unnecessarily for devascularizing a avascular tumor. Many of these tumors are very soft, like what Ohata showed, that tumor, absolutely soft tumor. 50 or 70% of tuberculum celli meningiomas are soft tumors. So devascularization is not the answer. And also the other argument in favor of endonasal is that you are doing Simpson Gray, you are removing the site of origin. Many of the tuberculum celli meningioma have very wide attachment to, like a carpet in the tuberculum celli, in the region of planum sphenoidal, in the region of diaphragm celli. It is like a carpet, and you cannot completely remove these tumors. In any case, I think time is going too fast. We have to move now, Manjul.
Thank you, chairpersons, the speakers, and the discussants. It has been a beautiful early morning session. And now we are going to the next session, from anterior skull base to going to the posterior skull base. I think the whole of the problem in the world is going to the no man's lands with the crowded neurovascular neighborhood, and in the glory to claim them, right from the Middle East to the posterior cranial fossa. So the first speaker today is esteemed. Yeah. Sorry. The chairpersons for this session are Dr. Vikram Karmakar, Dr. Vincent, Dr. Hemant Bhatia, and the discussants are Dr. Hiroyuki Goto. And I request Professor Goel sir, as Dr. Rupesh couldn't come for the today. Thank you, sir.
So we start with the first speaker, Professor Suresh Nair. He doesn't require any introduction. And so far we are maintaining time. So you have 9 + 1 minute.
Thank you.
Professor Suresh.
Thank you again, Professor Goel, for this outstanding meeting and bringing meningioma meeting to this wonderful week of neurosurgery feast and also Japanese. So I will briefly tell about this. These things were told by Narasimha Rao yesterday. All of us know the various zones, how to approach, what are petroclival meningiomas. I will skip all. And this is what the classical approach of Professor Kawase to upper petroclival region. And this is our pet friend, again a friend of Indian neurosurgeon, Professor Kawase. And he has described various types of meningioma, petroclival, and I will just briefly tell the anatomy of this Kawase approach. So here you see a spoon-shaped depression here. This is the trigeminal impression. For you to understand Kawase approach, you should know this anatomy of Meckel's cave. This is a dural pouch. This is a Meckel's cave, which is the dura. This dura of the Meckel's cave doesn't belong to middle fossa. It is in the it is coming from the posterior fossa, but it is between two layers of dura of the middle fossa, dura propria and the periosteal dura. So this is the Meckel's cave. It houses the trigeminal ganglion. Distal to the Meckel's cave, this dura propria of the posterior fossa, which is the dura of the Meckel's cave, it extends over the divisions. That's the epineurium, over the division. So what is this interdural approach? This is the dura propria, this black one is the dura propria of the middle fossa. Here you see the division. So you have the epineurium here. So you have to come between this black and you have to come between this yellow. That is this interdural approach. How do you do that? You can come either from the ovale, rotundum or superior orbital fissure, elevate the dura, drill this bone. So if you drill this bone, you can cut this periosteodural fold. If you cut this periosteodural fold, you can elevate and come into this plane. This is the interdural plane. Interdural plane, dura propria, the middle fossa, and the epineurium over the divisions of the trigeminal nerve. Expose, you can expose the Kawase's quadrilateral position, incision, and middle fossa exposure up to the floor, retract, and then identify the greater superficial petrocell nerve. And this 5 is the Kawase's quadrilateral. This is the LI of the internal auditory canal, GSPN. I will show one video. So you take out that bone, expose the posterior fossa dura. In short, this one is that you reflect the dura, identifying, protecting the GSPN, and then expose Kawase's quadrilateral, take out that bone, and then open the middle fossa dura parallel to the superior petrocell sinus, and make 2 cuts below and above the superior petrocell sinus, ligate the sinus, and then 5th nerve will look at you, work above and behind the 5th nerve. And this is the checklist. I will show one index case before I finish. And this is a lady presented to us of 3-year duration, a sizable upper petroclival meningioma. This is the post-op picture we have removed. And this is the incision. You should have all these things. And I will show one video, which quickly I will run through. And so this is, we are exposing the middle fossa epidurally. Again, you stimulate for GSP and sharp dissection of the periosteal dura. And you can peel off this middle fossa dura like that. You can peel off the middle fossa dura, expose. This is just identifying internal carotid artery below the GSPN. I'll run it little more faster because I don't want to. This is again stimulating for GSPN. And here again, we are identifying the internal carotid artery under the GSPN. In the event, this is not required actually for small meningiomas, large meningiomas. This is, you can have control over carotid little more faster. So you can see, you can Doppler and see. So this is the internal auditory canal. And this is the internal auditory canal. This is Kawase's quadrilateral. Now we stimulate for 7th nerve. This is monitoring to see 7th nerve. And then we have to drill out this quadrilateral bone. So once we drill out this quadrilateral bone, we are exposing the posterior fossa dura. And then after that, say we have to ligate the superior petrosal sinus. So we make two incisions, one above, one below the superior petrosal sinus. You can see the tendorium. You retract this temporal lobe, ligate this superior petrosal sinus. This is retracting the temporal lobe, and then we ligate the superior petrosal sinus. The structure which looks at you is the fifth nerve. So this is a tendorium. Next step is ligating with clips or suture, and then the structure which looks at you is fifth nerve. This is the fifth nerve here. So work above and below the fifth nerve. And as Professor Goyal was telling, many a time these tumors are soft, and you use a accuser, and you open the porous also. You work behind, below, behind, and take the tumor out in toto. This is in short the middle fossa approach, Kavase's approach to Peter Clivel. This is a poster picture. Various tumors removed by Kawase approach. This is one of the best approach for upper Peter Clivel tumors. So many advantages are there. So again, say large tumors. So sometimes we use both anterior and posterior petrosectomy, and tumors with extension to very much high up, we come from anterior lateral. These are some of the relative contraindications when these abnormal veins are there, sphenopetrosal vein or sphenobasal vein. And correctly, my friend Manas has come inside, so he has popularized this anterior petrosectomy through a subdural approach, and he will be talking about that. And this is described from Kavase's group, how to manage in the event of abnormal vein. So this is the series at Chitra Tirunal Institute. So we used to do all this petrosal approach before. After that, we moved to this simple retrosigmoid approach. But for upper petroclival meningioma, this is an excellent approach, Kawase approach, and one should try that approach. And these are some of the publications. And I have finished well ahead of time. Thank you very much again, my dear friend Atul Goyal.
Thank you, Dr. Nair. May I call upon Dr. Kentaro Watanabe to speak on the anatomical surgery of the parajugular foramen tumors, please.
Oh, thank you very much. So this is my second presentation. So I'm talking about the anatomical surgery of jugular foramen tumors. So as I'm from Tokyo, so Tokyo is close to my hospital. So it's for us, and then the anatomy is the most strongest weapon to fight against the scurvy surgery. So everybody knows it. So, and then the anatomy of jugular foramen is the most complicated place. Albert Lawton, he always mentioned about that. This anatomy is very complicated because of the nerves, vein, and the arteries, and a lot of structures concentrated in a very small space. So, and also the lower cranial nerve is very fragile. So we have to be careful to preserve the functions. So jugular foramen tumors, it's sometimes a little bit difficult. So it's in intrajugular lesion, so here, as you can see that the 9, 10, 11, but you cannot see the inside of the jugular foramen, inside of foramen. When you see the inside of the foramen, so there is a ganglions and also a lot of nerves and then like that. Also, the small nerves is going to the ear and it's a little bit complicated. So let's go to see the anatomy of the jugular foramen. So if you're exposed to the jugular foramen, we need to remove the bone completely. Otherwise, we cannot see it because of the tumors. The foramen is located the medial side of the sigmoid sinus. So at first, the mastoidectomy was done, and after that, at the retrosig approach, they have done, and also that they remove the condyle. So then, so exposing the condyle cell vein, and then go into the hypoglossal canal. Then, and after that, so we can have access to the jugular foramen. So first, we need to remove retract the sigmoid sinus and the jugular vein and the jugular valve. So as there's a strong structures around the foramens, so we can cut the fibers and then they make the jugular bulb is make it free, and then access to the foramen. So then after removing opening the sinus, you can see it. Here, there's a inferior petrosal sinus. It's around in between the 9 and 10. And then here, there's a intradural region, foraminal segment, and then extradural regions. And then these nerves is anastomosis each other. So it's all very complicated. And also it's impossible to see the cranial in clinical cases. Otherwise, it's a little bit difficult to understand it. So pathology is, we can divide the extradural lesions and intradural lesions. So you know. And then to access to the jugular foramen, there are several approaches: retrosig, bilateral, transcondylar, transmastoid, or anterolateral approach, or transnasal approach. But I believe that there is still remain the space of the jugular foramen surgery is for the microscopic surgery. So depend on the craniotomy size, we can see we can use several skin incisions, C-shape, hockey stick, or big C, or L-shape, or several. So like that. So it's the most useful approach for the for the jugular foramen tumors. So like a juxtacondylar approaches. So Bernard George described these approaches. This bone is very important to remove it, because the jugular foramen is located here. So we need the bones around here. So it's a tumor. If the tumor is located like this, and then there are nerves, we cannot predict the nerves location before the surgery, because nerve is always very thin. So it's very difficult to understand and where there is the nerves. So it's sometimes the nerves are dislocated is a very higher portion, or so if the tumor is inside in the jugular foramen, we cannot see the inside of the nerves or the foramina. And also, if the tumors extend more cervical lesions, we cannot. That's a bit difficult also. So sometimes the nerves push away the ventral side by the tumors. So how to preserve the cranial nerve functions? So first, the schwannomas. So you know that the schwannomas originate from the inside of the nerves. So we can. This is a acoustic neuroma case. So I always try to keep the small membranes, thin membranes of the tumors. So these fibers, the capsule, is protect the nerves. So this is one of the way to how to preserve the facial nerve functions. So same as for the jugular foramen, jugular schwannomas also. If the tumors originate from the cisternal segment, so the tumors originate from the one fiber of the small fiber of the jugular, the 9 or 10. So we can keep the small membranes, and then we can preserve the other nerves. And also, if the tumors originate from the extradural ganglion type, so we can remove just only inside of the tumors, and then we keep the capsule with the fibers. So this is the same. So it's the same as like the debulking and the decompression of the nerves, and then keep the membranes and then protect the nerves. This is one of the way to how to preserve the nerves. So this is the case of the jugular foramen schwannomas. So I use the retrosigmoid approach. Here is opening the retrosig keyhole approach, and then exposing identify the tumors around the jugular foramen. Here, there's the nerves. First, the nerves is spread it out by the tumors. So it's a little difficult to identify the location of the nerves. So we have to check the neuromonitoring, and then after that, we can use the small corridor between the nerves, and then the access to the tumor inside the tumors. And then the debulking the tumor precisely, and then try to remove the tumor, and with keeping the capsule of the tumors. Sometimes you can use the sonopet also, and then but after debulking, and keep the membranes. Like here, this is the membrane of the tumors. The capsule is one of the capsule can be protect these nerves. So finally, so I remove the most of tumors, and then here there's a small capsule is remaining of the tumor. So this is a way to to protect the nerves. So the other approach is a bilateral transcondylar approach. So if you need the look up view, so it's like those, we can use the bilateral transcondylar. Maybe so we can use the retrosigma approaches, or it's sometimes we don't know where is the nerves. So it's a bilateral transcondylar approach. So here is the craniotomy, one piece craniotomy was done, and then the condylar, there's condylectomy. It's actually it's not condylectomy, so we can remove the foramen magnum bone, and then until the posterior edge of the condyle. Then and after that, elevate the dura, then make it the dura is flattened. Again, then I can use the look up view to the dura from it. Then the tumor removal with the same manner. So like debulking and then separate the tumor from the capsule, and then keep the nerves. There is also the tumors. If the tumors are embedded in the foraminal segment, so you can use the opening. You can open the jugular foramen and then remove the tumor, and then use the endoscope to remove the foraminal segment. So it's have just only one case of the case nerve dysfunction. So because after removing the tumors remain on the foraminal segment, and I sent to the gamma knife, and then after that gamma knife, the patient has a nerve deficit. So I don't recommend it to using the gamma knives for the foraminal segment. So meningiomas, I will skip it. So as to preserve nerve function, the schwannoma surgery, subtract capsule resection is the most important technique for that. So radio surgery should not use the control the tumor for the jugular foramen pathology. Thank you very much.
Thank you. Thank you, Professor Watanabe. Now we call upon Dr. Manjul Tripathi to create new history and talk on his surgery, a history for jugular paragangliomas.
Thank you, sir. Thank you for this wonderful introduction. I think history doesn't repeat itself. It's the human beings who repeat the history. And then we just listened to a wonderful talk on which there was a beautiful anatomy description, the surgical skills description. Now I'm going to speak on something which I say that for this particular pathology, surgery is practically a history, except for some rare indications. There are only two people who, when they give me a call, I first stand from my seat and then I start the call. One is Dr. Mathuria, second is Dr. Atul Goel. And once in a while, he gave me a call and told me that, Manjul, what is your opinion about the glomus tumor? Because this is really something which creates a trouble to us. He is one person who is very particular about the post-operative outcome and the patient's quality of life. नहीं तो आप अपने में चला दीजिए कोई बात। So this disease, which sometimes becomes a surgeon's nightmare because of its intricate relationship to the surrounding neurovascular structures, its vascularity. I'm so sorry for this. Yeah, okay. So it's surgery, a history for a paraganglioma. And this is in 2022 when I received the first patient with this referral for this cause. These are my disclaimers, and with the personal experience of treating close to around 250 patients of the various paragangliomas at different locations at the skull base. And with so far 6,000 patients of the SRS, I am here in capacity of a microneurosurgeon and gamma knife radiosurgeon. So this disease, with this statistics, I say that this is one disease which can take you out of your comfort zone, because people usually avoid operating over it because it's cruel to the cranial nerves because of its intertwined nature with the surrounding structures. In extreme of the cases, you can have malignant paragangliomas, you can have paragangliomas extending into the intracranial compartment, because usually they have their natural tendency to follow the nerve roots and go into the skull base, petrous bone, and then down. In some cases, you can have multiple paragangliomas. Nowadays, I'm always getting a PET scan to all these patients, and I find that there is 2-3 more paragangliomas in familial cases sitting elsewhere in the body. When I read the humans, it still says that the surgery is the gold standard for this. But I really doubt it, looking at the quality of life of the worldwide series and the best of the hands with the best of the armamentarium and the intraoperative neuromonitoring. And I think that the radiosurgery has already replaced it as a primary treatment modality. And there is no role for EBRT or IMRT unless your tumor is extending deep into the neck. And the dose fractionation, especially with the gamma knife radiosurgery, has certainly pushed the limits of the radiosurgery now. If the patient is old, the tumor is small, it's not creating much problem, observation is definitely a valid option in those cases. But if that is not the case, and the tumor is showing progression over 20% on an yearly basis, or it is of a secretory variety, you need to intervene. When do I offer surgery to these patients? Only a couple of 3 or 4 indications. One, I have a doubt in the diagnosis, which is not ascertained with the best of the radiological evidence. When it is a secretory paraganglioma, when the patient wants to get rid of the tumor as soon as possible, even at the cost of the cranial nerves, or when the radiotherapy has failed to control the growth. And many a times I use multiple modalities, like in this case of around 80 cc paraganglioma, for which I used embolization, surgery, and everything, because the patient was having huge brainstem compression. But if you look at the worldwide series of the surgical management, you find that the morbidity is close to in around 50% patients. And here the morbidity is the lower cranial nerves, and the patient might have to be on tracheostomy tube or Riles tube for the rest of their life. The mortality is close to around 30%, which is significantly high in this age group. This is worldwide series with close to 1,100 patients. And you find that the post-operative complications are nearly twice, and vagus could be preserved only in 11 out of 254 patients, and that can lead to a very bad quality of life of these patients. Compared to this, if you look at different strategies like the subtotal, gross total, and the stereotactic radiosurgery, I would like to bring your attention to the down table, which shows the cranial nerve outcome in the different strategies, and the SRS provides you the best outcome in those ones. If you compare the external beam radiation therapy with the SRS series, the tumor control is very impressive. It's always close to 95% with no deaths, no major complications, and most of the times there is an improvement in the cranial nerve functions. If you talk in the terms of the total tumor control, it is a benign tumor sitting at a remote area of the skull base, and the long-term outcome shows that the tumor control is achieved in 95 to 100% of these patients. I was personally invited for this review by Shihan, who is a pioneer in the radiosurgery. And I found that different dosing regimes and irrespective of the radiosurgery machines, the cranial outcome was achieved, good outcome, and the improvement was achieved in 87% patients with tumor control in 95% patient. This was one series which I contributed to with an overall control in 93% and a 5-year control in 88%. So if you still want to operate, you need to ask yourself whether you are able to bring this patient out of the operation theater in the same or the better status. If yes, then go for the surgery. Otherwise, you have alternative tools. And I asked this question to my colleagues who say that we have an acceptable complication. Then I ask whether your acceptable complication is in sync with the acceptable complication of your patient, because these complications are of the lower cranial nerves. These are not about the hearing outcome. So the paradigm shift has already happened. We started with the maximum possible blood loss, with the preoperative embolization, with certain reduction, and then we have now settled to the primary radiosurgery in these cases worldwide. I did an evaluation for the cases which I treated with the single fraction radiosurgery or the multiple fraction radiosurgery for the large volume tumors. And in those cases, when I need to give the high dose of close to around 25 to 30 gray, I need to be very careful about my surroundings. So we treated these patients with the frame-based radiosurgery in 2 to 3 fractions, many patients in 5 fractions, keeping the surrounding structures like the brain stem, cochlea, because I needed to preserve the hearing in the patients who already had a hearing preservation. I found that the first thing to improve in these patients is actually the headache, which improves by the around of the 3 months. It's a pulsatile headache. It's a pulsatile tinnitus. And compared to the world literature, I go with a slightly higher dose because I treat these patients on the line of the AVMs with a dose of around 23 to 25 grain. The things which gradually improve over the course of time are all the lower cranial nerves. The patient gets better dysphonia. They improve in their dysarthria. The thing which does not improve even in the long term is actually the hemiatrophy of the tongue. Rest, all things improve. You need to be really careful while exposing the surround. Your radiation is placed to your bones there because that may lead to the osteonecrosis, which is usually found in the conventional radiation therapy, but that's a rarity with gamma knife radiosurgery. So these are the graphs of my patients, and you can see these patients presented with these orange ones are the preoperative ones, and then the patient gradually over the course of next 6 months to a year is practically free from all those problems, and there is a significant improvement in their lower cranial nerves. These are certain large volume tumors, like this is a 48 cc, treated with 7 gray in 3 fractions, gradually reduced to 20 cc. This is 20 cc, you can see the reduction in the tumor volume. You need to diligently follow these patients with the co-registered MRIs. And the first thing that the patient improves is the hearing loss, tinnitus, and the otorrhea. That all improves within 6 months. Rest of the things gradually take some time. These are certain examples. How much dose is a good one? If the tumor is very large, you can settle for a lesser dose of close to around 12 to 18 gray, but I prefer to go to close to around 20 to 24 gray in those patients. And this is something like a neuromodulatory effect. Many a times you do not find a significant volumetric reduction, but the patient improves in their lower cranial nerves, which is actually dictating their quality of life. You do not need to show a certain volumetric reduction to translate into that much outcome. Every treatment modality has its own set of complications. You may find a transient cranial neuropathy in some cases, like my previous speaker told, but usually these nerves are the motor nerves and they are very radiation resistant. In my own evaluation of the literature, I found that there was an overall complication of 8%, and it was higher in the LENEC and the cyberknife techniques in comparison to the gamma knife. When the lesion is superficial, you might find a temporary non-cicatricial focal alopecia, but this hearing loss improves. Sometimes the patients may develop certain cranial neuropathy or edema, and you might need to give steroid or bevacizumab for a certain duration of time. A word of caution is that most of these patients are now being treated with a primary radiosurgery, and you need to be really sure about the pathology you are treating. This tumor was treated at 2 institutions in India, thinking it to be a glomus tumor some 1.5 decades earlier, and the tumor didn't budge to the radiosurgery. When I need to operate on it, finally it turned out, it was not operation, it was an autopsy finally, and it turned out to be a primary intracranial extraskeletal mesenchymal chondrosarcoma. It was never a glomus tumor from the very beginning. So if your natural history, if your patient appearance is not matching, then you should actually operate and get the biopsy proven first. So notes for self is that surgical management of GJT is only for the symptomatic brainstem compression, secretory tumors in patients with the intracranial extension. SRS, especially gamma knife, is a safe and effective treatment modality with the excellent long-term clinical and the radiological outcome. It should be offered as a primary treatment modality rather than as a salvage, and the clinical improvement is irrespective of the radiological reduction. Is it cost-effective? Ask the patient who is not able to go to their work, who is on tracheostomy tube, whose family members are taking care of it. In our usual practice, when the patient is on a Ryle's tube for their feeding, this is one tumor which cripples the patient's life because of all these problems. The jugular foramen, those tiny nerves may lead to Horner syndrome and all those problems which do not happen with the radiosurgery. A word of a single slide on a catecholamine secreting glomus tumors. These are tricky ones. If you want to reduce the hormonal levels as soon as possible, operate on them. But otherwise, radiosurgery in the long term provides a good outcome. And you need to keep these patients on alpha and beta blockers because of the killing of those cells. It releases the catecholamines and your patient may end up into the hypertensive crisis. Thank you so much.
Thank you, Dr. Tripathi. I'm sure that will generate some discussion later on. Can I call Professor Goto now, please, for presenting mini combined petrocell approach in a large petroclival meningioma?
Okay. Thank you for a kind invitation to this meeting. Today, my topic is our mini combined transpetal cell approach for large petroclival meningiomas. Our institute, Osaka Metropolitan University, is one of the largest cardiac centers in Japan. Our old mentor, Professor Hakuba, started the combined transpetal cell approach about 50 years ago. And our mentor, Professor Ohata, and I followed his technique and modified the approach step by step. Professor Hakuba already published the combined transpetal cell approach in 1980s. So our team know that combined transpetal cell approach very useful procedure for safe resection of the petroclival meningioma like this. But in combined transpetal cell approach, we know that exposure of the sigmoid sinus and drill out the petrous bone in narrow surgical field seem to time-consuming and complicated procedure. So recently, many doctors prefer to use the lateral suboccipital approach to resect such kind of the tumor. So we modified Hakuba's approach step by step to increase the safety of the approach and also to shorten the surgical time. So today I will show our mini combined petrocell approach. This is our skin incision. Skin incision is not so small, but this is how harvest the temporal fascia with the pedicle of the sphenoid mastoid muscle like this. And then we just perform the temporal craniotomy, but we put the additional tuber hole to expose the sigmoid sinus. So we make the gutter posterior margin of the sigmoid sinus, and then we perform the temporal craniotomy. And then we harvest the outer plate of the mastoid bone. And this is our paper, how to expose the sigmoid sinus. In reality, we know that the wall of sigmoid sinus just adhere around the mastoid emissary vein. So we drill out just only this part, but another part, we dissect the wall of the sinus from the petrous bone and longitudinal out to expose the sigmoid sinus under the macroscopic fashion. And then we dissect the dura around the middle fossa and also dissect the dura around the presigmoid region and widely expose the petrous ridge. And then we start the petrous bone work, but we not expose a superior or posterior semicircular canal and also not open the internal auditory canal. We just focus bone work to cut the dura along this dot line. So we just drill out the petrous bone around the petrous ridge with a width of 3 millimeters. So our bone work is very short, just about 15 minutes or 30 minutes is enough. And then we open the Meckel cave at the initial step of the surgery to enlarge the surgical corridor. This is our paper, how to cut the dura to extend the surgical space. And then finally, we reported our mini combined transpetrocell approach to JNS, include a video clip. So if you have the interest, please check this paper. Now I will show how to operate this. This is a petroclival meningioma. So I choose a right side, a mini combined transpetrocell approach. Skin incision, of course, not so small, but this is how harvest the temporal fascia with a pedicle of sphenoid muscle like this. And then we designed a temporal craniotomy. We just put additional tuber hole to expose the sigmoid sinus. Our young staff expose the sigmoid sinus under macroscopic fashion, not microscope. And then we harvest the outer plate of mastoid bone for cosmetic mastoid plasty. And then we longitudinal out and dissect the wall of the sigmoid sinus like this. Now the sigmoid sinus is completely exposed. And then we dissect the dura around the middle fossa like this. And then we just open the mastoid antrum to know the location of the lateral semicircular canal. And then we dissect the dura mater around the presigmoid area. And then bone work start. But we just drill out along the petrous ridge with a width of 3 millimeters. So the surgical time of bone work very quick, short. And then we cut the dura. This is a presigmoid dura, and this is a dura mater under the superior petrosal sinus. And we open the Meckel cave at the initial step of the surgery. Why the opening of the Meckel cave is a very important procedure to enlarge the surgical corridor. And then we start the detachment of the tumor between the horse and the hip nerve. And then we mobilize the trigeminal nerve upward to additionally expose the anterior petrous bone. I drill out this part to identify the sixth nerve around the Dorero canal. So now, the most attachment of the tumor was already coagulated and devascularized. So when we start the internal decompression, we not encounter the bleeding. So we perform the careful internal decompression and dissect the cranial nerve. This is the third nerve. Now we reach the upper margin of the tumor like this. And then we carefully mobilize the tumor downward. Now most part of the tumor detach. So we can carefully dissect the tumor from the brainstem, icar, or basilar artery, like this. And now the most part of the tumor was resected out. This is a contralateral the trigeminal nerve and SCA. So bone work was small, but the tumor was successfully resected out. And also we can preserve the neurological function. This is another example. This tumor looks a migraine to brainstem, but we choose the same procedure. We skip the surgical video, but the bone work was small, but our lateral direction to the brainstem was very effective for careful dissection of the tumor from brainstem or cranial nerve. So finally, all tumor was resected out also, preserve her neurological function. This is another case. This is also petroclival meningioma, but surgical procedure same. At first, we open the Meckel cave in all cases, and to start the devascularization of the tumor between the space of the horse and hip nerve. And then sometimes the tumor involves the internal auditory canal. In such situation, I additionally drill out the superior and anterior wall of internal auditory canal through the subdural space. So it's easy to open the internal auditory canal. And then we detach the tumor like this. After detach the tumor, we not encounter the bleeding, so we careful dissection from the brainstem like this. So this case also tumor was resected out nicely, and then we can preserve the neurological function. This is the same, the size is large, but the strategy is the same. We skip the video, but the design of the skin incision is the same, and the bone work also same. And then we open the Meckel cave at the initial step of the surgery. So detachment is very important. After detach the tumor, we rotate the tumor from brainstem and basilar artery or something. Then tumor was resected out. We can preserve her neurological function. This is another case. I skipped the surgical video. Time is limited, but we can preserve her neurological function. This is our result for recent 10 years. We applied this mini combined transpectrosal approach to 44 cases of large petroclival meningioma. Extent of tumor removal is sufficient. In addition, we can preserve the neurological function in most cases. But one of the problems is that most patients show the numbness of hemiface after the surgery because we widely open the Meckel cave. This is one of the complications of this procedure. Now, of course, petroclival meningioma remains a challenge tumor, but now can safely rejected out our mini combined transpetrosal approach. Professor Hakuba started the combined transpetrosal approach about 50 years ago, and then we modified this approach continuously generation to generation, finally reach our mini combined transpetrosal approach. Thank you for attention.
Thank you, Professor Goto. So with this, the last paper for this session is reappraisal of anterior petrosectomy for petroclival tumor by Dr. Ascar Alves.
You know, I'm more a little bit known as a spine guy, but I thank Atul for allowing me to present our data here. So, you know, in Europe, there are not many people doing Kawazi's approach. It's not really a well-seen procedure. We do some of it, but we think it's nice to do a critical appraise of the Kawazi approach for petroclival tumors. I have no disclosures relevant for this presentation. We all heard here that this is a no man's area, very difficult, that raise operative challenges. There are many surgical approaches from a wide variety, ranging from anterolateral orbitozygomatic approach to posterior perspectives like the retrosigmoid approach. Kawazi in '85 reported the new approach for petroclival region for basilar aneurysms, and later on he expanded to petroclival tumors. However, there is a modest enthusiasm due to technical difficulties and feared iatrogenic risks, at least in Europe. And worldwide, the majority of surgeons still approach petroclival tumors through a familiar retrosigmoid approach. And we do as well here. This is one of our petroclival meningiomas that we could do a retrosigmoidal approach with no major deficits for the patient. But there are limitations for this approach. The surgical corridor is deep. The degree of freedom depends on cerebellar retraction, and the bigger the tumor, the more retraction. And you have to work in between the nerves, and this may cause iatrogenic lesions. Also, you have a limited access to clival dura to devascularize the tumor. Also, the brainstem tumor interface, access to the posterior cavernous sinus and cavern mecal. We presented in North America Skull-Based Society in 2002 a cadaveric study comparing retrosigmoid approach with the anterior petrosectomy. And you see clearly that the surgical corridor volume, as we measure it using the brain lab technology, was much wider for the anterior petrosectomy, and also much shorter distance to the pathology. And these were some of our work from this cadaver lab. So if you look at the clivus ramp zones, zone 1 extending from dorsum sella to a line across the two internal acoustic meatus, this would be zone 1, zone 2 between the line, this line and the line across the two jugular foramen, and zone 3 from the later line to the foramen magnum. And clearly for the upper clival tumors, anterior petrosectomy, it's a really good option. Extradural subtemporal corridor, drilling the apex of the petrous bone. There is no neurovascular structures, division of superior petrous signs and tentorial incision, and this will increase the surgical field. And you have a wide access to clivus, prepontine region to remove safely all these tumors. So some key steps for the juniors here. Neuromonitoring is important, especially the facial nerve. Positioning in supine with a shoulder roll and a deep lateral shoulder. The head is rotated to a position almost parallel to the floor, and the zygoma should be the highest point of the surgical field. Neck slightly extended, and the head tilted inferiorly, so gravity will assist mobilizing the temporal lobe away from the middle fossa. And always elevate the thorax about 10 degrees to facilitate dreenus drainage. A linear or a curved incision like this, exposure of temporal root of zygoma, and the burr hole is just placed above it. You do a very small craniotomy, 5x5, 4x4, square-shaped middle fossa craniotomy, 2/3 in front of external auditory canal. You should flatten the temporal bone at the inferior limit of the craniotomy. This will, you don't need almost any temporal lobe retraction. And because this is an extradural approach, there is an extradural elevation of temporal lobe. There is no interference with the labia vein. Identify and coagulate meningeal medial artery, further elevation of temporal lobe. You already start to devascularize some of the tumor. Dural elevation should be done posterior to anterior until you reach the GSPN, which is confirmed by using facial nerve stimulation. You identify the foramen ovale, foramen spinosum, and you reach this triangle, which has a limit anteriorly by V3, lateral by the nerve, posterior by the arcuate eminence, the superior semicircular canal, and medially by the petrous ridge. And just inferior to the nerve, lies the carotid artery. And for those you don't have intraoperative navigation, you can have a very nice, you measure the angle between the great superficial petrous nerve and the arcuate eminence. This is around 120 degrees. If you split the angle in middle, you will have the internal auditory canal. And on front of that, you have the Kawase triangle. We calculated with this study from 2002, drilling volume of petrous apex around 3 cubic centimeters. That exposes the posterior fossa with the preservation of the internal auditory canal and petrous internal carotid artery. Drilling from medial to lateral, preserving the bone covering the cochlea is very important. And you can also expose the dura covering the carotid and drill posteriorly to the internal auditory canal if there is a need. T-shaped incision of the dura, first incision as basal as possible in the middle fossa, parallel to the edge of craniotomy to access the tentorium, and a second incision perpendicular to the first incision to open the posterior fossa. You can also open the tentorium, and this should begin on the superior petrous sinus to the free edge to avoid lesion of the fourth nerve. So like that, you have your surgical field where you are facing the nerves directly instead of working from the posterior, interposed between the nerves and the tumor with your instruments. The angle of attack will be an angle of attack postero-medial and then the anterolateral. You have a very good visualization of the tumor and of the interface between the brainstem and the tumor. So the indications are for middle and posterior fossa tumors with variable extension, which includes also posterior fossa tumors that displace the fifth nerve laterally, elevates the third nerve in proximity of posterior cerebellar artery and extending above the tentorium. This is some of our cases, 73 years old man, important comorbidity. We decided to offer a Kawase approach instead of a occipital craniotomy. There was invasion of brainstem, of the pia, invasion of cavernous sinus, a very small component posterior and inferior to the internal auditory canal. We did a subtotal removal for brain decompression, brainstem decompression. Another case here, 65 years old man, neuro intact. This is the images. You see here petroclival tumor going with a supratentorial extension. And this is 4 years follow-up with gross total removal with a small remnant in the posterior cavernous sinus. This is the post-op MRIs. Another good indication is this kind of patient, 44 years old, right facial dysesthesia, neuro intact otherwise. This is a type C dumbbell-shaped neurinoma. there is this very interesting relationship with internal carotid artery, and the internal carotid artery transverses around the neuroinoma, but is separating by a firm dural layer that has been shown here. And this makes your life much easier. So this is how we approach with the linear incision for the craniotomy, and 11 years follow-up, just the right facial numbness, which is very restricted, no ocular nerve palsy. And actually, these kind of tumors, neuroinomas, are the best ones to operate because they create the corridor for you. They already destroyed some of the Petra's apex. So many pathologies can be indicated. Even we have done this operation for intrinsic lesions of the lateral pons. So these are the indications, but at least in our hands, there should be a minimal component of the tumor inferior and posterior to the internal auditory canal. This is those are the limitations for the surgery, where you have this dead corner of the angle of microscope that you cannot reach, you cannot work. You can bring an endoscope, but you can hardly work with the tools with the endoscope. There are limitations. This is one of our patients, also 33 years old, facial hemioapoesthesia, a tumor that was extending above the tentorium, almost reaching the foramen magnum.
Please conclude.
It was, and this expresses just the limitation I want to show you. We have now 10-year follow-up. We send the patient for radiosurgery because of the remnant, and it's a very stable lesion over the time. So this is really the dead corner of this surgery, and that's the difficulty. So conclusions, for the young people in the audience, I think it's a worth learning surgery, very useful for petroclival lesions that extend from a line behind the level of the sella to the internal auditory canal line, located medially to the internal auditory canal, allows the earlier devascularization of meningiomas from feeding arteries. It's a natural corridor free of vessels and cranial nerves interposed between the surgical instruments and the tumor, a very low risk of CSF fistula. Of course, extensive lesions, as we have seen here, need a combined approach, and you have to be careful with the iatrogenic morbidity, the cochlea, the facial nerve traction, and the forced nerve section. Thank you.
Thank you, Dr. Oscar. So with this, we come to the discussion part of this session, and invite the discussants, Dr. Hiroyuki Goto and Dr. Sumit Sinha.
So a wonderful session on the posterior skull base, and we had beautiful talks by distinguished speakers. So may I request all the 4 speakers to be ready with the discussion, and I can see Aip there. So we start with Aip. Yes, please.
Excellent talks by all the 4 speakers. And Manjul, especially, I would like to comment on your excellent talk. Now, for for jugular foramen tumors versus paragangliomas, the glomus jugulare tumors, the glomus jugulare is not a CP angle surgery. The moment you mistake the glomus jugulare for a CP angle tumor and go through that window, it's disaster. How much ever skilled you are, it is going to be a disaster. So what we have started doing in the past couple of years is that this tumor is in the sinus. It is in the jugular bulb. So you have to go lateral. You have to do a retrosigmoid craniotomy, and after that, go lateral to the sinus, extradurally, drilling out the whole bone. and then land on the jugular bulb, open the jugular bulb. Now the jugular bulb is so beautiful that everything, the dura anterior to that protects the cranial nerves. You're not even seeing the cranial nerves. You can take out this entire tumor from there rather than getting into the CP angle. The moment you get into the CP angle, it's like, going through your girlfriend's home through her father's room. So it is disaster. It will be disaster. So I think it is just a matter of approach. This is, obviously your radiosurgery, the results are very good, but I think paragangliomas or glomus jugulare is a purely neurosurgical entity. I beg to differ with you, number one. Number two, the Japanese faculty, Dr. Watanabe, had talked about CP angle schwannomas. We do something called total internal decompression, which when I say total, it is not just partial internal decompression. We open this, Kono calls it perineurium, people call it arachnoid, whatever it is. We open this superficial membrane, and using the exoscope under very high magnification and later on a 3D endoscope, we take the tumor out completely so that only a transparent membrane remains. It's not partial resection. I wouldn't say it is partial resection, but we're not, after decompression, we're not pulling anything. We're not trying to dissect anything from the cranial nerves. I believe eighth nerve preservation is only not possible for most because we do this and that creates the vasa nervorum to damage. So I believe this total internal decompression under high magnification is a very, very useful technique. I know many people may not agree, but this is our take on it. We haven't had the follow-up to see how many of them will recover, but I don't think so, because at the end of the day, we will just be leaving only a transparent membrane through which I can see all the cranial nerves and the vessels. Thank you.
Now another point.
Yes, sir.
I first is to Dr. Watanabe's lecture. Watanabe said that anatomy is very important. So it is very important. Second thing is, you know what, Watanabe did not, refer to my article. Where is Watanabe? Watanabe did not refer to my article on schwannomas, where we said something similar to what Ipe has said, that schwannomas are different. They are surrounded by, he talked repeatedly about capsule, about membranes and all those things. But that membrane, they are interdural in location. Whether the schwannoma is intracranial, whether it is in the mastoid bone, whether it is extracranial, the entire schwannoma is within dura, membrane dura. And that capsule that he was talking about is not a part of a tumor. And if you try to remove the capsule of schwannoma, you will definitely damage the lower cranial nerve. So this was written in my article. All three types, intracranial, mastoid, extracranial, the entire tumor. And if you do what even Ipe said, that radical means you remain within the dura, you remove the tumor, you save the cranial nerve. Not only save the cranial nerve, you can improve the function of cranial nerve. So that is about Watanabe's lecture. And Manjul, of course, you see, this is a different version. Whole life I have spent saying that glomus tumor is a surgical issue, no question. And I have not only said, I have argued, I have fought, and I have badly fought that should be only surgical issue, glomus tumor. And now what Manjul has said, and with my negative experience with glomus over some period of time, I have come to realize that glomus tumor indeed may not just be a surgical issue. And if you can get away with radiation and if you can avoid surgery, it is such a fantastic relief, not for a surgeon, but for the patient. And you know what? If you have to remove glomus jugular tumor completely, you have to handle the facial nerve. You have to move the facial nerve. So it is not just lower cranial nerve morbidity. It is facial nerve morbidity. So add facial nerve morbidity to lower cranial nerve morbidity. Now, you know what? If you remove glomus tumor radically, some facial nerve weakness has to be there in about 95% of patients. So you are adding facial nerve weakness, you are adding lower cranial nerve, you are creating a disaster. So if you can get away with radiation, I think there is, what do you say, Oscar, about this?
No, I agree with you. And the limited experience we have, because we in Portugal are just 10 million, and as it was shown here, these are not very frequent tumors, but we tend to approach with an anterolateral approach, the Bernard George with whom I learned this approach. You mobilize the vertebral artery from C1, C2, and the jugular tuberculum is just a little bit higher than the C1, C2, C0, C1 joint. And you approach from an inferior perspective. You have the control of the cranial nerves extracranially, extradurally, yeah. And you can also do the craniotomy, and then you get inside, and you can, so you almost don't see the facial nerve. Facial nerve, and it's a really good option to remove those tumors.
So,
Yeah.
yes, Dr.
I
Nair.
just have three questions for three speakers, not to myself, no question to myself. So one to Manjul, excellent talk, Manjul. You told that, we all of us know that this away, paraganglioma, it melts away with a gamma knife. But you told you embolized one case. Is it a negative step? Before people tell you should never embolize before giving gamma knife. Your comments.
So first of all, sorry, I do not say that it melts away. That I say for the cavernous sinus hemangiomas. In paragangliomas, the volumetric reduction might be just a modest one, a 10%, 20%. But what we are looking at, the aim of treatment in these cases is one is the tumor control of a benign entity. Second is a cranial neuropathy. The tumor control you are able to achieve in more than 95% patients in more than 2 decades.
Sorry, my question is embolization.
I'm coming on that, sir.
Please.
So the patients whom we embolize are the ones which we plan for the surgery, and those are the ones which are having a significant brainstem compression with the clinical manifestation. Only in those cases, it is not for the radiosurgery, because that embolism is not something like an embolization of an AVM. They are not same. Here, you embolize only for surgery, not for the radiosurgery.
Got the point. Dr. Vadanabe, you told what is the management, the paraganglioma in Japan? You operate or you do gamma knife?
Please give him a mic. But I remember in his series, there was only a single patient of a glomus tumor, rest all were meningiomas and schwannomas, what he showed.
I think it's a paragangliomas is in Japan, so it's almost really sent to the gamma knife or radiosurgery. So that or something like that.
Okay.
But glomus jugulare is so it's a really complicated, and also the vascularized, and also the nerves is surrounding. So it's it'll be not good for the surgery. But jugular tympanicum, it's good for the surgery. So because of the tumor is located inside of the bone, we can remove it. But as you say, it's a gamma knife is very effective. So it's a patient. It's depend on the patient's symptom, I think. So if the patient is complain about some symptoms from because of the pain or something like that, we need the surgery is very effective sometimes. But the radio surgery is very effective. So as most of glomus tumors sent to the.
Thank you, Vatanam. And last, I want to ask some to Goto also. I have listened to his talk on endoscopic approaches to Peter Clivel, and he has described one arising from posterior clinoid and one arising from down. And he always tells it is position of the sixth nerve. Goto, your comments.
Goto, also you must say, what is your take on glomus tumors? I want to know your opinion.
Thank you. First question from the Professor Nair. Of course, I use an endoscopic enonasal approach to clival meningioma. Endoscopic approach very effective to resect the clival meningioma. But in case of the petroclival meningioma, I not use endoscopic enonasal approach because the attachment of the tumor is dorsal side of the sixth nerve. So if we access a petroclival meningioma by the endoscopic endonasal approach, we have to mobilize a sixth nerve to detach the tumor. So surgical result not good. So I prefer to use our mini combined transpetrosal approach to the petroclival meningioma if the size is large. But recently we tried or we performed the keyhole endoscopic subtemporal anterior transpetrosal approach to reject the small or minimum size of the medium size of petroclival meningioma. This year we reported this technique to JNS. So please check. Endoscopic keyhole anterior transpetrosal, very effective. The second question is when the Professor Hakuba he tried to reject the jugular foramen paraganglioma, the transjugulare approach, but the surgical results not sufficient. Patients show the lower cranial nerve palsy for 1 month or 2 months. It's very aggressive procedure to the patient. So Professor Ohata completely changed the strategy. Our first treatment is radiotherapy, gamma knife, or IMRT. We already treated the jugular valve, the paraganglioma for about 30 years, long time, but the control rate of radiosurgery is very, very effective. Of course, very few patients show the recurrence, and we have to operate. But in such situation, the vascularity of the tumor dramatically decrease. Surgical resection, very, very easy. So recently, we first choice is radiation to jugular foramen paraganglioma. Thank you.
So,
Thank you so much, sir.
My question to Manjul is, Manjul, you said that by gamma knife, there is very little volumetric reduction in the size of the tumor. It's only a stable control, tumor control is there. So what about those patients in glomas who present with brainstem side effects, brainstem compression or mass effect? I don't think that gamma knife is a very thoughtful strategy in such type of tumors presenting with mass effect.
I totally agree. If you remember my slides, when to consider the surgery, it really happens in a very small proportion of patients. The tumor grows intracranially. The tumor has a natural tendency to follow the path of the least resistance because of the it destructs the petrous bone and then goes down along the lower cranial nerves. Very rarely it happens, it goes inside. But if it happens, patient presents with the brainstem compression, or very rarely it may present with a trigeminal neuralgia when the tumor has gone up. In those cases, you need to operate because the volumetric reduction with gamma knife or any sort of any IMRT is not going to be that much robust in a shorter duration of time. So if the patient is symptomatic for those ones, go and operate over it. Leave a residue and then we can tackle it later on if you have to.
Yeah, Dwarika, last, then we wind up.
I just want to make a comment on
Please, sir.
this glomus jugulare. Actually, I have a large series on this glomus jugulare. At one time, I was really operating on this glomus jugulare tumor, and I do get a lot of references. And recently, I operated one patient from Sri Lanka also. And nowadays, actually, we don't mobilize the facial nerve as we actually do what is called fallopian bridge technique. We keep the facial nerve on the fallopian bridge. So you operate on both either side and keep the facial nerve. So you don't have to mobilize the facial nerve. So most of these, glomus jugulare tumor, they come with the lower cranial nerve palsies. So when you operate them, you don't give them with extra deficit. And most of them do compensate, and they don't have much lower cranial nerve palsy because they do compensate by the opposite side. So yes, so you do a volumetric reduction. You don't aim for the total excision. So you reduce the volume as much as possible and then do gamma knife, or we have cyber knife, so we give cyber knife. And they do excellently well, as you have said, 95%, 20 years follow-up, 95% control rate for 20 years. They do exceedingly well. But as you said, the volumetric reduction does not take place. But if you really do a volumetric reduction by cytoreduction surgically, and then give them gamma knife or cyber knife, they do really well. I have a large number of, glomus jugulaire, as all of know. Initially, I was presenting them quite a bit. And I still do get a lot of referrals. Me and one of my colleague, head and neck colleague, we do together, and because we have still a fascination. And so they do exceedingly well combined with CyberKnife. So volumetric reduction as well as, CyberKnife, they do exceedingly well.
Thank you for that comment, Dr. Ghosh. Last comment, Dr. Dwarika, please.
I had a question. Question is, what is the, do you use the posterior transpetrosal approach, the pre-sigmoid retrolabyrinthine approach for petroclival meningiomas, and if so, when? Do you use the pre-sigmoid posterior petrosectomy and pre-sigmoid retrolabyrinthine approach for petroclival meningiomas instead of the Kawase's approach? That was one question. The second question is, I agree with Manjul, our data is almost similar. There's almost a 30% reduction in size, Manjul. We just analyzed it. And it's not only glomus jugulaire, it's also in juvenile nasoangiofibromas with cavernous sinus excision. I mean, it is the JNAs and cavernous hemangiomas melt with gamma knife. And with the latest gamma knife, actually, we are becoming more aggressive. We can go up to C2, we can go up to 18 to 20 grays, fractionated, and unless there is pressure symptoms, in today's day and date, I don't think it is proper to operate upon glomus jugulaire tumors, unless there is a mass effect on the brainstem.
So whom is your first question directed to?
Regarding the posterior approaches to petroclival meningiomas.
To all the speakers?
No, to the last speaker. Do you use the...
Dr. Oscar.
So we use the pre-sigmoid approaches for tumors which go below the foramen magnum, and it obviates the need for doing both an anterior approach and then stage it with a retrosigmoid approach. So you could do both for all these tumors which extend from top to bottom in all the three zones. We do a pre-sigmoid, we do first a posterior petrosectomy, preserve the hearing, and then do a pre-sigmoid approach, transtentorial, and then approach the tumor. It's almost like gives you a direct line of attack onto the top of the tumor. So that is better than the standard retrosigmoid approach.
Okay, well, thank you so much, all the speakers and the and
the chairpersons and the discussants. That's my duty.
So much. So it's a wonderful, wonderful session then.
Thank you so much. Thank you. And now from one war zone to another war zone, it's an apple pie of so many neurosurgeons here, the cavernous sinus, mastering the complex. And the chairpersons are Dr. Kentaro Watanabe, Dr. Arun Srivastav, Dr. Massimiliano, and the discussants for this contentious issue are Dr. Kenji Ohata and Dr. Suresh Sankla. Please, sir.
So we're gonna start the second session, the cavernous sinus and the mastering the complex. So first speaker is Dr. Manas Paniglash. So as a transdural petrocypex removable pros and cons. Please start it.
Good morning, chairpersons, and I changed the topic because I saw so many talks on anterior petrosectomy. I thought tentorial meningioma was not covered in the CME, so I'll be speaking on our experience on tentorial meningiomas, because I have spoken many times on intradural petrosectomy. Tentorial meningiomas means it's not very common. Long ago, Professor Yasagil had classified them into 8 types, depending on the site of attachment on the tent. From the tentorial notch, he divided into T1, T2, T3, depending on anterior, middle, and posterior. And laterally, again, anterior and posterior divided into C6 and C7. The middle part was T4, and in the along the straight sinus, again, it was divided anterior, depending on the anterior and posterior, as T6, 7, and 8. Now, they have modified that. Professor Yasagil modified the classification into basically 5 instead of 8. They made it 5 groups only to. It is easy to analyze the results in these 5 groups. So you have a medial incisoral group, you have a faccotentorial group, you have a torcular group, lateral tentorial, and the intermediate. If you go back to 2004, this was the first article, largest series of 81 cases. The morbidity and mortality in tentorial meningiomas are quite high. This is in 2009. There's a report from SGPGI. They said the operative morbidity was almost 27%, including the paper from Dr. Goto and Professor Ohata in 2017, and then 2006. They also had a very higher morbidity and mortality. That was morbidity was high, not mortality. That was the reason why we wanted to analyze that what is our results. Now, this is a paper in 21, and here one can see, in spite of 30 years of expertise, the incidence of new deficit has been almost to the range of 5 to 15%. Over the period in 30 years, the mortality rate has reduced from 14 to 44%. In 30 years ago, the mortality was 44% in some series. Now we have come down to 3 to 10%. The complication rate is almost, till now, it is almost very high, 25 to 30%. And this is a paper in 2017. Now, this paper in 2017 from Dr. Anil Nanda, he reported that among the 5 groups, like you see here, the 5 groups which I described, modified Yasagil, the recurrence rate also is very high, almost 22 to 40%. Because it's a varied sites of pathology, one has to operate by different approaches. Most of the anterior tentorial incisoral tumors can be done either anterior approach, either with a Kawase approach or FTOZ. And if it's a lateral tentorial, then you can do with the retromastoid or a combined pre-segment, which I described now. And if it's an intermediate type, one has to do it either a suboccipital or a supratentorial, depending on the extent of the tumor, whether it's a supra or infratentorial, then one has to do a combined approach. And if it's a faccotentorial, one has to do a posterior interhemispheric approach. So we analyze our data for the last, from 2009 to 2024, or 15 years. We had 60 patients, and then we had a mean follow-up of 33 years. And there is a strong female preponderance. It's 75% of our population were females. Now, this is the first group of tumor. We had in the medial incisional type, we had 11 patients, patients with scans like this, which is ideal for anterior petrosectomy. We do not do extradural, we do an intradural petrous apex removal. That's a different talk. I am not speaking on that, but this is what we did. And this was the small video clip of that. So we did an intradural petrosectomy. We opened the Meckel's cave and then dissected a tumor. This is the 4th nerve. One has to detach the tumor on either side of the 4th nerve. We use a laser, thulium laser, it becomes easier to detach from the tent. the attachment and then deliver the tumor below the fourth nerve and remove. So the basic principles of dissection, preserving the nerves and the vessels has to be done to take out the tumor. So in this 11, the commonest approach was Kawase or subtemporal approach, and few cases we could have done. The second commonest approach was retrosigmoid approach. And this is the pre and post-op scan in this group of patient. We had only 3 patients in the peritorcular area, which is a T5, and this is a small video clip of that. The tumor, first one has to detach from the tent and then decompress. And then we do a limited dural opening so that the cerebellum doesn't pop out. Just open the dura along the tumor. And after decompression and devascularization, it was a very hard tumor. CUSA was not working, so we had to use knife to decompress the tumor. And finally, the part which was involving this, the torcular area was removed. We had a torrential bleeding. It was easy to achieve hemostasis by putting serial clips and then reconstructing the clip by removing clip one by one. As you can see here, you put serial clip to reconstruct the transverse sinus and torcular region, and then did a continuous suturing by removing the clips one by one and reconstructed the vessel to achieve hemostasis. And these are the post-op scan of the patient. Now the intermediate type, we had 10 patients, and these are easy to approach. So the commonest approach, what we did was suboccipital, and the other common was combined supra and infratentorial. The lateral, the most commonest group in our was the lateral tentorial. We had 25 patients in this group. The commonest approach was suboccipital and retrosigmoid, depending on the extent of tumor. Like this patient, which had which is in the lateral 10, the transverse sinus was obliterated. Both it had gone infratentorially and supratentorially. So the first, so this is the infratentorial part, this is the supratentorial part. We detached from the tent. Also, Sastri was there for this case. And after we had decompressed and detached, then we incise the transverse sinus as it was already obliterated. And then cut the tent all around the attachment. Yeah, you use the Colorado needle to, this is the infratentorial part, and the tent is cut all around the attachment to excise the whole tumor along with the attachment. Either laser or Colorado needle works very fast and easy. And this is at the end of tumor dissection, tumor removal. This is the pre and post-op scan. This is another pre and post-op scan of another case. This is another case. In the pharmacotentorial group, we had 11 patients, and suboccipital approach and combined intrahemispheric approach was done in 3 cases. I don't have a post-op scan, but we had one mortality in this case. So for all the 5 groups, the highest complication was in the peritorcular, whereas the other groups have the least complication was in the intermediate group. The complication rate, we had 1 death in the pharmacotentorial, but then we could reduce the complication rate to 7% from the 27% or 20% described in some literature. We had a recurrence rate, but the recurrence rate was related to the extent of excision rather than the MIB index. We had 56 cases which were in grade 1, but the recurrence was there in this group rather than patients who had a higher MIB index. We had one patient who had a primary radiotherapy outside. She came with recurrence, and then we had to operate. In her, the report was anaplastic meningioma, and the MIB index was 14%, 40%. As she had already received SRS, we started on bevacizumab and everolimus. In conclusion, the recurrence of the lesion is associated with the grade of excision rather than the tumor histological report. So goal of surgery should be complete excision except in the phacotentorial group, and understanding the anatomy helps in diagnosing the disease. Thank you for your attention.
Thank you so much. We will discuss at the end of the presentation. Now we move to the second speaker, Dr. Siddhartha Ghosh, surgical nuances of medial sphenoid wing meningioma. Dr. Siddhartha Ghosh.
There you go. Just do it.
Then the next speaker speak, I'll just do it. Next speaker. Can the next speaker? I'll just
Okay,
do it.
so we're gonna change.
I'll just do it.
Next speaker is Dr. Shunsuke Shibao from Japan, and then the topic is the usefulness of the endoscopic assisted anterior petrosal approaches. Please go ahead.
Thank you, Chairman. Good afternoon. Good morning. I'd like to talk about the usefulness of endoscopy-assisted anterior transpetrosal approach. The anterior transpetrosal approach, ATPA, is and subtemporal anterior transpetrosal transitorial approach. This approach was reported by Professor Kause in 1985. He's my mentor. In recent years, endoscopy-assisted microsurgery has been developed and its usefulness has been reported. The anterior transpetrosal approach is a useful method for reaching the petroclival region but it has limitations in its reach and some blind spots. The objective of this study is to present a case series of endoscopy-assisted ATPA and discuss its usefulness. This study included 13 ATPA cases out of 110 endoscopy-assisted craniotomy surgery performed from August 2021 to July 2024. We analyze the purpose and situation in which endoscope was applied in these ATPA cases. As for patient characteristics, mean age was 62 years, almost female patient. Most tumor was located around the pituitary region. The pathology included meningiomas, epidermoid, and metastatic tumor. Mean tumor size was 25 millimeter. This is the purpose and situation of endoscopy-assisted ATPA. The purpose included the endoscopic observation only and endoscopic manipulation. The observation included confirmation of important anatomical structures such as facial nerve, auditory nerve, abducens nerve, and pituitary vein, and prevention of CSF leakage. Manipulation included tumor dissection around the internal auditory canal, inferior part of pituitary apex, and behind the pituitary vein, and manipulation of other blind spots. Next, I will show the representative case of each situation. First is tumor dissection under the internal auditory canal. The case is 41 years old female with right pituitary apex meningioma. The main symptom was hearing disturbance, and tumor was extending into the ISE. The operative video. The standard ATPA was performed. MMA was cut, coagulated, and cut. And the GSPN was identified and dissected into durally. The causes triangle was exposed. The causes triangle was drilled and drilled. The tumor attachment was appeared. The middle and the posterior fossa dura was incised, and tumor was exposed. SPS and the tentorium was cut, and tumor attachment was detached. When the attachment around the internal auditory canal, the endoscope was introduced. So under the endoscope, the tumor inside the internal auditory canal was visible, and the pituitary vein was confirmed under endoscope. The last attachment was detached, so the tumor was totally removed. The postoperative MRI shows the gross total resection, and hearing disturbance was improved. The next is the tumor dissection around the inferior part of pituitary apex. The case is 55 years old female with right pituitary apex meningioma. The surgery and radiation therapy for pituitary germ cell tumor was performed 30 years ago, and radiation-induced meningioma was suspected. Preoperative venous system evaluation shows the vein bridging from the brainstem and the superior surface of cerebrum to the tentorial edge here and here in 3D, and tentorial sinus continuing to the cavernous sinus here and here in 3D. So we want to avoid SPS and tentorial ligation to preserve this venous system, and tumor was located around the inferior part of the pituitary apex. So we plan to perform simplified ATPA without SPS and tentorial ligation, as reported in this paper, combined with endoscope. The operation as a BR system is used to confirm the craniotomy position. The craniotomy was placed and the epidural dural dissection was performed. The MMA was cut. The arcuate eminent was dissected. And this PN was dissected interdurally. The Carset triangle was exposed. In this case, the Carset triangle is widely drilled to manipulate the inferior part of petrous apex and introduce the endoscope. So after the cut incision of dura, the tumor was exposed. The decompression was started. Here is the abducens nerve was identified, and the tumor split along the abducens nerve. At this stage, the endoscope was applied. So under endoscope, the structure around the tumor was good visible. So this is the monitor arrangement. The exoscope was used to check the structure around the endoscope. Dissecting the tumor from the brainstem, and the endoscope, the dissecting plane is visible. Under microscope, the clival attachment was not visible, whereas under endoscope, clival attachment is visible, and we can take seeing this. Finally, tumor was totally removed. And no digital tumor was confirmed on the endoscope. The postoperative MRI showed gross total removal and no complication was found. The last is prevention of CSF leakage. Under endoscope, we confirmed open air cells in the blind spot here and fat filling. This is included in this paper. The clinical outcome, the gross total removal was achieved in 53.8%. As for complication, transient brain edema was 2. Permanent cranial nerve deficit was included facial paresthesia in 2, trochlear nerve disturbance 2, facial nerve 1, probably due to the heat injury during the drilling. And no CSF leakage was found in this series. In ATPA, with narrow operative field and many blind spots, the endoscope is used for observing important structures and operating while confirming them. It is also useful to confirm closure of open air cells in the blind spot to prevent CSF leakage. This is conclusion. Thank you for your attention.
Thank you so much for your beautiful presentation. As said before, we will discuss at the end. We ask again to Dr. Siddhartha Ghosh. Presentation title is Surgical Nuances of Medial Sphenoid Wind Meningioma.
Thank you, Professor Abdul, for giving me this opportunity. And it's really a great conference. I will talk on this, on the medial surgical nuances of the medial sphenoid wing meningiomas. As you know, this is a very difficult area. And as per the Professor Al-Mefti's classifications, these tumors are divided into three groups. The one group is medial to the anterior clinoid process, and this, the peculiarity of this group is that there is no arachnoid plane in this. So these tumors are densely adherent, and the encasement of the neurovascular structures are there. So it's very difficult to separate this tumor from the neurovascular structures, as opposed to the second group, which is lateral to the anterior clinoid process. So this tumor has an arachnoid plane. So it's comparatively easier to separate this tumor from the neurovascular structures. And there is a third entity which arises from the optic foramen. And so these tumors goes early into the optic foramen. And so these tumors are relatively small and they get detected earlier also. And the visual loss is very early. And these tumors are very difficult to remove. And these are the patients who normally presents with visual loss very early. So that treatment is always surgical, unless there is some specific indications where the patient's age and other factors, otherwise it's always surgical. And that a lot of factors depends on the size, shape, extension of the tumors, epicenters of the tumors, the vascularity of the tumors, and of course the attachment of the tumor. And the relationship with the visual apparatus, ipsilateral optic nerve, contralateral optic nerve, optic chiasm, and the relationships with the major vessels. That's all important for this decision making. So also important whether the vessels is encased or vessels is displaced, epicenter, extension of the tumor inside the optic foramen, evidence of hyperostosis of the sphenoid wing or cavernous sinus involvement. So we need always intraoperative navigation is very important. QSA is very important tool, and sometimes the ultrasonic bone QSA is important for the, when you do the clinoidectomy. So here is a patient which has a medial sphenoid wing meningiomas. I will show the video in these patients. This is the position. You make it slight extension so that you get a good base control on these patients. So you do the extended pterional craniotomy, orbitozygomatic osteotomy, and you decide on the extradural clinoidectomy if that is needed or not, and then the intradural exposure. So I always go through, open the medial in the sylvian fissure, go through the sylvian fissure, because it's very important to have the, the important of this surgery is to have the middle cerebral, important of this surgery is to have the MCA vessels under control. The most of the time, the problem the tumor gives is the MCA vessels and the perforators, and that gives the deficit. This tumor was very, very firm, and the consistency is very, very important in these vessels. If you look into, so you go to the frontal side and devascularize the tumor from the, from the orbital roof and the frontal side of the tumor. So I'm taking into the frontal side, devascularize the tumor from the frontal side of the tumor. So as you can see it here. And once you do that, then you go and look behind and see whether you can get into some M3 branches. Try to see some M3 branches. As you can see, I can see some M3 branches here. And once you see the M3 branches, try to follow those branches proximally. The tumor is very firm, and there is no way you can suck this tumor. So you take the top part of the tumor and cut this tumor, and you follow the branches proximally and try to get the M2 branches. Here you see I got into the, this is the I saw the A1 branches there, which is crossing the optic nerve there, taking out the superficial part of the tumor, and then try to lift that superficial part of the tumor to get some CSF. Then once you get the tumor out, you can use the CUSA. Again, try to see whether you can get the middle cerebral artery in control. I got the middle cerebral artery, and you see the A1 branches crossing the optic nerve. Try to get the internal carotid artery. So, got the internal carotid artery. You see the A1 branches. You have to see all the perforators. Tumor is very firm. So, it's very important for these firm tumors, very, very difficult for this at this area. Try to take the superficial part of the tumor so that you leave the deeper part of the tumor where the perforators are. So here is very important because here the ICA will come and form the M1 branch and try to get into the middle cerebral artery and dissect that middle cerebral artery here. These are the difficult tumor because this tumor is very, very firm. So you can get into the middle cerebral artery completely. And lenticulostriate branches are also very important. You have to keep all the branches safe. So you may have to leave a small little bit of bits and pieces on the MCA branches. So you can see the whole M1, M2 all intact. All the perforators are intact and the patient did very well. Sorry. So this is the post-op pictures. The tumor has been excised completely. And the patient also is doing well, did well. After 2 weeks, after the patient had a mild ptosis, but has been walking with no deficit. So this is a clinoidal meningioma. This is more difficult tumor because these patients. Again, you have to go through the sylvian fissure because you have to try to open the sylvian. Here, actually, my associate opened the dura first before I came. So I'll just take 1 more minute. So I had to open the dura and do the clinoidectomy later on. So did the clinoidectomy. So this tumor was also not that firm. It was suckable. You can see the optic nerve here. Most important to see the neurovascular structures. And here, because it's in the clinoid, you have to first you have to see the optic nerve and the internal carotid artery there so that you get a proximal control over there. Because the most of the time, that is the area where you can get into the, just 1 minute. So to debulk the tumor, The large tumor. The magnification was not much here, so that so you can see the carotid here. Over. So you can see all the neurovascular structures are all intact, and the patient did well without any deficit, and vision also improved. So this is a post-op scan showing total excision. Thank you.
Thank you very much. So we're gonna discuss it after. So let's move on. The next speaker is Dr. Ashish Suri. The topic is surgical nuance in cavernous sinus invasion of the pituitary adenomas.
नोट पे चला दूंगा, लगा दो फिर मैं प्ले कर देता हूँ। प्ले करूँ? कल आप चेक तो किया था, देखो चल रहा है। Yeah, thank you, dear chairpersons, dear Dr. Goel, thank you for the kind invitation and the wonderful Indo and Japan programs. So this is again a slightly humbling talk. This is some pituitary adenomas growing into the cavernous sinus. So how do you treat them? And they can be small extensions, they can be big extensions, they can be huge extensions. So this scroll is not working. Can you put it on this? I cannot control there, no? I cannot see and do this, right? Yeah, आ रहा है, ठीक, अभी आ गया, ठीक. रीटाइम कर दो मेरा. हाँ, दिख रहा है, मुझे भी दिख रहा है, ठीक. वो टाइम भी ठीक कर दो. फिर घंटे बजाएगा तुम. हर 30 seconds के बाद ठंग ठंग ठंग. So these are difficult tumors. They grow into the cavernous sinus, small extensions, big extensions, huge extensions. They're humbling, all types of surgeries, radiation. These are invasive pituitary adenomas. They invade in the cavernous sinus, bones, sphenoid sinus. Invasion does not include suprassural extension. It is a MRI-based classification. Cavernous sinus extension is pretty common. Nearly 1/5 of all pituitary tumors, 1/3 of all giant adenomas, 2/3 and 1/3 of acromegalies, and 1/5 of prolactinomas, and even Cushing's. Though I've personally seen less Cushing's invasions, but if you see, many of them are stuck on the cavernous sinus. But why would you need to operate them? You can just take off the cellar and just give radiation surgery. But the result is cavernous sinus cytoreduction is important to make it more gamma knifeable. So especially for functional adenomas. Second, in the non-functional adenomas, the Cushing's and acros are pretty resistant to gamma knife or to SRS. So then medical therapy is better if you do some cytoreduction. And these patients have very severe headaches. That is the main presentation of these patients. What is the invasion radiological parameters? The NOS grading or the mucous NOS 3A between the two cavernous, below the ICA, and going beyond the cavernous. This is something which I love. I combine the two, the NOSP and the Goel classification. So this is where it transgresses the middle wall of the cavernous sinus, goes beyond into the superior wall, and then goes subdiaphragmatic. Then the last WHO classification changed everything, and it was Dr. Kiran nicely presented yesterday that the higher giant and invasion, non-remission, post-operative residual, progression, recurrence, morbidity, mortality. So it's not only a surgical skills, the tumor biology is also important. The sparsely granulated somatotroph adenomas, the lactotroph adenomas in men, Crookes cell corticotroph adenomas, and the silent corticotroph adenomas in the PIT1 positive pluripotent tumors. These are the ones will have more invasion, will have more morbidity, mortality. Several series has proved. Now, the main problem is endonasal or transcranial. That is a different thing. Microscope versus endoscope. Several series over the last 10 years have said that endoscope approach has higher incidence of extent of resection in NOS3 and NOS4 tumors. NOS grading is inversely proportional to the gross total or the extent of resection. Grade 4, total encasement of intracavernous ICA, the gross total. Even if you do a very good excision, there's a minimal chances that you will completely remove a NOS4 tumor. The extent of resection can be as good as 0%. This is my personal series. My teacher is sitting here. I learned it from Dr. Banerjee and Dr. Mehta. The first close to 200 cases when I became a faculty was all microscopic. I used to do it so beautiful and so fast. And then I changed. I changed because of these invasive adenomas. And then we realized that you could actually see more with the 30-degree and the 45-degree scopes. For the microadenomas and the macroadenomas, both microscope and endoscope are the same. Even uninostril, binostril are the same. It's only in the invasion and the giant ones, it makes a difference. And then if you see the transcranial also becoming bigger, these transcranial ones are the ones which actually are important, which I'll come down to that. So these are the approaches that can be used for invasive adenomas. I personally use the endonasal, the extended endonasal. Again, the scroll has gone back again. I don't know, some problem. Ye mouse gayab ho gaya. The pterional and the transcavernous. And if there is a NOS3A or a GOEL2, that means it's transgressing the cavernous sinus. It's between the two it's between the two ICAs. It's not working. It was working and abhi aa gaya. Thank you. Yeah. So it's between the two ICAs. You can actually, you need a standard endonasal endoscopic approach. You need to just change it to a 30-degree scope. Look at the extension, take it out. You only need a fat packing because it be between the 4 blue lines. You do not need a Haddad flap in a 3A and you can completely excise these. What about 3B? 3B is more difficult below the ICA. So again, you need a 30-degree scope to visualize and remove it with a curette so that you completely remove it. Only fat packing if there's CSF leak required. No Haddad flap is required. These are standard endonasal endoscopic approaches which are required. But because you need to see the arachnoid bulge and the cavernous sinus, and this is the view you can easily get with a 30-degree and 45-degree scope, just an additional. But what about NOS4 and GOEL3, 4, 5? There's nothing known as 5 at the moment. We may put another 5 also. So these are extended endonasal approaches. These are not minimally invasive. They are maximally invasive approaches. There's more removal of the skull base. It's not between the 4 blue lines. You have to go beyond the 4 blue lines. You have to go beyond the carotids. You have to go beyond the tuberculum celli into the clivus. There's much more destruction of mucosa. You need to do a middle turbinectomy. You need a Haddad flap because you have to go beyond the carotid. So these are the steps for an extended endonasal endoscopic approach. The nasoseptal flap, there is one horizontal cut just parallel to the mucocutaneous junction. There's one vertical cut and 2 horizontal cuts. The lower horizontal cut is at the junction of the septum and the nasal floor, and the upper one is at the parallel to the upper wall of the middle turbinate. But the more you go behind, you actually dip below. This is where the olfactory mucosa would be there. Then the dural incision is important. We're doing a standard microscopic cruciate incision, standard endoscopic a semilunar incision. But in extended approaches, it's different. It becomes a T or an H. You actually go probably 5 o'clock to 7 o'clock. If there's a subfrontal extension, you go through the anterior intercavernous sinus. If there is a crossing beyond the cavernous ICA, you actually take the dura beyond that. And the skull base repair is also different. It is a 3-layer repair with fat inlay fascia, sometimes a non-lay fascia, and a Haddad flap, which is pericranial flap, and then the pad packing. And we always put a lumbar drain for nearly 3 to 5 days if there's high flow CSF leak. This is a NOS4 coil 2, transgressing the cavernous sinus, going beyond the ICA. And this is, I'll just scroll through the video. You actually drill more. You need to drill on the dorsum sellae. You drill lateral to the cavernous sinus on the right side because the tumor is on the right side. And then this is the sellar incision I'm giving already, the sellar dural, taking off the tumor. And I can see the ICA there. That's the ICA. Use a Doppler, and with navigation is a must if you're doing an extended approach. For a standard endonasal approach, it's not required. That's the ICA. Now I want to go lateral to the ICA. Must look at this. That's the anterior notch that I'm taking out the tumor from. Then drill more, drill more. Therefore, if you're drilling more on that side, you need a middle turbinectomy of that side. And you cut the dura at the medial OCR, and then cut the dura lateral to the ICA. You can even bridge this dura, this dura is overlying the ICA. Once you have taken off the tumor there, no biopsy forceps here, only curette and gentle suction. And then 3-layer pad. You cannot leave the carotid bare. So you can use this extended approach with a standalone approach, or it can be combined with a staged transcranial one, or it can be a shake hand approach, an endonasal and a transcranial. And this is a bilateral NOS4, in which the skull-base drilling is much more, it is the planum, the tuberculum, between the two lateral to the cavernous sinuses. That's the anterior intercavernous sinus I'm opening. That's the sellar floor. That's the suprasellar tumor I'm removing there. That is from the A2s. Then incision beyond the carotid. That's the carotid. I'm going lateral to the carotid on the left side, taking tumor there. Doppler is there. These tumors are fibrous. The more lateral they go, the more fibrous they become. So do not use any biopsy forceps there. Gentle curettage. And then again, a 3-layer repair. The carotids cannot be laid bare. They have to be covered with a natural tissue. So these are the cases. We operate the tallest lady in the world from West Bengal. We're finishing it, but it's still long. And then what about these unilateral invasive tumors? These are the ones which go beyond the carotids. There you do not do an endonasal approach. You do a transcranial approach. You do a transcavernous exposure. I'll just rapidly go through this. Open the Parkinson's triangle. Take off the tumor from there, a bulking. And you're safe with all the cranial nerves there. The more lateral it is going and more transgression is there, and we've done some unilateral invasive, even done some bilateral invasive, but transcranial. What about recurrent? I'm getting a lot of these tumors post, these are all functional adenomas with a paracellular extension, post gamma knife, post surgery, but the hormonal, even with medical therapy, the the cure is not happening. So you open the cavernous sinus, Parkinson's triangle, decompress the tumor from the Parkinson's triangle. So it's all pterional craniotomy, extradural approach here, and then you go intradurally. And then open the falciform ligament, take the tumor out from the opticocarotid cistern. That's a suprasellar extension. And then this lady was cured, she's an MBA student. And then this is another tumor, which is, there's no suprasellar, this parasellar and the oculomotor trigone, that is the superior, that's the GOEL 3. So you do an extradural removal of the tumor, Parkinson's triangle, and then you go intradural. Intradural, you're not in the opticocarotid, you're actually over the third nerve. That's the oculomotor trigone. I know my friend Dr. Goto does this beautifully from the endonasal route. I want to see the third nerve and then be away from the third nerve. I don't want to handle it, and then this tumor is removed completely from there. Goto is much more daring than me here. So this is our paper in which we found that all these extensions, retrocellular, subfrontal, cavernous sinus, are poor prognostic indicators. If the tumor is T2 and T2 hypointense, it is the extent of resection is poor, multilobulated. These are the humble conclusions. The cavernous sinus extension of the pituitary adenomas are invasive adenomas. If it is GOEL1, NOS3AB, standard GOEL2, standard endonasal endoscopic approach with just a 30 degrees or 45 degree scope, no, just fat, no Haddad flap. If it is a GOEL2, that means transgression of the cavernous sinus. NOS4, small hyperintense tumors, extended endonasal approach. You need an optimal drilling, an optimal exposure, and a meticulous three-layer report. But if the tumor is hypointense on T2, it is large, it is going in the superior wall of the cavernous sinus, and that is GOEL3, 4, and NOS4, beyond NOS4. You do not do an endonasal approach. You actually do a transcavernous approach. Here, there's a combination of extradural and intradural. In extradural, you open the Parkinson's triangle, decompress from there. Intradural, the opticocarotid or the oculomotor trigon. Thank you so much.
Thank you so much. Now we move to the last speaker, Dr. De Pujari, endonasal endoscopic approaches to the cavernous sinus. Oh, no, okay. And we open to the discussant, Dr. Kenny Hohata, Dr. Suraj Sankla.
I think all the speakers really presented very well, and the presentations were superb. We learned a lot of new things from these presentations. First of all, we go to the meningiomas, posterior fossa meningiomas, and I would congratulate Dr. Manas to have a super presentation. My only contention is that, you know, the more posteriorly placed meningiomas were like any other meningiomas which you see all over the skull. It is the deep-seated meningiomas which are really problem. In the anterior, posteriorly placed meningiomas, it is just the question of management of sinuses. And whenever the sinuses rupture, we do take care of it accordingly. And I agree with Manas that we use the same technique for closing the sinuses. I don't know what is Dr. Ohata's opinion about this. Closure of the sinuses.
So some tentorial meningioma is very dangerous because sinus is on the way to the lesion. So in my case, the transverse sigmoid sinus is very key issue to how to treat during the operation. So I carefully analyze the structure of the transverse sinuses and the communication between two sinuses and the location of the vein of Labet. And if it is, not dominant side, I intentionally cut the sigmoid sinus distal to the entry zone of the vein of Labet and lift out the tentorium together with the temporal lobe. It's, I think, one of the way to avoid the complication of the rupture of the sinuses.
I think it's a good technique. Manas, do you have something to say?
It depends. Means we always do a pre-op MRV. We don't do angiogram. But Professor Hota always does an angiogram. MRV, no, means he does an angiogram. But we just do an MRV, and then during surgery, means I didn't have time to show the video. If many times you can see the wall of the vein and preserve it. But if it's involved, as I showed, we remove it and reconstruct. But it's totally obliterated. Then we excise. But in some cases, we have reanastomas, electively cut, and then reanastomas at the end of surgery.
Your follow-up was rather
3 years.
small, 3 years. For
Yeah, that's
meningiomas,
because-
at least you have 5 years follow-up.
Yes.
Yes. You want to...
So regarding this reconstruction of the sinuses, I would like to know the opinion of Professor Ohata and Dr. Manas. Have you seen in the post-op by getting an MRV done as to what is the status of the sinuses after you repair it during the surgery?
how many times you come across with the thrombosis of the sinuses and its clinical implications in the post-op. I hope I am clear for my question.
Yeah, means if the patient is not symptomatic, I've never done an at follow-up.
Yeah, but I mean,
MRV.
what is your experience about repair of the sinuses during surgery and the status of the sinus after the repair and or the reconstruction in terms of the thrombosis of the sinus? Because you can repair it very well, you can reconstruct it during surgery. The only thing which matters is the thrombosis of the sinus with its clinical implications in the post-op, which happen.
See, I don't have document of doing post-op MRV, but we didn't have complications that much because as I showed you, we had only one mortality that was in the fork-backward interval, but not in the cases we have done sagittal sinus reconstruction or transverse sinus reconstructions.
What's your experience, Professor Wahata, regarding that?
So in case incidentally we injure the sigmoid sinus or transverse sinus and wall is damaged, the second problem is the development of thrombosis. It's migrate to the peripheral distal side. In such case, I take a jugular vein and put the graft on the sinus to repair it. It's I think one of the solution to development thrombosis.
Yeah, I start low molecular weight after 1 day, 24 hours.
And for how many days?
5 days.
5 days complete. Very good. Yeah.
Means it's just an observation.
I know.
There is no proof.
So
and then follow it up with the oral apixaban till the suture removed.
Right. We now move to the second paper, and if you have any question about the first paper, please ask.
Just to open the discussion to
Okay.
different vascular topics,
For the anterior petrosectomy, particularly with the meningiomas, we do endoscope to use during the surgery. Towards the, the last part of it, from where we can remove the tumor completely. We have Professor Goto with us, who uses the endoscope more frequently than us. And I would like Professor Goto to make a comment on that.
Recently, we introduced a pure endoscopic procedure for anterior petrosectomy. Because endoscope can offer panoramic view, so even just through the keyhole, we can widely expose a Kawasai's triangle. So drill out the petrous bone under endoscope is not so difficult. So recently, I recommend the keyhole, the pure endoscopic anterior transpetrosal approach. But of course, I respect the classical, the anterior petrosal approach. Surgical, the craniotomy not so large, and also I understand this is very less invasive epidural procedure. When we just plan the keyhole anterior transpetrosal approach, we have to access the petrous apex through the subdural space. So my procedure is a subdural anterior petrosal approach through the keyhole and the endoscope. So there is some the difference.
That makes the difference. Yes, Manas.
I mean, why did you prefer to do through the subtemporal? You can do the same thing through retrosigmoid and means the standard CP angle approach and use endoscope to remove.
When I apply the endoscope through the suboccipital approach, the cranial nerve and the petrous vein is behind the camera, behind the endoscope. So I feel it's very risky, dangerous procedure. So I prefer to use a subtemporal approach. If we access a posterior fossa through the subtemporal approach, the behind the endoscope is very safe. There is no cranial nerve and no critical vein. So I think the subtemporal approach is a reasonable procedure to access the posterior fossa through the by the endoscopic approach. So this is my comment.
Gentlemen, thank you so much. Sorry, I have to interrupt in between. Okay.
So we have been using the lateral supracerebellar approach. So Professor Goel has started using this approach long back for petroclival meningiomas. So we have seen that majority of the tumors we have been able to handle and tackle with this approach, even with the cutting the tent or going into the cavernous where it is expanded. And we were able to handle majority of the petrocaval meningiomas with this approach.
I only interrupted the gentleman, ladies are allowed, so it's okay. So thank you, chairpersons, discussants, and the speakers for this wonderful session. And now we are so honored. Thank you, chairpersons. And let's move to the next session, and this is a much awaited one. We are honored by our guests who have come all along from Japan for this Indo-Japanese meeting. And this is going to be a marathon session from 11:30 to 6 p.m. with multiple topics and with a galaxy of stars. And I first invite Professor Kenji Ohata for the welcome address. And subsequent to that, I request Sir to address our gathering. Thank you.
So good morning, everyone. First of all, I would like to thank Professor Atul Goel for graciously acceptance of our request from Japan to revive the Indo-Japan Neurosurgical Conference. So we have a long history between two countries to have a friendship, academic communication and people-to-people communication. We have now 20 delegates from Japan, including very, very active neurosurgeon, active chairman, and active staff of the Department of Neurosurgery. And we have, of course, 3 senior executive committee, including myself and Professor Hongo Chris is here. So I hope young generation further deepen this communication between two countries. So no wonder all are extremely happy to revive this conference. So I'm sure we have a wonderful 2 days. Thank you, Professor Goel, again. And I would like to invite Professor Chris. He has to cancel the conference 2020 due to the COVID-19 pandemic. So Professor Chris will describe the history of this friendship, and he will mention how to spend the 6 years silent. Please, please.
Good morning. Dear friends, colleagues, seniors, youngers, ladies and gentlemen, on behalf of the tentative of Japanese delegates at 9th meeting. No. Later. Just greetings. Okay. A 9th meeting of the India-Japan Neurosurgical Conference here in Mumbai. I'd like to express our sincere appreciation to the Indian Organization Committee members, especially the President, Professor Atul Goel, for managing 9th Friendship Joint Meeting in Mumbai. I had to organize the 6th meeting 2020 in Hiroshima as president, but Professor Ohata said, I could not organize the meeting by COVID-19 pandemic for 3 years in Japan. During these 3 years, all Japanese trustees of joint meeting retired from university. In Japan, after retirement from university, it is very difficult to collect funds for managing meetings. So after discussion about the restart of this meeting by the Japanese trustees of this meeting, Professor Ohata asked Professor Goel to manage the joint meeting with or in some meetings in India. Professor Atul Goel was so kind to add this meeting to the Neurosurgical Week. Thank you very much for all of you very kind invitation to Neurosurgical Week meeting. I do hope our joint meeting will continue on the basis of mutual respect and mutual understanding and mutual support attitudes. Thank you very much for your attention and the patience. Already, all of you know that Professor Jun Yoshida, one of the founders of this meeting, passed away on December 28th, 2022, at his age of 77. I'd like to move to the special issue in memory of Professor Emeritus Jun Yoshida. Good? It's okay? Hi. No problem. Oh, this is the wonderful curriculum vitae of Professor Yoshida. He was born on March 27th in Hashima, Gifu Prefecture, Japan, and graduated from Nagoya University Faculty of Medicine in 1969. And then he moved to the Medical Center, New York University, and Montefiore Medical Center for research, especially neuropathology and molecular biology. And then he came back to Japan and then became a second head, Department of Neurosurgery, Kam Hospital, Aichi, Japan. And back to the university as assistant professor, Department of Neurosurgery, Nagoya University. And he became professor and chairman, Department of Neurosurgery, Nagoya University in 1996. And he became head, Center for Genetic and Regenerative Medicine, Nagoya University Hospital in 2002. And he became a president, 63rd annual meeting of Japan Neurosurgical Society in 2004. And he retired in 2008 and became Professor Emeritus, Nagoya University. After that, he worked as a director of some hospitals, and he passed away on December 28th in 2022. He got a huge several awards and prizes, especially from the Japan Neurosurgical Society. He got the Garen's Award in 1983 and the Saito Makoto Prize in 2002, and the highest prize of JNS, the Sano Cage Prize in 2016. This is a summary and history of India-Japan, of Japan-India Neurosurgical Conferences. The first meeting was held by Professor Yoshida in Nagoya in 2003, followed by the Professor Mehta, New Delhi, AIMS, 2004, and followed by Professor Hori in Tokyo, and then Professor Panikar in Cochin, and Professor Ohata in Osaka, and Professor Goel in Orobanbad, and then from Kiyoshi, Professor Kiyoshi Saito, of course, Osaka, and then Professor Sastry, Hyderabad in 2018. And ninth, this time, Professor Goel in Mumbai. This is a memorable photos of Professor Jun Yoshida at the greetings of the opening ceremony by Professor Ohata and the Japanese and the Indian trustees of this meeting. And then also the greetings at the opening ceremony. In summary, Professor Jun Yoshida was born on March 27th in 1945 in Hashima, Gifu Prefecture. He had been a medical doctor, a specialist of neurosurgery, PhD, past professor and chair, Department of Neurosurgery, Nagoya University, and Professor Emeritus, Nagoya University, and President, 63rd Annual Meeting of Japan Neurosurgical Society. Of course, he's a specialist in neurosurgery, but other specialty is neuropathology. He introduced molecular biology and genetic engineering to the field of neurosurgery and put forward the concept of molecular neurosurgery. He started gene therapy using interferon beta embedding liposome as the inaugurator in Japan. We'd like to pray for his soul to be in peace. Thank you for your attention. Thank you.
Thank you, sir. And I'm sure a generation of neurosurgeons got benefited because of his teachings and his interactions. Now, I request all of you to kindly stand, and we should observe a moment of silence for the departed soul and the legendary neurosurgeon, Professor Yoshida. Thank you so much. In Ghazal, we say, "Mohabbat karne wale kam na honge teri mehfil mein, lekin hum na honge." The mehfil is still continuing, this neurosurgical mehfil, and now I request Professor Atul Goel sir to address the gathering.
One thing I can tell you, you ask any Indian participant of this meeting, you talk about Japan in general, you talk about Japan. There is inner respect for Japan, inner love for Japan. Like, I think you agree, Manjul, like no other country, Indians love Japan. You agree? And there is no controversy about it, no controversy. If you go on the roadside and ask about Japan, you know what the people will say? Country with greatest discipline. There is no other country in the world with that kind of discipline. If you ask me, one thing is, there is no other country in the world with time respect. No other country. You agree, Dr. Kiki? Absolute, no other country. As far as I am concerned, I have spent a lifetime in Japan with my dear Hongo. Hongo, please come here. I want to hug you. Please come here. Believe me, I have spent a lifetime with this. You will not believe, but if you see my passport, there are more than 60 entries in Japan, 60. And majority, he was the one who invited me, Professor Kobayashi, Ohata. I have spent a lifetime with Ohata. Ohata, come here. You know what? I spent a lifetime with my dear Ohata. Another person, Kurisu, come here. This is another gentleman, very respected, very senior, very accomplished, very much known neurosurgeons of the world. They are not ordinary neurosurgeons. Ohata's contribution, Hongo's to skull base, Hongo's contribution to vascular neurosurgery, Kurisu's contribution to all types of neurosurgery, including functional neurosurgery. They have not just done neurosurgery. They have promoted the art of neurosurgery, they promoted the art of micro dissection, promoted the art of precise dissection throughout the world. If you ask me, Japan means a lot to me. If you ask my wife, one country which she wants to visit, believe me, I'm not just I'm not a politician. She wants to visit Japan. She wants to see the culture of Japan again and again. She wants to see the flowers of Japan. Once, you know what, all the time I go to Japan on some meetings for some conference and this and that, Ohata, you'll be surprised. Once I went to, not for any conference, not for anything, just to see the flowers, lavender flowers. No, lavender. Where was this lavender thing we went? It, only to see flowers because my wife wanted to see the flowers. And it is indeed my great pleasure to welcome the Japanese delegation that has come here to interact with us, to enjoy our culture, but more than anything else, teach us. Teach the juniors and seniors alike and promote the art of neurosurgery, the love of neurosurgery, the discipline of neurosurgery to each and every one of us. I can only say that when I see my Japanese friends, I bow down with respect. I bow down with love. And at each occasion, you see, when I was growing up in my life of neurosurgery, I used to conduct, Hongo will remember, many cadaveric workshops in Japan, cadaveric workshops. First time I went on the invitation of Professor Kobayashi to Japan, and I was looking for some gift, what to take to Japan. Professor Pandya told me, take a skull to Japan, skull bone. So I took 2 skull bones, one I gave to Hongo and one I gave to Professor Kobayashi. And then I was traveling repeatedly to Japan. You know what? This skull in Professor Kobayashi's room was locked. I mean, nobody, just glass was there and people could see, nobody could touch it because it was such a precious gift. Plastic model at that time in Japan, plastic model of skull was costing 350,000 yen. Hongo, is that correct? Real skull bone there was no cost of it. It was most expensive gift. Then what I started doing first in Shinshu, then in Osaka, then in Tokyo, and then in multiple cities in Japan, I used to, in cadaver dissection, I used to take a skull. First I started temporal bone. This cutting of temporal bone is very common in India and with ENT people. So I went to the cadaver fellow and I took 2 or 3 or 4 temporal bones, packed in my bag and went to Japan. I conducted first temporal bone cadaveric workshop in Japan ever. We called Professor Al-Mafti from US, we called Professor Kawase was always there. Professor Hakuba with his very nice smile was always there. So then then my enthusiasm grew. What I used to do is cut the cavernous sinus. When the mortuary, they cut the head, they remove the brain, put some cotton there. So there is no problem. This is routine. So what I requested this cadaver fellow who were my friends, I used to give 5 rupees or 10 rupees or 15 rupees of me, if it was, and they used to enjoy some nice drink and they used to allow us to do dissection. And I used to cut cavernous sinus from middle, and I conducted, Hongo, how many workshops we conducted in Japan? Most popular workshops at the age of, I was hardly 33 or 34 years old at that time, and I became a celebrity in Japan. My workshops were most popular in Japan. First I conducted with 4, and then I went to a mortuary fellow again. He said to me, Dr. Goel, you are coming repeatedly with 1 temporal bone, 1 cavernous sinus, 1 this. Why don't you take the whole body and give me 100 rupees? That time I realized that there is some danger in this. And then I realized to transport human skull and human parts is a crime. And recently stopped appointment of Hongo and Professor Kobayashi. And I was repeatedly invited to Japan, and we wrote a book, Neurosurgery of Complex Tumors and Vascular Lesions. In 1996, the book was reprinted thrice. Still, it is one of the most popular books in complex neurosurgery, 1996-97. The beauty of that book was Professor Kobayashi had hand-drawn many line drawings. He used to draw like Sugita. This art of line drawing, every operation that you do, line draw. Professor Kobayashi used to do. So those pictures, and I thought that my work also was very tremendous in that book, became very popular. All in all, I must say that if there is one country that has contributed to the growth of my life, I think I can only tell Japan is the country. And I am extremely proud and privileged to have you all. I hope that we do not disappoint you. I hope you enjoy your short trip. I hope you interact with young and senior alike and let them see what Japan means. There are some tremendous neurosurgeons from Japan here, tremendous. Many of them are high quality neurosurgeons, well-known neurosurgeons here. I'm sure our people will enjoy and learn from them. Thank you very much for coming. Thank you.
Thank you, sir. Thank you, the esteemed guest. And now we start with the special lectures. And the chairpersons for this session are Dr. Girish Solanki, Dr. Siddharth Ghosh, Dr. Sridhar, and Dr. Yuta Sato.
So I'm going to start the first session of the Indo-Japan meeting, special lectures from Dr. Hongo, Kazuhiro Hongo from Japan, and the title is How to Avoid Complications Intraoperatively, focusing on retraction work and high-speed drill. Please start, Dr. Hongo.
Good morning, everyone. I'm Dr. Hongo from Japan. Well, first of all, I'd like to congratulate Professor Atugoyo to organize this wonderful neurosurgical week, including Indo-Japan friendship or collaboration meeting. I'm very impressed. And before my small talk, I should say one thing. While I'm hearing Professor Goel's remark right now, well, I just remember that you talked about the temporal bone dissection first ever in Japan, in Matsumoto. Or actually, the temporal bone, human temporal bone, real one. So Professor Kobayashi worried about, is it safely he can bring the human temporal bone to Japan? So he wrote a letter signed by Professor Kobayashi, autograph signature. And I brought the letter with me and went to the Narita International Airport. So as Professor Goel came through the custom without problem, I brought the letter. But fortunately, I can welcome Professor Goel without problem. That is the real first event of cadaver temporal bone workshop successfully done. And the other things, yeah, it was, I met Professor Goel. First time was 1992, if I'm right, after coming back from Pittsburgh. At the time, already 32 years ago. I was young and Professor Goel was quite young, early 30s, I think. Yeah, he gave me a present, a skull, whole skull, with two more pearls, C1 and C2 bone. Frequently, Professor Goel had lectures showing. Now he is also the specialist on craniovertebral junction expert. He shows the C1, C2 bone frequently. Oh, this is the bone. This is what I was, Professor Goel gave me. It's unforgettable memory. Congratulations and thank you very much. I'm very proud. I'm very proud of being here, and he is my lifelong friend. I'm really proud. And so this is I'm the first to present the in-Japan scientific session as the special lecture, but well, I retired from Shinshu University, and well, I thought, what is the appropriate talk? Well, I will talk on, I cannot talk current very sophisticated surgical procedures. So this is not senior, but I'd like to share my bad experience especially to young and less experienced surgeons to avoid the severe disastrous experience. Just mainly, I showed two cases. Of course, for patient having that complication is not good, but by sharing these experience, please avoid such complication. This is my intention to show. Various steps causing complications, of course, surgical indication through surgery and post-operative management. And today I'm focusing on surgery, and among surgery, there are various, of course, complications, and focusing on vascular surgery, vascular injury, arterial and venous. I will show one each, caused by myself. Not many, but about less than 10 years. When I was the professor chairman in Shinshu University. Well, one case is rather elder lady having craniopharyngioma. The lesion is here. And because of visual deterioration, I thought that the surgery is indicated. The goal is not total removal, but we thought I need to at least decompress. Partial removal is good enough. And I did surgery via left pterygium approach. Here is the nearly end of the surgery. Now here, optic nerve, internal carotid artery. Many of you may not notice the event will occur from now. Now this is nearly, I thought at least a little bit more piece will be removed. Now, spatula is here. And what happened is now magnified. Now, you may notice some change in the operating field. Now, at the time, I thought I could control the breathing, try to suture, of course, evacuate the blood and compress the cervical carotid and try to suture, but eventually, because of sclerotic change, the tear became large and eventually almost lacerated. But fortunately, the retrograde flow, I thought it was sufficient and MEP monitoring not deteriorated. So just without doing any revascularization, I terminated the procedure. Now here. 2 days after surgery, as you may imagine, the ischemic change. And 4 years post-op, the patient, CT scan getting worse and not hemiplegia, but almost hemiplegia. And the patient was sent to the rehabilitation hospital. It was very bad for the patient. Well, to prevent arterial injury, no excessive direct retraction. Direct means direct retraction of the artery itself, and no retraction of the, especially sclerotic artery. Now, she's my mentor, Professor Sugita. He was the professor chairman when Shinshu University neurosurgery started, 1997. And you may know this atlas, micro neurosurgical atlas. And even in the cover figure, this AVM surgery, of course, and the spatula. The spatula, brain spatula is one of the Professor Sugita's invented, nice one. And in the drawing, he sometimes showing this. To widen the operative field, he preferred to retract the internal carotid artery by a spatula. So yeah, this is very efficient, I think. So with using his multi-purpose head frame to very fine maneuver retraction can be done. At the time, this is a paper I wrote, published at the Journal of Neurosurgery, 1987. This is the sensor installed retraction pressure sensor spatula Professor Sugita made. And I use this to retract pressure. The basal artery was retracted and optic nerve was retracted. So during this surgery, I retract the very sclerotic internal carotid artery too much. But honestly, I didn't notice this change during surgery. It's no good here, and too much retraction. So I take home message, retraction work for vessel, no excess retraction, direct retraction, especially in the sclerotic artery, and especially the proximal IC near the carotid ring is anchored. It's good for even a little bit sclerotic, the middle cerebral artery or other portion of the artery, but this is not good. At this site, the artery is fixed. Another one, just venous injury. Well, this is young lady having the incentive found aneurysm, paracranial aneurysm. I did the direct surgery, and here, covered the surface of the brain with rubber, and this anticranial process being drilled. You may notice what happened in a minute. I used diamond drill. Cutting drill is not good at this stage, so diamond drill is used. And then here, and venous injury. But fortunately, the floor was patent, and remaining procedure was completed by removing the further anticlinal process further by bone curate and clip the aneurysm without problems. Fortunately, very lucky. Now keep drilling. High-speed drill is very good, but need to be care. Remove these very important, and the steady handling is needed. And drilling on off at inoperative field and adequate irrigation to prevent heat injury and appropriate selection of bar. Diamond cutting, currently there are various ones, but the diamond, even diamond gloving occurs and appropriate angle is no good. Very basic, but need to be careful about appropriate direction. This is no good. Should be this way to the safer way. And drilling and cutting, curating, bone curate is when it is available. This is better, safer. Do bone curate almost gloving, no gloving. So high-speed drill, efficient, but the under operating microscope is near vital structure, but the gloving the vessel or causing heat. So appropriate and suitable usage is mandatory. Take home message here. Now, bone curate is safer, alternate too. Just the bad experience I showed, appropriate retraction was stress and proper usage of the high-speed drill was stressed. So in any difficult cases, the very basic procedure should be done at any time. Not acrobatic, but steady. Basic one needed. Thank you very much for your kind attention. Thank you.
Thank you very much, Dr. Hongo. He presented he made a very special lecture, a very important lecture for us neurosurgeons. So we'll move on to the next speaker.
I call upon Professor Suresh Nair. We'll call on arachnoid in vestibular schwannoma surgery.
Thank you, Atul, again, for including me in this very important session with three of my very close friends from Japan, Professor Ohata, Professor Kurisu, and Professor Hongo. In fact, they have come to my house also. And I have not gone to Japan 60 times, but I had been there 18 times. And 18th time I went 3 months back with my wife just to see Japan. That's not for neurosurgery. And I saw first time I saw real Japan with my friend. What a great country. Humility, that is what all of them have. And I don't want to give this talk, but to tell how I learned this surgery from them. Otherwise, I have so many stories to tell about these three great persons. Thank you. I will talk of arachnoid in vestibular schwannoma surgery. Indians in this crowd can go to sleep because they have seen this. My experience of 835 cases, we see all sizes, shapes. Unlike Japan, they might see very small size, and this yellow things are something which is myths, people thought CS of compartment, there is a single compartment, which is not. Vestibular adenoma, people all thought it is epiarachnoid tumor. Is it correct? We'll see. And let me go through all this. These people demystified something. We all know the anatomy of these things. I will just keep ECP angle, a single cisternal space. It as written by Professor Majid Sami. He has put everything in that saffron colored thing. And these are some of the pictures, and this is the article. But if you see this video, say CP angle area has multiple CSO spaces. This is what we are straight seeing. It's a 7th, 8th nerve in acousticofacial cistern. This is the 5th nerve in another CSO space. This is the lower cranial nerves in another CSO space. So suppose a tumor arises from 7th, 8th, and vestibular here, inside the subarachnoid space. Always there is arachnoid which separates it from the 5th nerve. Always there is arachnoid which separates it from the lower cranial nerve. If it is arising from intra-arachnoid. So this is just to tell you there are multiple CSS spaces, and you can open up all these spaces just for teaching purpose. Say some of the case, one case, I was drilling this, then there is no complication. And then just to show all the cranial nerves, so you are seeing the 6th coming between the rootlets of, between ICA artery coming between the rootlets of 6th, 7th, 8th here, a compressed 5th nerve above. So this is the lower cranial nerve, 6th nerve. So we can open up everything, but all of them are in different. This is the 7th, this is the 5th here, compressed, and even 4th. Some residents were there in the department. So I thought I will demonstrate that also. So all these are in different CSO spaces. And we know that subarachnoid space extends right up to the far lateral end of the internal auditory canal. There is no epiarachnoid space there. And we know that this is a high resolution T2 weighted image to show arachnoid extends right up to the lateral. And we know these tumors arise now inside the internal auditory canal, inside the subarachnoid space. So this is a myth. We have been taught these tumors arise epiarachnoid by Professor Yasser Gill's this famous diagram. Tumors arise epiarachnoid at the far lateral end of the internal auditory canal. As these tumors push towards the angle, they carry it with 2 layers of arachnoid. The arachnoid which was inside to juxtapose with this parietal arachnoid. So any surgeon who operates through a retrosig or retrolab route, he has to remove this double layer of arachnoid to remove the tumor. Is it correct? These 2 gentlemen taught me what is vestibular schwannoma surgery. One person is sitting here, Professor Kenji Ohata. This is his present publication which came long back. And this is my friend there, some pictures. And this is yet another friend of mine, Mishiro Kono from Tokyo. So they taught me, because everybody is telling after acoustic surgery, large surgery, House Brackman grade 1 post-op. Here I am not seeing 7th nerve at all. And then this is excellent article written by Professor Kono. 2 depictions are there. This is a subarachnoid depiction. We are seeing arachnoid here. And this is a epiarachnoid depiction. So what he did, this publication, you should read. He peeled off this double layer of arachnoid and then took a biopsy from the cut section and found that most of these tumors have got a arachnoid over the tumor to make it a point that these tumors arise subarachnoid inside the canal. And now you know this is the mechanism by which you get this duplicated fold of arachnoid. Tumors arise inside the canal, and at the porus it carries with it the arachnoid and go back. You get this duplicated arachnoid. These tumors arise, Professor Ohata described, inside the internal auditory canal, gets adhered to the porus, behaves epiarachnoid for some time to become subarachnoid again. And this is excellent depiction of the tumor from Professor Kono. This black thing is the perineurium, which is the capsule of the vestibular nerve. The capsule of the tumor is the perineurium. Facial nerve is stuck to the tumor. There is no arachnoid there. Arachnoid is outside. So we all taught so many people, you look for arachnoid between the seventh and the tumor. It is never ever there. And this is an excellent depiction again from Professor Kono. This is a seventh nerve stuck to the tumor. You wait, you look for arachnoid, it won't be there. So this is again from one of my old things while I was at Bhopal. You can see it arises inside the internal auditory canal. And you can see CSF at the far lateral end. Unlike vestibular meningioma, petroclival meningioma, always there is arachnoid, which separates it from the tumor. Vestibular schwannoma, there is no arachnoid. Unless very few cases like this, intracochlear, these things, you have this, it arises epiarachnoid. And let me make my point clear with some videos. These are some of the problems with vestibular schwannoma, burr how to make everything small craniotomy. I'll skip all this just to show some videos. So surgical technique, what I do is first step is internal decompression. Second step, internal decompression. Third step, internal decompression. Decore the tumor and make it slack. After that, go to the internal auditory canal, identify the nerve, and then trace both the canalicular to the other. This is a very old thing. So this sharp dissection, SS forces, this is what Professor Kono had taught me. By these SS forces, very sharp forces. So I'll just run this video just to make the point that these tumors are subarachnoid in origin. So first, I have decompressed the tumor, identifying the nerve. This is the facial nerve here. And you can see a thin layer like that, which looks like arachnoid. It is not arachnoid, it is the perineurium. Arachnoid doesn't have a blood vessel over that. Here you can see it's a perineural dissection. Some tumor is left there, fifth nerve there. So just to make the point that there is no arachnoid, which separates it from the seventh nerve. This is another video. I'll skip this. This video always Atul used to tell, please don't show this video. I have seen it time and again, but it is a lovely video. So that again, to make the point, so I have decompressed the tumor inside the angle area, covered everything with bone wax there, so that an assistant who learns can drill the canal, even if the drill slips, like what happened to Professor Hongo. If you keep the bone wax there, even it slips, nothing will happen. So here, this tumor inside the canal, after, say, we are peeling it out, now you see the nerves there. Already I have decompressed the tumor here. Now you have to connect these two. And that is simple acoustic surgery. This was taught to me by Professor Ohata, and you can see the flattened nerve. This is a flattened seventh, eighth nerve. Here it is the internal auditory canal part, and most of this is the flattened nerve. Ultimately, you can connect that. These patients do extremely well, and even if they have some deficits pre-op, they recover very well. So what point I have made is, this is a patient after surgery. These tumors arise intra-arachnoid, inside the internal auditory canal, and behave epiarachnoid for some time to become subarachnoid again. This is again this is currently what we do is we take out this tumor, drill the canal, and then people use it as total tumor, as if the whole tumor has been removed. You can see the nerves there, but when you introduce the endoscope, you can see still tumor inside the far lateral end. Doesn't mean all these tumors will recur. So here you can see the tumor totally removed, the nerves there. So I think I will, this is cystic vestibular schwannoma is a different issue. I don't want to show all this. This again to show perineurium. Perineurium, I just want to show again, it is just a veil of membrane. Let me come to the here. Here you can see seventh nerve here. You can see this thin membrane here over the seventh nerve. This is the seventh nerve. This cotton should go out. Then you can see the thin veil of membrane over the seventh nerve, which is not the arachnoid. It is the perineurium of the perineurium of the vestibular, from the perineal capsule of the tumor, which is the perineurium. This is the seventh nerve here. You can see this veil of membrane with vessels over that. This is the perineurium, not the arachnoid. Let me conclude. So if patients develop this, we do this anastomosis after some time. And bilateral acoustic is always a different ball game. And let me finish with the vertebral artery injury. This is the principles of acoustic surgery. All this has been described, and there is a learning curve. I burned my finger, and then only I thought from these Japanese people who taught me how to do acoustic surgery. So everything is sharp dissection. This person, this is Professor Hongo's boss, Professor Kobayashi, what 10 golden words he has written. Everybody has to do vestibular schwannoma surgery, and you should believe that you can do it, and then you will start doing it. And the conclusion is, in giant and large vestibular schwannoma, there is no arachnoid which separates the tumor from the facial nerve. If you look for facial nerve to protect you, there won't be any facial nerve. Thank you very much, ladies and gentlemen. These are some of my publications in vestibular schwannoma. And thank you for attention. And I am so happy that Professor Hongo, Professor Ohata, I don't know whether Professor Kurisu, they have come to my home. Thank you again.
Thank you, Professor Nair. May I now call upon Professor Kurisu to talk on basic maneuver of microinstruments, especially so-called three fingers technique.
Yes. Thank you, dear Chairman, for kind introduction, and also the Atul, and also the all members of Indian society. A great congratulations of the great success of the Neurosurgery Week here in Mumbai. And thank you again to add India-Japan Neurosurgery Conference to the Neurosurgery Week. Oh, this is our new logo mark. I'm now working as a director of Chirugorosai Hospital. So actually, I presented full paper at the timing of the Neuroscal-based Con 2017 in Kochi, directed by Professor Panika, full paper at the time. But this time, this is the contents of the full paper, but today's just focus on the holding and handling of micro scissors and bipolar coagulator, a so-called three fingers technique, especially under microscope. Okay. So this is the bayonet type of the micro scissors. Which type micro scissors do you like? I like this type. How do you feel the handling and just covering the holder? This is my fingers, and using the thumb, total 3 fingers to hold this micro scissors. So this is the supporting joint point, and then power point, and then working point. Just look on the same line, like this. But this type, the parallel of the supporting and working line. What's the difference of the movement of these two kinds of microinstruments? And if you hold the bayonet type of instruments like this, it might be very stable, but your finger covers your tips. I don't like. If you hold this like this, you can observe the tips through or between two knees of the bayonet type. And then to confirm the tips clearly, that can easily safely dissect and cut. And if you hold like this, it may be stable, but rotation and movement of the microinstrument is very limited, very difficult to use freely. Don't use like this. But if you hold like this, 3 fingers, we can rotate the wrist to adjust the direction almost 100 degrees, like this. So please look the tip of the micro scissors and rotating very less movement. But if you hold like this, the point is relatively moving. And also, if you use the bipolar, maybe you twist the bipolar, and then sometimes the tips of the bipolar move like this. So this is the bipolar. Also, the can observe the tips through the knee. But if you hold like this, very limited. But if you hold like this, you can change and rotate freely. So with suction, hold like this. So the basic maneuver of the using the suction and bind type of bipolar or forceps, like this. So I'd like to emphasize the additional effect of shoulder movement and posture. If you hold like this, rotate, but shoulder angle is not change, like this. But if you hold like this, shoulder angle widening like this. So if you hold the bipolar like this, and then type microinstrument like this, maybe rotate needs the widening of shoulder angle. But you hold like this, and then turning the wrist, the very stable. And then under the microscope, we can control the microinstruments through the very small area, like this. This is the during operation of the tuberculous cell meningioma through the basal interhemispheric approach, like this. Yeah, also if you hold the suction like this, can be easily pushing. But if you hold like this, just adjust to the field and then stable, not to pushing, like this. Okay. And then if you hold the micro scissors like this, we can observe their tips. Like this. Yeah, this is crystal style micro scissors, fairing. And then, like this, yes, I move from left to right, but just a turning of the rotating the wrist. So they very freely to use the micro scissors like this. So of course, we need active use of normal cerebellar function and the proprioceptive function, and also image training and training of basic movements. I think this maneuver is crucial under the microscope, but now exoscope we can use the almost the same concept we can introduce to the exoscope surgery, but endoscope is quite different. So if you start the microsurgery, please hold the instrument very carefully to get the wide and stable movements and free movement. Thank you very much for your attention.
Thank you very much. Speaker is Dr. Kenji Ohata, surgery of cavernous sinus meningiomas.
Whilst we're getting ready for the presentation, I said invite all the delegates to visit the stalls. They're on the first floor in room CJs. During lunch especially.
Okay, thank you. So thank you for giving me opportunity to talk about my surgery regarding cavernous sinus meningioma. This is my life work. So this is a classification of the cavernous sinus meningioma. Some secondary cavernous sinus. This is extending from the spinal ridge towards the cavernous sinus. And this is a secondary one from the middle skull base. And this is a secondary cavernous sinus meningioma from the petroclival meningioma or ship angle meningioma. And true primary cavernous sinus meningioma is not so common, and expanding the cavernous sinus, and then it's protrude extending to the any way regarding based on the its nature of the tumor. So mainly we have encountered the secondary cavernous meningioma like this. This is a spinal ridge meningioma. We removed this part outside the cavernous sinus, and the tumor left behind. And tumor in the cavernous sinus, if grow, is act as a real primary cavernous sinus meningioma. This is a petroclival meningioma is also same. Tumor, if left behind the cavernous sinus, usually we left behind the tumor in the cavernous sinus, we leave observe the patient, it's act as a real primary cavernous sinus meningioma. So treatment of cavernous sinus meningioma, there's two topics. First is a relatively small symptomatic primary cavernous meningioma, mainly treated by gamma knife, as you know. And second, treatment has some difficulty in case of recurrent meningioma after gamma knife or SRS, or in case with symptomatic non-small tumor. How to treat this one? So subject of this talk is to describe how to remove the meningioma from the inside of the cavernous sinus with functional preservation of the cranial nerve. This is a most important topic for nowadays for all skull-base surgeons. So this is a publication from my department by Professor Akira Hakuba. This is a famous publication with zygomatic approach. He describes the Hakuba triangles, and the Parkinson triangle is also available. This is a geometric drawing. This is an epidural approach, and we can enter to the cavernous sinus using a lateral door. Let me say anterior door or anterior lateral door. This is very small space. And this is, I want to show one nightmare we operate 30 years ago. We have gamma knife already in Osaka, but we couldn't really believe the efficacy of the gamma knife. So this is a 45 years young female with third and fourth nerve palsy. We operate this case 30 years ago with orbital zygomatic epidural approach.
In this case, we expose a lateral wall of cavernous sinus. I want to show what's happening. This is an orbidozygomatic sub middle fossa approach. We drill the anterior petrosinus, anterior part of petrosal bone. This is difficult to explain because so many blood here. We try to remove the lateral part of the cavernous sinus, and then this is a Meckel cave here. We open the Meckel cave, and then what happens is we injure the meningohypophyseal trunk. So this is a very dangerous part. So we coagulate this part, but we further we couldn't stop the bleeding. So we what decided was we perform the high flow bypass. This is at midnight. Midnight we perform the high flow bypass. This is a nightmare. We clip the internal carotid artery at the petrosal segment, and then we perform the high flow bypass finally. So this is, most dangerous part of the cavernous sinus meningioma surgery. This is after bypass. This is after operation. Fortunately, carotid artery is patent and high flow bypass is occluded. Patient has a total ophthalmoplegia. 30 years ago, patient come to my clinic from Yokohama. Patient looks very happy because no recurrent at all. This is summary of outcome of the cavernous sinus meningioma when we treat we use anterior or anterolateral door to enter the cavernous sinus. There are so many complications regarding the cranial palsy. So nowadays, we don't like to use anterior and anterolateral door to enter to the cavernous sinus. That is why outcome is very nice. So current strategy of cavernous sinus meningioma is there is three entrance. Anterior or anterolateral door, it is very small door. And posterior back door is very wide because cranial nerve is scattered in the posterior part of the cavernous sinus. The other way is to use a medial or inhaled door using endoscopic endonasal approach. I want to show of course, one of the typical case of the sphenoid meningioma invading the cavernous sinus. This is a relatively large one. But if you carefully observe the cavernous sinus, tumor is a bit invading the cavernous sinus, so we can preserve the all cranial function. I want to skip this operation. So this is next one is possible access route to the cavernous sinus is endonasal approach. So now this is very good because we can avoid cranial palsy because there's no cranial nerves around the inferior door or medial door, but we must pay all attention to not to avoid the carotid artery injury. This is a calculation from the department. We developed the posterior crinoidectomy approach. We should open the base of the skull for the safety entrance to the tumor around the cavernous sinus. This is a very good approach. This is one sample. This is a primary cavernous sinus meningioma. Of course, total resection is difficult. Some parts of the piece of tumor left behind lateral to the cavernous internal carotid artery, but the decompression is perfect. So third one is using through the posterior back door to enter to the cavernous sinus. This is I recommend this entrance using back door of the cavernous sinus. This is a very wide cranial nerve scattered. This is small, relative small cavernous sinus meningioma. Door is very wide. We report this technique in the JNS neurosurgical focus already. This is a compass concept of the posterior enter to the common sinus through the back door. This is a sigmoid sinus, transverse sinus here, trigeminal nerve here, seventh eighth nerve. And this is a normal anatomy guided operation. You can expose the trigeminal nerve around the brainstem. If you follow, this is seventh eighth nerve as well. If you follow these normal structures anteriorly, you can naturally enter to the cavernous sinus and you can remove the tumor safely. Of course, there is a limitation. Of course, tumor around the carotid artery is dangerous. As I mentioned, meningohypophyseal artery must be protected from injury. This is a small case, 44-year-old female with right oculomotor nerve paralysis. How to treat this case? This is small case. Maybe most of the doctors send the case to the gamma knife or SRS, but our decision is rejection. This is a patient has oculomotor nerve palsy, very young. We use a transpetrous approach. This is an operation by Professor Goto. This is a right-sided transpetrous approach. Now, trigeminal mercury cave is already open. This is fourth nerve followed anteriorly, and this is a mercury cave is opened. As I said, back door is so nice to enter to the cavernous sinus. Now we are close to the internal carotid artery. We must avoid any injury to the cavernous sinus, including the hypophyseal artery. So we use Doppler to localize the internal carotid artery. And now we are looking for the oculomotor nerve. This is oculomotor nerve here. This is a normal anatomy guided operation. So if you follow this normal anatomy, this is oculomotor nerve. Of course, part of a tumor in the anterior half in the cavernous sinus must be left behind. Otherwise, you may damage the internal carotid artery. So this is an outcome. Of course, tumor left behind in some part of the cavernous sinus. But patient oculomotor function getting better, so patient are free from any diplopia, and we tightly, closely observing this case. This is a large one. In the 38-year-old female, this is a large one. Of course, selection is transpetrous approach. This is, and I want to show the stages of operation using transpetrosal and endonasal endoscopic approach, stages of operation. If you carefully observe this MRI, there's a ligament intact. This is a normal anatomy. Guided operation is available as well. So this is a ligament around the oculomotor nerve, guide us to the normal anatomy. So we use a posterior transpetrous approach. We enter to the cavernous sinus using a back door. Back door is same, regardless of the side of the tumor. This is a posterior cranial ligament. This is a third nerve. This is for your orientation. Around the internal carotid artery, we must be carefully dissect the tumors. This is a petrocranial ligament. Guide us to the normal anatomy. Tumor is big, but the ligament is as it is, as like a cranial nerves. This is a final part of the tumor. Dissection. Professor Goto is operating for me. This is a trigeminal nerve. This is the final stage of operation. So this is outcome after the first operation. If you carefully observe, there is a tumor left behind the inside and medial side of the cavernous sinus. So how to treat this radial tumor? This is a 38-year-old female. There is a still tumor left behind in the cavernous sinus. So our decision is endonasal endoscopic approach. This case is also operated by Professor Goto using a posterior colonidectomy approach. This is a very nice approach. Even in the endoscopic approach, we can widen the entrance to avoid any injury to the cavernous sinus and or structures inside the cavernous sinus. So this is also the normal anatomy guided operation. So of course, total resection is impossible. Of course, we must earn the time for the patient. Patient is 38 years, very young female, so we can earn the time to start the gamma knife. We can wait. This is the final stage of operation. This is outcome. After first operation, after second operation, of course, some piece of the tumor left behind inside the cavernous sinus. So we first use the back door, secondary with medial door. So medial door, back door is very good door to enter inside the cavernous sinus. This is outcome. This is second operation, patient oculomotor function getting better. Patient are happy, we are happy. And this is a summary of the cases, the pre-operation, post-operation, pre-operation, post-operation, pre-operation, and post-operation. This is a summary of the 9 cases we published in the journal Neurosurgical Focus 6 years ago. Concept is same. I recommend to use back door and medial door, inferior door. Don't use anterior door or anterolateral door to enter to the cavernous sinus. Thank you very much for your attention.
Thank you, Professor Wahata, for such a beautiful presentation. We'll go on to the next talk by our dear Professor Atul Goel. He's going to talk on AVM surgery, one of his very favorite talk.
If you really ask me which surgery stimulates you, which surgery titillates you, this is a dangerous word, titillate. What is the meaning of this, Keki? Titillates? Keki? Sridhar, what do you think? So AVM surgery, in my view, is the last chapter of neurosurgery. You need not only anatomical understanding, you don't need only technical understanding, you don't even, philosophical understanding. What is most important in AVM surgery is understanding your own self. Understanding the fact that yes, it can be done before operation. You have to know, yes, I can do it. No, I cannot do it. This understanding cannot come with, hyperinflated ego or overconfidence and yeah, like this. It has to be absolute realistic. Now, this is one AVM before operation. You have to study this AVM beautifully, here, there, not in 10 minutes. Oh, yeah. You have to study this for 10 hours and then come to a conclusion, no, it is not possible. Yes, it is possible. So AVM surgery, in my view, there are 2 treatments. One is either just leave it. Second is operate and remove it, because operation is a curative. You cure the person. I will not argue on gamma knife because Manjul is sitting and he has done some fantastic work. We will hear what he has to say. So in my view, this partial, repeated, multiple embolizations are no good. Gamma knife here and there is a controversial thing. AVM is a surgical issue. The art of surgery has to be learnt. It has to be learned over several years, and then you have to assess. So AVM surgery, AVM can be in a frontal lobe. This AVM is a relatively straightforward. This is in the parieto-occipital or posterior occipital lobe. The issue is this nidus has aneurysm here, aneurysm here. When there are aneurysms, it means it is a high flow AVM. When the patient comes with headache, it is a high flow AVM. When a patient comes with a bleed, it is a high flow AVM. When the AVM has large blood vessels, it is a high flow AVM. The other issue comes is when it is located in a critical area, like in the motor area, speech area. These are difficult AVM, and the patient comes with convulsions, only convulsions. This kind of nidus in the depth is one has to think whether he can do it or whether he cannot do it. And that realization has to be from the depth of his heart and mind and soul, because you're not allowed to do just experimentation on the patient. Also, you're not allowed, if patient gives consent, okay, doctor, operate, I have full faith in you. Don't go with that. Consent means nothing. Patient says, okay, doctor, do it. That means nothing. You have to know whether that doing is possible or not. So surgical grading, this is my grading scale, easy. There is nothing easy in AVM surgery, difficult but safe, very difficult and risky but possible, not safe or not possible. So this is my grading scale. What is important is where is the AVM, how many vascular territories are feeding. Most critical issue is the degree of flow, how high flow the AVM is, and there are many features which give us an indicator high flow AVM, not so high flow. Most important is you see the angiogram whilst it is being done and you will realize whether it is high flow or slow flow. So this is the AVM. Now, most important issue in this AVM is to understand whether it is intraventricular or extraventricular. If it is intraventricular, the surgery is relatively straightforward. If it is extraventricular, it is impossible to operate. So we made these kind of models. Long time ago, this model was made for this case in particular, and then this DTI imaging showing the AVM is completely intraventricular. So the whole life of AVM surgery changes. So for the first time in the literature we made, even before Japanese, the king of technology, we made these models for the first time in the literature of AVMs. This is the AVM. You make this model. You keep the model in front of you during surgery, keep on moving it, keep on understanding it, and then you can make quite a number of interpretations from these models. Then this is not a color-coded model, but we subsequently are trying to make color-coded models. So that you can hold in the hand, identify where is the AVM, and then, AVM surgery is a difficult situation. So this kind of AVM, we made this model. Now here is this patient. This patient comes with severe headache. You see, she is holding her head, and this is quite a largish AVM. Now the question is in front of you, whether it can be surgically removed or not. You have to think about it. And if you cannot remove, say no. That decision has to be made by you, by the surgeon. And this is the large AVM, and this was obviously operated. This is the AVM, and this AVM removed. And you see the smile. Essentially, you have cured the person. You have given new life to this person. This is another AVM. I have been showing this AVM since last 20 years. And this was a farmer, young man, and I told him, no, I cannot operate this. He had only headache and giddiness as presenting symptom. I sent him home. He comes back after 6 months, and then he says, doctor, kill me. And I took him. You see this? And I said, come, let me try. And this AVM was removed. And this farmer is quite a farmer now. And this farmer has produced already 3 children, and all of them are farmers. And this is my contribution to the farming industry of this country. This was another huge AVM. This was also a young boy. You see, I like to call this AVM as ball of fire. Now, there are various good points. You see, this looks quite horrendous. Good points and bad points in this AVM. You have to really study this AVM in a three-dimensional perspective. Some good points like area of the brain, some bad points like big aneurysm inside the thing, and this is the AVM during operation, and this is the AVM after resection, and this is the boy. Cured, so new life. Possible or not possible, that we have to see before operation. This is another patient, IIT engineer, IIT Indian Institute of Technology, very precious institute of this country. Only problem is epilepsy, fits. Now the question is whether you want to operate this AVM for convulsions. You're not even sure whether convulsions will be controlled after surgery or not. This is not such a difficult AVM as you can see. It's quite a, but still it is an AVM which is difficult, and this was removed, and this is completely, this guy, IIT engineer now, settled in US and doing phenomenally well. This is another AVM in the region of vein of Galen in the circulation. This is also long time ago I had done. What is more important is learning the art of interhemispheric approach. Interhemispheric. You come interhemispheric, get to the anterior cerebral artery, that is one. Second thing is go to the PCA. That is number two thing in AVM surgery. Most of these AVMs will need interhemispheric approach. Now PCA feeder, you have to get it above the tentorium. Get the PCA, get the ACA, and then you can remove. These are difficult issues, but these are the necessity. You see, this is the PCA, large PCA feeder. If you can get this, if you know how to get this PCA feeder, then you have learned half the AVM surgery. You see this quite a large PCA feeder. Then you come interhemispheric, get anterior cerebral, get PCA feeder, and you have removed this AVM. And you have given new life to this person. Then you say, I will do embolization, I will do partial emboli, I will radiate and all those things. That may be good, may not be good, but this patient can be cured. Now this looks quite a simple AVM. Posterior parietal occipital AVMs are common. Looks simple, but you see this is fed by PCA, this is fed by MCA, this is fed by ACA, this is fed by the contralateral ACA, high flow AVM, like, and this is one of my more difficult cases, but we removed. This is another AVM. So let me just show you, because you know time is a constraint and I don't want to just go on and on. PCA, my friend, get to the PCA. You see this is majorities of PCA. Interhemispheric, come over the tentorium, get the PCA there, and then you can go further, and this was removed. This is another AVM flow. The AVM is here, anterior cerebral artery. How to get, and all those things are technical issues. This is another AVM which had bled. You see this patient had come bled, drowsy situation in the depth, and you know you have to decide whether you can operate or we cannot operate, and after a lot of deliberation we came to the conclusion, yes, operation. See, when I say we came to the conclusion, you see it is not we, it is I have to come to conclusion. The surgeon has to come to the conclusion. So, you know, when we operate, it will bleed here, bleed there, bleed there. You know, surgeon will be highly criticized during operation if he is not able to control that bleeding. The art of controlling bleeding is the life of a neurosurgeon. The entire, let me see if I can show you at least some part of this AVM. Now you see the AVM surgery is wide exposure, both anterior cerebral artery, both posterior cerebral, both optic nerve, contralateral MCA, come to this area, get to the feeder, coagulate and cut. Wherever there is doubt, you have to put temporary clips. It is the art of controlling bleeding. It is the art of controlling heavy bleeding. It is the art of controlling bleeding from more than 1 point. You see, what I'm showing is maybe just edited here and there, but sometimes it will bleed on your throat and on your neck. You have to just go on, and you have to just go on and on. You cannot stay during operation, no, I'm sorry, I cannot do it. You kill the person. You cannot take the most important issue in AVM surgery is identify normal from abnormal. If you take one normal vessel, you have killed the person. You have made hemiplegia. Most of these patients come with only headache. They come with only giddiness. They come with only some epilepsy. Some patients come with bleed. That does not mean anything. If the patient comes with bleed, that patient will recover eventually. So many of these, these are difficult problems. As I have said, this is the last chapter of our subject of neurosurgery. But this is a beautiful chapter and it remains, and there is a possibility of giving new life. Some of these Sylvian Fisher AVMs look very horrendous, but if you can get them, you can really get them. This AVM, you see, like now you have to identify where is the feeder coming from anterior cerebral artery. Controlling large blood vessels is one issue. Controlling small blood vessels is another issue. If you ask me one point, what is the key issue in AVM surgery? I will say that identify small blood vessels bleeding. Don't start coagulating that vessel. If there is a small vessel bleeding, go to the mother vessel. That small vessel will lead you to the mother vessel, which will be large vessel. Coagulate that. If you waste your time in small vessel, you can never complete AVM surgery. And that will be an issue. This is the huge AVM which was removed beautifully. This is embolization, preoperative embolization. I work in a very heavy embolization department. Many of the AVMs are already embolized and they come to me. I will say preoperative embolization can help here or there, but not tremendously. I don't like preoperative embolization if it comes, virgin case comes to me. So this is post-operative. This is another AVM I did several years ago. Very high flow AVM. You can see this AVM, large vessel, large jugular bulb, everything is large about this case. Patient comes with very severe headache. And when there is headache, high flow. When there is severe headache, very high flow. When there is bleeding, patient has come with, this is the patient after several years of surgery. This is another beautiful, let me just, tentorial AVM. This AVM was another nightmare for me during operation. But this AVM, referred to me by a very important, not very important, the Union Health Minister referred to me. Sushma Swaraj was the health minister. She says, I have heard about you and this and that, and I became inflated. And I said, yeah. And ultimately, I operated and created a bad hemiplegia in this patient and aphasia. And I regret to this date of my life whether that phone call from that health minister made me operate or whether I would have operated it otherwise. But this guy has improved. This was a BJP fellow. He still says, Jai Shri Ram, but nothing else. And I said, you are fit for BJP, enjoy the BJP. And this was the post-operative situation. Patient comes with motor strip AVM with a bleed. This patient comes with a hemiplegia. Earlier in my business, I used to wait for 3 weeks or 4 weeks, this patient would recover in hemiplegia. Now, if I have decided to operate on this patient, now I operate early in the business. Because if there is hemiplegia before operation, if it remains, then you are not at least blamed. But if the patient has recovered, becomes hemiplegic, you will be blamed. So now my strategy is to operate early in motor strip AVMs. This is another motor strip AVM removed. Another one removed beautifully. This patient has some weakness in the hand. And this patient, for the first time, we described contralateral intrahemispheric approach to remove such an AVM. This is rather straightforward. This is another AVM in the motor area. So you see, recently I published my series of large AVMs, more than 4 centimeter, largest series published in the literature. Just 2 months ago, this article has been published. So this was the model that we made, and contralateral interhemispheric approach in this young. If the child is young, the surgery is relatively simpler AVMs. And this was my approach, contralateral, which was published in my book in 1997 with Hongo. And this approach is being followed. But as has been usual, this is one letter to editor for Michael Lawton's article. I have got more than 100 letters to editor because my approach was not discussed by the author. So I am one author who has written the maximum letters to editor because the other author has not referred to my, so this is my life of neurosurgery, contralateral, get to the artery, get to the vein. This is another beautiful AVM near the vein of Gallant, going in the velum interpositum. Your anatomy has to be perfect. If you don't have the anatomy, don't even try to think about this. But you see this anatomy and this dissection and all those things are possible. This is another one. Now this patient also I have shown in several occasions, huge AVM, and this was on the left side and I removed it. Now I removed it, but this man who was a shopkeeper, now the problem is he has severe parietal lobe sign. He is not able to calculate properly. He cannot, he was not able to talk properly, but now he is all right. He cannot calculate. So he was running a kirana shop. So this fellow comes to me with his family and he says, I was asking him, how are you and this and that. So the family, somebody says he's not able to calculate. I said, for a kirana shop fellow, if he's not able to calculate, it will be a big problem. But that his brother told me, but whenever he calculates, when he is dealing with money, he keeps more money always. Calculation is always for us. I said, enjoy the calculation. And he is calculating. This is another with left side, only epilepsy. Control epilepsy. This is a very high flow AVM that I had done. This is another one. This was another one. This is a temporal AVM, and here in the temporal AVM you have to save the middle cerebral artery, but you see here the middle cerebral artery is not seen after surgery, but there was no real deficit in this patient. So this is another one. This is another one, I'll tell you. This patient was a nun. Sridhar, nun. Nun means that Christian lady nun. And I was operating and there were huge, means about 200 nuns in the, not 200, but at least 30, 40 nuns in the hospital. And I said, today, my dear friend Atul Goyal, it is all or none for you. And it was, this was the surgery and this was the AVM removed and this is, so I just, time is an issue. This is another in the motor strip. This is another patient I operated several years ago. Patient young boy became hemiplegic after surgery. But his hemiplegia has completely recovered and he's quite active. This is another patient with very marginal symptoms. So you have to decide before operation, yes or no. That decision. Another thing is, patient comes with a bleed, I never do decompression. Decompressions, I have never done decompressions for, at least for such a situation. Now this patient had come to me with a decompression, clot was removed, this was the AVM, I removed the AVM, replaced the bone flap. So I never do this kind of, this patient comes to me with, in an unconscious condition, and I thought, let me just do it. And but I must tell you, I removed this AVM, but this patient never survived and he ultimately died. Posterior foci AVMs are a little bit better and I have got a big series of posterior foci. This is of course PCA, tentorium, basal. This is a posterior foci AVM. This is another posterior foci AVM. This AVM was a mathematics teacher, this man. And I operated, he became unconscious after surgery, decerebrate and all, but recovered, and very soon recovered. Now he's a mathematics teacher and he keeps on, his wife keeps on troubling me, he's having headache and he's having this and that, but he continues to be a mathematics teacher. Okay, my dear friend, finish. Intraventricular AVMs are more dangerous, more easier. This is temporal AVM, this is velum interpositum AVM. And this was post-operative. Intraventricular AVM, rather relatively straightforward. And this was another beautiful beauty. So I am having some beauties, and I must also tell you that I am having some difficult. These are my trophies. I like to show them. I have done it. See how beautiful, how beautiful. But there are potential complications that you have to realize and that you have to understand, and you have to understand because we are dealing with human beings. We are not, artists. We are not showmen. We are performers, but we are performing for the interest of our patients who are our life, and you have to do it properly. So AVM surgery has been one big beauty. This is another pile AV fistula, and we have things like that. So thank you very much.
Thank you, Professor Goel, for an astounding AVM story. Thank you. There is going to be no discussion in the interest of time. So on behalf of my co-chairs, I'd like to thank all the speakers for a wonderful session. Thank you very much.
Thank you, chairpersons, speakers. Sorry, I'm a little late here. And now it's a lunch declaration. And let's reassemble here at 2 p.m. sharp so that we can stay on time. It's a wonderful next session, cerebrovascular session, the gorgeous but delicate.
कपड़ा खराब मत कर देना, जापान से है। ये निकल जाएगा ना? नहीं निकलेगा। मतलब हाँ वो निकल जाएगा। क्या फालतू में
नहीं तो
पटका लग जाएगा।
सिरा एक काम करो ना, आनी ऊपर मारो ना, सिरा सर टेप मारो ना, टेप ऊपर मारो, टेप मारो ना, टेप ऊपर। सिरा सर के साथ रह के थोड़ा थोड़ा सीख गया हो।
आया सतीश भाई?
इधर ही दिखा कर लो प्रोजेक्ट। ये तो फोटो है भी नहीं डेस्कटॉप को, कहाँ से
देना नहीं है डेस्कटॉप, स्क्रीन पे नहीं देना।
नहीं नहीं स्क्रीन पे
वीडियो चलता है क्या देख। सब मत दिखा, वीडियो चलता है क्या देख। वीडियो चलता है क्या देख।
ठीक है।
बाद में है क्या?
आपने कहा ना लास्ट में डालो बीसीएलआर वाला।
रिजल्ट्स के बाद डालो।
हाँ रिजल्ट्स बाद में ना,
केस के बाद ही।
हाँ रिजल्ट्स अपने रिजल्ट्स कंक्लूजन। ठीक है ओके दादा निकाल लो। ये कैसे आती है फोटो? ये तो मेरा डेस्कटॉप पे नहीं है। कौन सी फोटो? नहीं
ये वाला हाँ ये वाला
भाई देखो जरा आया क्या एक सेकंड स्क्रिप्ट नहीं आ रहा
आधा आ रहा है
लेट्स पे करना पड़ता है
आगे मैं इसको बंद कर दूं बंद कर दूं 11
Good afternoon. After this very fulfilling gastronomic session, I think now it's time to feed your neurons again. So we are going to the next session today. The session is cerebrovascular session, the gorgeous but delicate. I think it should be gorgeous and delicate. So chairpersons are Dr. Vernon Velho. I request the chairpersons, Dr. Vernon. I'll give it to you, sir. And Dr. Sumit Sinha. The discussants for this session are Dr. Aip and Dr. Ishiro Nakagawa.
Okay, so a heavy afternoon lunch, post-lunch session, and that too as cerebrovascular. So I can imagine. To proceed with the talks, we have the first speaker at our hand, Dr. Paratosh, who will speak on revascularization techniques in modern cerebrovascular diseases. Dr. Paratosh, please.
First of all, thank you very much, sir, Dr. Goel, for this kind invitation. I don't see it here. Possible? Okay, fine. Thank you. Yeah. So once upon a time, this cerebral revascularization was one of the prima donnas of surgery, which has now been replaced by, as Professor Goel says, AVM surgery in cerebrovascular. But there are still some indications, despite being hammered by both evidence-based medicine and being by the endovascular treatment. So, of course, we have flow augmentation and flow replacement here. Present indications, the majority of the present indications are ischemic diseases, out of which large majority is moya-moya disease. And then there are some carotid occlusions, arteriopathies, and dissections. And hemorrhagic indications are very, very few now. For STMC bypass, for aneurysms, high flow bypass, very rarely the other bypasses, and all of them have been replaced by different form of endovascular treatments, especially after the advent of flow diversion. So first is, I would just give 3 examples of these things. First is moya-moya disease, which is quite prevalent nowadays in our country because of increased recognition of this disease by neurologists and the physicians. And our preference is always combined revascularization, single STMC bypass, never a double barrel, and with indirect revascularization. We do it both ischemic and hemorrhagic disease. Indirect only when inadequate recipient in MCA and bilateral surgery 4 weeks apart. So this is a 38-year-old lady, multiple TIAs left more than right, and collaterals from posterior circulation, inadequate cerebrovascular reserve on SPECT. And this is the typical surgery. So this is how it was done. So this is the M4 branch. We take the sutures on heel and stitch before we clamp the artery so that we can reduce the occlusion time. Then there is, we open the artery, the toe stitch first, and then the heel stitch, the second one. Because it is already tied to the ST, it saves some time. In adults, I don't shy away on doing continuous sutures. In pediatrics, almost never, but this is continuous sutures taking on STA to MCA for the end to side anastomosis. And these are 10-0 ethylon sutures, as everybody knows here. We try not to handle the M1 MCA vessels too much, but sometimes we have to. So this is the one side which is done. And then we go to the other side after the inspection that there is no back suture there. So the MCA looks quite clean. And this part of the anastomosis we do either with continuous or interrupted sutures, depending on how we feel like it. We also train a lot of people, so a couple of residents or fellows take one month sutures here. So we have to do the not interrupted sutures and not the continuous sutures. So I've left a couple of some place there so that the resident goes and does this thing. And then we take off this distal first, then proximal, and this is how the anastomosis is. And this is the postoperative angiogram. We see that the STA has hypertrophied here and is filling in the entire thing. We can do it for aneurysms, very rare these days, but this is one of the patients investigated only for Marfan syndrome, very tall guy, and this is what they found. You see there is MCA filling, MCA vessels coming out of the aneurysm. It is calcified hard here, and this is the MCA. So it was tried, intervention was tried, but it was not successful, and that is why we took this patient for the bypass here. So what we have done here is surgical flow diversion. So this is we're opening up the Sylvan fissure. This entire thing is aneurysm here. You see both of these branches are coming out of this aneurysm here. This is the branches which is coming out of the aneurysm here. And this is another branch of the aneurysm which is coming out of the aneurysm here. And this patient is completely well preserved. So we did not want to open the aneurysm because then it will be a ruptured aneurysm rather than unruptured. So this is the STA which is coming here. Good flow. Again, we have done the same thing, STA to MCA bypass here. And I will take off this thing. But I will show you one thing, that on ICG, the entire circulation is filling despite clamping of the proximal one. So this is the end of the anastomosis. After which ICG is done, and all the branches are filling here. Now I could not go to the proximal end of the MCA here, and that is why this was the end of this surgery, and we did not do anything either proximally or distally. So only STA was there. As it is, the aneurysm had very, very sluggish flow, and because we have done a flow diversion, the flow diversion away from the aneurysm, that is why everything has thrombosed after 6 months. So this is how it looks after 6 months, and this is the revascularization which is there. So this is how it is revascularized. Sometimes we have done, before this, we have done in situ bypass. So you can do an in situ bypass, you can anastomose this to this, and then it becomes a clippable aneurysm here. I don't have the video of this, but this. Pica aneurysm, long back we have done this. Now this will be treated by a placement of flow diverter here, and it will be fine. But at that time, flow diversion was not much in this. So we have done a side-to-side bypass of the pica and connected both of them, and then we have gone ahead and occluded the vertebral artery with the pica itself so that the patient does not have pica infarct. But now many of these will be treated with this. In side-to-side bypass, first the inferior wall. We have to remember that all the sutures have to come from, have to fall outside and not inside the lumen of the aneurysm. So that is why, that is something that we have to be very careful about. And once we have done the inferior side, the superior side is much easier. It is not a problem at all. But the inferior one is a little more difficult here. The problem here is that both picas are at ischemic risk for these aneurysms here. So if you take 30-45 minutes for these anastomosis, then both picas are occluded, and that is why there should be good collaterals there, and that is the problem of this side-to-side bypass, both in ACA and MCA. So this is final H which is formed, and then we can go ahead and do this. So our experience over this thing, little modest experience of majority of the cases are moya disease, as we'll see. Some of them are carotid occlusions, high flow bypass, in situ, STMC bypass, and others are there. So more than this, I'm very glad to note that bypass surgery has become very widespread in India. 20 years back, when Dr. Suzuki had come to All India Institute, hardly 2 to 3 centers were performing these surgeries. Now almost 50 or more centers are performing. And microvascular anastomosis courses are held regularly in this country with NSI, academic institutions like AIMS and NIMHANS, and there is a very widespread interest among surgeons to learn these techniques. So revascularization surgery must be learned by anybody who wants to do cerebrovascular surgery. STMC bypass is the workhorse, and it's not a very difficult surgery once you get the full nuances of it. And good technique and attention to details will lead to excellent outcomes. Thank you very much.
Thanks, Dr. Paratosh, finishing well ahead. So we'll save, do we have the discussion in the last or? We will have the discussion in the last? Okay. So thank you. May I invite Dr. Ellen Tripathi for his talk on multiple brain aneurysms management.
Good afternoon, everyone. Thank you, Atul, Abhida, and the team for invitation again. I'm very happy to speak on this Indo-Japanese friendship. And I'm very proud that I'm a good friend of Atul. So both friendships will work here. And in this context, I thought that let me talk something different, which is multiple aneurysms. I mean, we know how to treat aneurysms. Of course, there are a lot of controversies. But how about multiple aneurysms? What are their special features? What are the different things that we do in multiple aneurysms? So in the course of next 9.5 minutes, I will take you through this. So we know the locations, could be anterior circulation, posterior circulation, and traditionally anterior clipped, posterior coiled, or depends on your choice. So what I went through literature, I found that it can range from 10 to 30% of cases to have multiple aneurysms, more than one aneurysms. The point is that if you have a patient with multiple aneurysms, the 2.5-fold risk of rupture and almost twice the risk of enlargement as compared to a single aneurysm, which necessitates aggressive treatment as far as the size is concerned, if it is not ruptured. And if patient is young, smoker, hypertensive, and the aneurysms, even they are 4 millimeter or more, treatment should be considered because they are high chance of rupture. Now the point here is, which one has bled? Traditionally, again, the size, the largest has bled, not necessarily always. The distribution of blood in the CT scan, irregular fundus, or teat sign or nipple sign, spasm in the parent artery, or recently contrast enhancement of aneurysmal wall. In contrast enhanced MRI is one indicator to show that that aneurysm has ruptured. If you have still doubt, I haven't done any in our series to prove or disprove the rupture, which one has ruptured. Now, if the unruptured aneurysm is incidental, to treat or not to treat, there are regular, principles to treat, which to treat, and everything else is sort of, we all know that. Clipping coiling is an accepted controversy. I'm not going to discuss that this talk. And whether you do one stage or staged depends on whether it is unilateral, bilateral, same artery, or anterior and posterior circulation. There are various factors to consider in each individual case. Now I mentioned about the contrast enhancement in the contrast MRI, anterior, the aneurysmal wall enhancement. Cigarette smoking, we all know, this is the risk factors, especially working age women, high chance of multiplicity and rupture thereof. And of course, people with hypertension tend to have more multiple aneurysms than not. Now, some examples, you can see that this is anterior communicating, which ruptured, but there is a V4 aneurysm which picked up by the clever radiologist. Of course, we would have noted it, but when I was going to clip it, he said, sir, there is one more there. And I said, don't worry, this is a small one, we'll observe it. So this is the subarachnoid hemorrhage this patient presented with, and we clipped, and then we are following the V4 aneurysm, microaneurysm. Now, sometimes the aneurysms can be metachronous. This gentleman had clipping of anterior communicating aneurysm in NIMHANS 21 years earlier, and then recently presented with the subarachnoid hemorrhage, and this was due to a basilar aneurysm, basilar top, and the patient wanted to go for coiling. So this is coiling, and he required an EVD before he had because he had hydrocephalus. So it can happen. So we need to follow them up with follow-up angiogram. So no age is, no duration is long enough to prevent another aneurysm or another rupture unnoticed. due to the follow-up problem. So can you clip aneurysms at the same sitting? This gentleman had bilateral aneurysms, and depends on how the patient is responding. Now, how is your result? Depending on that, you can clip the aneurysms if it is bilateral in the same sitting. And this lady, especially from Bhutan, came with a ruptured left pica aneurysm, posterior communicating. I clipped that, and incidentally, we found 2 more aneurysms. I see a right side, and then the vertebral aneurysm on the right side. So because she came from a remote place, they wanted her to stay. I think she stayed almost a month and a half, and I clipped 3 aneurysms, at the end of which she developed hydrocephalus. So because the right side had a craniotomy, retrosigmoid craniectomy, I had put a left-sided shunt. So and this is the day she was going home with 3 clippings and a shunt. So it depends on how the patient is behaving, how the results are occurring, so you can clip them at the same sitting. What about the aneurysms in the same artery, same parent artery? Now you would say that this is the bigger aneurysm, this might have bled than this, but actually the anterior communicating is notorious to bleed if it is there. And many times when I was training in England, I was told that if DSA, there was any doubt, you go and explore and clip the anterior communicating aneurysm. And that is, incidentally, as we know, is the commonest aneurysm to rupture, anterior communicating. But we found, we did a craniotomy, both intrahemispheric and terional. We clipped both aneurysms, and we found this one had bled, as corroborated by the CT scan finding. And we did use navigation at times to site your craniotomy, because sometimes, because of the curvature of the corpus callosum, you may be a little bit anterior, a little bit posterior. So navigation does help, but because of the curvature, again, it is helpful to angulate your microscope. The problem is bridging veins. So if you have bridging veins under control, go in between the bridging veins, like the myelotomy we saw Dr. Turel's, in between the vessels. So this lady I recently operated, she presented with a ruptured anterior communicating, but we found the middle cerebral, and there was something there also. So she basically had 3 aneurysms, and I will show you the video. The 3D CT angiogram does show it beautifully, but at times you will be, how to plan this 3rd aneurysm treatment, we will decide at this time of surgery. So this is a short video, and I just want to take you through, nothing special about it. So left-sided approach, left terional approach, initially planning to clip the anterior communicating artery aneurysm which had ruptured as per the angiogram and the CT scan distribution of blood, standard gyrus rectus approach. And so I do always, whenever there is a chance, I do always a proximal keeping. I'm a little bit, traditional teaching chap. I'm getting older, of course. And so this is the A1, left A1. Even after the A1 clipping, there was still blood flow from the right side. So when I was preparing for the final clipping, it ruptured. But I could control it nicely and then put a clip and could control the bleeding instantly and then release the temporary clip. So these are the standard teaching for our residents and younger surgeons, and there's nothing new in this. When I finish that one, I use Doppler and as well as ICG. The Doppler is very helpful because it shows you the flow. And I like to see the flow rather than the pictures, but both are helpful. And after that, we turn to, I wanted to see the other side A1. I hadn't seen that before. So a little bit of exploration, I could see that. I'll show you at the end with the Doppler. And then we turn to the middle cerebral aneurysm, which I already cited while Sylvian fissure was opened to give little space here after CSF drainage. And so the middle cerebral was straightforward, and it was in the bifurcation, actually trifurcation. And after clipping, this was the unruptured one. So after clipping that, a small clip, 5 millimeter, then I looked at the other suspicious microaneurysm, and you'll see how it looks in a short while. I just wanted to make sure it was not circulating from the other side. And then I turned it around and saw all the branches, and the perforators were intact. And then I looked at see the small microaneurysms. Now, it looks like a bleb blister, but it wasn't. So I tried using a mini clip or a fenestrated, but I was not happy because it was slipping all the time. So I did a little bit of coagulation, the typical traditional coagulation, and then put a little bit of cotton wool and wrapped it. Nowadays, we don't hear rapping. Because earlier, we couldn't do anything about this kind of aneurysms. We could rap. I'm going to follow it up. So this is just an example. And I checked everything and the papa variant going at the end. So nothing wrong. I mean, the thing is that how you decide about each patient is very important. And patients and relatives, they are aware of the alternative treatment of coiling and flow diverters. Parito showed very nice examples of how the flow diverter is taken over his bypasses for the aneurysms. I think the same story probably in most centers. And this is my humble experience of multiple aneurysms, 67. Majority of them had 2 aneurysms. And again, only 3 patients had 3 aneurysms. Majority in the anterior circulation by, not by natural selection, but by treatment selection. And then this is the distribution of the multiple aneurysms. They were bilateral. If they were same parent artery, I clipped them single craniotomy, single stage. If they were bilateral, in some cases, same sitting. Otherwise, we used to call them after 1.5 months or 3 months, whenever they recovered from the first subarachnoid and the first surgery. Anterior circulation, posterior circulation, very few. Metachronos, I showed you the example. We had a patient with SLE with multiple aneurysms. And I've seen that the also reports that the vasospasm is slightly higher, and the results by and large are comparable to single aneurysm depending on the grade of the patient. Thank you very much. I'm very happy to take questions at the end. Thank you.
Thank you, Dr. Tripathi, for a lovely presentation. We shall have the questions at the end of the session. I now invite Dr. Nitin Dange to talk on early endovascular flow diversion for ruptured intracranial blister aneurysms.
Good afternoon. At the outset, I would like to thank Professor Goel, Abida, and the team for this wonderful neurosurgical week and a platform. I also thank our senior mentors from Japan, Professor Hongo, Professor Kurishu, and Professor Ohata. Just to remind and just to appreciate, Professor Ohata was the one who instrumented me and helped me to go to Japan for my endovascular fellowship with the stalwart and the pioneer of intervention in Japan, Professor Nigoro. So because of him, maybe I'm standing here today and I'm sharing my experience with one of the unique and complex problem in vascular ruptured aneurysms, that's the blister. We call it as blood blister aneurysms. So there's no disclosures and all patients had consented for showcasing their cases in this presentation. So just to revise, what is a blood blister aneurysm? There's lots of confusion in the definition and how do we understand the naming and nomenclature of blood blister aneurysm. As the name in itself says that these are blister-like aneurysms. Many of us have earlier encountered many times earlier for surgical clipping, and some of us might have experienced while clipping it's so flimsy that it just bursts open and starts bleeding and there's a hole in the parent artery. So basically these are most commonly located in the supraclinoid ICA, but there are other locations like anterior communicating and posterior circulation. So this characteristically they are broad-based hemispheric originating from classically non-branching areas, instability, morphological changes on short-term angiographic follow-up, that's the problem, and they vary from day to day and they can present with recurrent bleeds. Fragility and tendency to rupture is the classical criteria and they also known to regrow. So how do we differentiate, and lots have been studied and data has been there regarding these blisters, and as we know nowadays, because of the advent improvement in the rotational angiography, especially 3D, these aneurysms are picked up more, and that's why the earlier incidence of non-aneurysmal subarachnoid hemorrhages, which are about 20 to 25%, is now going down because we are picking up these blister aneurysms. And we should have a high index of suspicion, especially when we are doing an angiography 3D, DSAs. So to look for these blister aneurysm, especially when the patient is symptomatic with subarachnoid hemorrhages. So just to highlight and just to understand the pathogenesis, there can be atherosclerotic etiology, hemodynamic stress related to the hypertension or any other reasons of the vascular stress. Arterial dissection is one of the causes which has been mentioned, and they can be a pseudoaneurysm, and few of the cases we have seen they keep on growing if you don't treat them. Some unique histopathological features is very, very important to understand. This slide tells you much about that. So what is the classical true aneurysms? And these are the blood blister aneurysm where there's hardly any internal elastic lamina or smooth muscles. There's a wall defect and the adventitia becomes like a fibrinous tissue, and there's a blood clot after the bleed, which we usually see while we do clipping. So as already studied, it's due to the supraclavicular ICM mainly on the anteromedial aspect, these aneurysms arise due to the tortuosity there, curvature, as well as the stretch which impinges, not at the arterial wall where branching is there classically for formation of the standard aneurysm, but this is like a unique way where because of the shear stress, they say that it can be a dissection and form aneurysms. So increased hemodynamic stress has been studied with computational flow dynamics, and that's how they have attributed or come to a conclusion that's the reason they can be formation. But as against our concepts, these are also seen in younger population as against the standard aneurysms which may be seen in elderly people, and they are little more preponderance to the female population. So diagnosis, as I just mentioned, it's very, very important to study and have a high index of suspicion, especially in subarachnoid hemorrhages, which may be at remote location also. But if you do a good 3D rotational angiography, it's very, very important, and study it very classically. And when you are suspecting to the side of SH, you have to do a rotational angiography for all 3 or 4 vessels whichever side you are suspecting, and not to miss such blister aneurysms. So what are the variable options? Even today, some of us might be clipping wherever there's no possibility or finance is an issue for endovascular treatment. So reconstructive techniques like clipping as shown in the diagram, primary clipping, wrapping, clip wrapping, wrap clipping, and direct suturing, all were done, and we know the morbidity and mortality in such patients with bleed during the clipping. So deconstructive techniques, they've said parent artery occlusion and bypass or endovascular means with or without bypass has been proposed and been done earlier. So what we used to do before the advent of this flow diversion, that was primary coiling, which was very, very scary because it was a flimsy thing and it used to just rupture. And putting a microcatheter was very dangerous because these were small aneurysms. Then stent assisted, telescopy, and diversion of flow were tried earlier also. But with the advent and availability of this new, I think so, revolutionary modality, that's the flow diverter, things have become very, very easy. Among all different available, flow diversion seems to be showing more promising results, and definitely over the period of last few years, it has shown that it gives a success rate of almost 95%. So what is the flow diversion? It's a concept very, very important to understand. We have to put this stent, which is like a stent in stent, which only diverts the flow from the aneurysm to the normal circulation. So you have to cover from proximal to distally. So you can see here, it is a very important, the wall apposition is very important, the sizing is important, as well as the covering of the neck from distal to proximal. Both sides is very, very crucial, and that's the key and the skill which is very, very important while deploying a flow diverter. Things have become easier because the technology, the deployment, the advent and evolution of these flow diverters, every day they are becoming better and better so that the outcomes are very good. But the concept itself has revolutionized the treatment for complex wide neck aneurysms, similarly for blister aneurysms. So our experience, for want of short of time, I am just rushing through our cases. It was to understand the efficacy of endovascular treatment as compared to the previous available modalities and to study perioperative, intraoperative, and postoperative complications. So we analyzed around 21 cases which were ruptured intracranial blister aneurysms in the last 5 years, and the mean follow-up is around 16 months. All patients were treated with flow diverter. So every patient underwent a 3D rotational angiography, and that's how it was very important to understand and identify the problems, and that's how we convinced them for endovascular treatment. So we had a strategy to load this patient on table just prior to after taking a puncture, after an anesthesia, and then this was the double antiplatelets regime which we followed, and then we went ahead with standard approaches, which is a triaxial system. Initially there is a 8 French guide catheter, then the intermediate, and then we use the microcatheter and wire to deploy the stent. I'm just coming to that very soon. So this is just a representative video which shows that this is a 3D rotational, how well you can understand, and it's very important to identify this blister aneurysm. This was a ruptured case with a blister on the left side. There was no other aneurysm on the DSAs. And this is how we take the triaxial system. This is the intermediate support catheter. It's very, very important to have a good support so that the positioning of the flow diverter distal and proximal to the aneurysm as well as wall opposition is very, very crucial so that the principles of flow diverters are maintained. So just running through the cases, few of our cases. This was a blister aneurysm ruptured, very angry looking. Patient presented with subarachnoid hemorrhage. We have a follow-up of about 6 years with this patient. One of our initial cases, you can see here the flow diverter has been deployed, and this is a follow-up. And you can see a follow-up angio where the aneurysm has been disappeared, as well as there's remodeling of the vessel, plus the perforators and other branches are preserved. Another case who presented with a subarachnoid hemorrhage looked like an infundibulum, but definitely not an infundibulum. And this is what we did, flow diverter. So we have a follow-up. You can see there's no aneurysm there. I'll finish in 1 minute. So case 3, this was a unique case. We were identifying what could be the reason of this massive SAH, and finally we could find a blister at the basilar on the posterior circulation, very angry looking, and we offered them a flow diverter, and this is post-deployment. Post-deployment, you can see here, there's already a stasis there, and this is a follow-up of 6 months. You can see the FD there with disappearance of the aneurysm. So our results, 8 patients were operated on day 1. The other patients were operated on day 3 because they presented late, and standard 3D rotational angio was done, and this is how none of the patients had any complications. Till date, I think so all patients are being followed up, all are doing well. None of them had a rebleed, and we followed the regimen of dual antiplatelet, single antiplatelet for 1 year, dual antiplatelet for 6 months, and that's how our results are. To conclude, flow diverters definitely are a revolutionary treatment, especially for these complex aneurysms, which can be catastrophic blood blister aneurysms with rebleed rates very high, and they can be dissection and they can worsen with vasospasm. So this is our references, and I thank you, my team, and all of you for your kind attention. Thank you.
Thank you. Thank you, Dr. Nitin, for a wonderful talk. We shall now invite the next speaker, Dr. Ichiro Nakagawa. He will tell us about avoiding thromboembolic complications in cerebral aneurysm embolization.
Thank you, Chairperson, and thank you for your hospitalities. Today I'd like to talk about the avoidance of complication for the treatment of cerebral aneurysm embolization. So I come from Nara. It's an ancient city where all capital located. It's a very beautiful place. And now our department is here like this. It's a cherry blossom. And so we have a stroke centers and a heliport about our hospital. And so this figure shows the transition of endovascular aneurysmal treatment. So as you know, the detachable balloon is firstly used for the aneurysmal occlusion. And the GDC coil is developed. And as you know, the ISAT trial proves the advantage of endovascular treatment in ruptured aneurysm treatment. And so neck bridging stent is greatly expanded the indication of cold embolization. And now, flow diverter or flow disruptor like a wave is available now. So this is the Japanese neuro-IVR registries, and it shows an aneurysm treatment of 40% of neuro-IVR, and mortality and mobility adverse event is 6.4%. And this is our current issues, the drug gap, JP2B3 inhibitor, teconep, tecloprase, and ticagrelor, it's unavailable in Japan now. So this is also the Japanese registry about the unruptured cerebral aneurysm treatment. So you see here, so procedure-related ischemic complication, the patient stent used is about 9%, relatively high percentage. So the stent error, so the avoidance of ischemic complication is an urgent issue for us. So we have two solutions for avoidance of complication. The first is antiplatelet management. So we have reported the active target PRU management. So using the verify now and controlling the platelet function. And this method will reduce the ischemic complication, not only during the endovascular treatment, but also the delayed ischemic complication. But today's my topic is electrophysiological monitoring in endovascular treatment. So to minimize the neurological deficit in endovascular aneurysm, so we reported the usefulness of motor evoked potential MEP and visual evoked potential VEP monitoring in endovascular treatment. So in this study, we discussed the usefulness of neuromonitoring in the real world and vascular aneurysm treatment. So this is a practical setting of MEP and VEP monitoring. So unlike the surgical setting, we really take care such a lead wire setting, not disturbing the working angle of coil embolization. So now over 300 cases of unruptured cerebral aneurysm treated endovascularly under neuromonitoring. So we like such a dish electrode for MEP and LED stimulator for VEPs. And so decrease more than 50% of maximum amplitude is set alarm point. So this is a result. So over 300 cases. The aneurysmal distribution is posterior circulation at 25%, and large aneurysm is 27%. And this distribution is almost same as Japanese registry. So this is a result. So half of the patient performed both MEP and VEP combination monitoring, and the inter-procedure event occurred 4% of all patients. And here is a monitoring result. Total 11 patients shows their MEP amplitude decreased, but 8% is only transient due to prompt additional rescue therapy and recovered completely discharged without deficit. So about VP monitoring, 6 patients decreased, but all patients transiently without deficit. So I show some cases. This is a 42-year-old female, the right MCA, lenticular straight artery aneurysm here. So we tried cold embolization, but during cold embolization, the MEP amplitude decreased. So we added the antiplatelet therapy immediately, and then the MEP fully recovered at the end of the procedure. This is the final view. So the diffusion weighted image a day after the treatment, some spot found, but no deficit. So next case is a 73-year-old female, like multiple aneurysm, vaginal top aneurysm, and VASCA aneurysm, and P1 perforate arising from between the dome like this. So we planned the coil embolization separately, this one and this one. So under general anesthesia, distal access catheter navigated to the V4 portion of left VA, and firstly, vaginal top aneurysm coiled, and next, and the BSC aneurysm coiled using the double caster technique. But during the embolization, suddenly SEP and MEP amplitude decreased. So we surprised and we checked the diagnosed angiography. No perforator occlusion and nothing happened. But cone beam CT showed such a contrast accumulation in the medulla, which is the area of proximal to the union of VAs. So we immediately stopped the treatment to avoid worsening symptoms. After the treatment, a patient shows ataxia and hemiparesis, so that's why we started steroid therapy. And after then, hemiparesis is almost improved, transferred to rehabilitation hospital. So we think this, we speculate the contrast-induced encephalopathy due to the VBB disruption. So next case. This is IC ophthalmic aneurysm like this with BREP, and ophthalmic artery is arising from the dome of the aneurysm. So we firstly tried the balloon occlusion test at the neck of the aneurysm under VEP monitoring, and showed no VEP change during BOT. So we decided for diverter with coil and completely occluded ophthalmic arteries like this. But no MEP and VP change during the procedure, and the patient has no visual deficit. So this is the final case. And this is a 70-year-old girl presenting a headache, and this MRI shows a left PCA partially thrombosed aneurysm like this. In this case, we planned the stage of treatment. At first, the stent-assist coil embolization, and second is the instant PAO, parent arterial occlusion, if recurrence happened. So before the treatment, we performed the balloon occlusion test, neck of the aneurysm, and VP monitoring, but no VP change during the BOT. So we think the possible PAO. So at first, the stent-assist coil embolization performed, but 3 months after the recurrence happened in the thrombosed portion. So we performed the instant parent artery occlusion like this. It is the final views, and no visual deficit after treatment. So discussions. So previous reports show the neural monitoring in the endovascular treatment. So SSEP is measured. But this is our studies. So MEP technique is advancing. So in the future, the possibility of transition of MEP-based monitoring in the endovascular treatment. And also VEP is a widespread use of total venous anesthesia and develop the LED stimulator. So there is some report in neurosurgical setting about the transphenodal surgery, tumor resection, and aneurysm clipping. But I think that VEP can become common also during the endovascular treatment. So in conclusion, intraoperative neuromonitoring is useful for avoiding perioperative complication of endovascular treatment. Thank you for your attention.
Thank you, Dr. Ichiro, for that wonderful talk. May I now invite Dr. Vincent for his talk on management of unruptured cerebral aneurysms.
Good afternoon, everybody. Again, it's a privilege to be here, to be giving a talk on the management of cerebral aneurysms. Thank you. I think first of all, we need to revise ourselves for what actually causes and what is the histopathological of aneurysm formation, which is what was mentioned just now, which is related to the disrupted of the IEL, the internal elastic lamina, the thin membrane, and also the loss of the smooth muscle cells, and also the collagen remodeling itself. So what you see on the picture on the left, you see that the IEL is actually missing, and then the smooth muscle cells are gone, and you have all the collagen remodeling that you will see. The reason why this is important subsequently when we are talking about risk prognostications, looking at the structure. The other concept is really about the role of inflammation that is associated with the formation of the aneurysms, be it the hemodynamic stress. And so what you see here on the picture is really very complicated. It's really the interaction, the biochemical interactions of the smooth muscle cells and also the endothelial cells together with the macrophages. The key word is on the right bottom, which is the inflammation of the aneurysm. So part of when we see unruptured aneurysms in our clinical practice, a lot of the time is, will this aneurysm rupture and do we really need to treat? What we know from the ICU study is really size and location matters, and that's obviously very well known. On top of that, we have the patient's clinical factors such as hypertension, the age, the gender, the smoking history. And in this particular, it gives you the various hemodynamic factors, the reason why it leads to the initiation of the aneurysms and also the progression of the aneurysms. Of course, besides the patient's factors, we need to look at the aneurysm factors, and that's very well presented here by the study itself, where you look at the size of the aneurysms, the size of the aneurysms, and also the various shape index of the aneurysms. That itself is nothing new, and of course you look at the various hemodynamic factors. To put it together now, we also look at the 3D morphological changes of the aneurysm. That's basically looking at the patient and the aneurysm factors. And what do we do now in the clinical practice is, number one, the three various famous scores that we have. The FACES score itself, the ELAPSE score, and then based on the UCA study itself on top, you would then have the UIATS treatment score itself, right? And that itself then allows you to actually prognosticate, make a decision whether you will want to favor a repair or the treatment or conservative management. You do have websites on the line itself in order for you to create all these scores at the same time. This is the best review part paper that you can see that you're looking at the three scores in the center of the paper, plus all the aneurysm factors when you look at the aspect ratio, the size of the aneurysms, plus the various other factors below, right? Whether you have the wall enhancement and all that. That's really still something that we can take together and look at it in a clinical practice. The previous speakers have mentioned a lot about computational fluid dynamics. I mean, the difficulty really is the technical challenge and the modeling behind these aneurysms that actually limits the broad-based application of this. There are many factors along the way that we have used, such as the wall shear stress, which is the main one, and the various other parameters that's reflected here. But it is really complex. But this paper itself basically tells you that you can have, by just looking with the engineers, with a PhD, you would have many of these hemodynamic factors, which really looks at the aneurysm itself. But which one is the holy grail? Which is the one that you really want and to be useful, that will be useful? On top of looking at the hemodynamic factors itself, what has moved on is looking at the aneurysm itself, right? So what you want, therefore, is interaction of the blood flow and the structure of the aneurysm itself, which is why you see here the fluid structure interactions that are happening in the aneurysm itself, right? What you see in this paper in the Communications and Nature is how you can then look at the interactions of the fluid, the modeling, and how that affects and that changes the harmonic frequency of the aneurysm itself, and that using that as a part of the prognostic factors. You can put all these very complex factors where you look at the geometric analysis, like what we mentioned just now, into the velocity, plus the washer stress, and all this put into factors for risk assessment. I think it is important, therefore, to come in to understand the application of washer stress, where actually this paper by Monk was quite a good paradigm to tell us about the two pathway, the mural cell pathway and the inflammatory pathway, where you have two categories of patients, one of aneurysms, one with the high washer stress, leading with the hemodynamic stress with the mural cells mediated pathway, and the low washer stress that leads with the inflammatory pathway. And that itself then leads you to two kinds of aneurysms, one on the bottom left, which is the small aneurysms that are thin wall, translucent, and have high risk of rupturing, and the other group, which is what we are used to, which is a large lobulated, thick wall atherosclerotic, thrombotic, partially thrombosed aneurysms. And this is what you then see. On the left is one of the thin wall aneurysms, and on the middle, on the right side, and D, is where you have that large lobulated aneurysms. And that's really the difference between using the hemodynamic factors to differentiate. On top of that, what has happened now is using the inflammatory markers that is in the aneurysm cell by using the Mendelian randomization study, you are then able to look at the genetic markers that predispose the fractures, such as the FGS 9 and 16 down here, in order to combine that with the degree of inflammation. I mentioned right from the start about the collagen. Why? Because now there are different theories about the wall of the aneurysm with the collagen modeling, right? On how does that formation of aneurysm, what is the wall collagen formation in the aneurysm can be part of the risk of the modeling of the aneurysm. So subsequently, what you see now is the hemodynamic analysis, the structural analysis, and together with the degradation and the remodeling of the collagen in the aneurysms. And all this comes together with the overall FSG simulation network that helps you to predict the aneurysm. On top of that, then you're looking at, therefore, the various other factors that you can see of the osteoprotogenesis. Basically, it's still a marker of the collagen remodeling. We have always been having the aneurysm paradox, that small aneurysms sometimes don't rupture, and some of these small aneurysms then stabilize for a long time. And that's something that the previous Monk, the hypothesis have helped us to understand about the stabilization of this aneurysm. What is latest in the visualization really is with the 3T MRI scan with the enhancement, the importance of the aneurysm wall enhancement gives you a degree of inflammation. But that has not been proven yet, right, with this study, that is an inference that we are making, that a gadolinium enhanced intracranial aneurysm itself may predict the risk of rupture. And that's really proven in this paper in 2023. Moving on, before we talk about that, is what are the treatment options? Ironically, aspirin has been coming up and talk about it because of its anti-inflammatory purpose, whether they will help to reduce. And there is an ongoing trial, the Protect U trial, which will give us a bit more information about that, but it's probably still not within our clinical practice to talk about routine use of aspirin for patients with unruptured aneurysm. Interestingly, clopidogrel, Plavix, has also been implicated about this. There is, with this Mendelian randomization tactic itself, where you then randomize the alleles with the outcome of even coffee drinking, you can actually predict, and using that as a form of predicting or increasing the risk of ruptures on the bottom left, which is about 1.5 times. In continuation of yesterday's talk about using machine learning, there are now many, many techniques of using the various algorithms it is over here that you can see to use to predict aneurysm rupture and prognostication, and this is really a repeat of yesterday's slides. So to put it in together, you will then see what you can put in a model will be your age, gender, size, the patient's factors, the hemodynamic factors on the right, plus the FSG model that we were talking about, the elastin and collagen, in order to put that and to predict the aneurysm rupture. this is actually a repeat point. One of the more leading centers in China have actually showed us what they do, where they put in the various factors. And on top of that, they have moved forward into metabolomics studies. And on the bottom right, what you see is that they look at pharmacological interventions such as the oleic acids and the anti-tumor TNF-alpha, and whether that would be useful in terms of using it as a model for evaluating intracranial aneurysms instability. I think this is really advanced center. I would say that in my center, this is something that we aspire to towards it. Just for it was quite interesting that this paper was actually published with the evidence in the gut microbiome. It seems to be more and more literature is coming up about that this biosis of this gut microbiome, which is very far away from the brain and for brain aneurysm, may have an implications of formation of aneurysms based on this studies itself. And that's not the only first paper. The paper came up in Nature as well. That alternation of the gut microbiota may lead to the progression of the unruptured aneurysms. And similarly, what you see then the fecal proteins itself, well, we'll never know whether better dentations and better gut probiotics will help to prevent aneurysms, but there's now ongoing literature about this, about the gut microbiome. And to talk about the inflammation, there's also ongoing trials to talk about dimethyl fumarate, which is a drug used for multiple sclerosis to reduce inflammation as for unruptured aneurysm. In preparation of the talk, this is probably the last consensus review, the latest consensus review that come out in the journal of the ARISE consensus trial, which really talk about utility of some of these modelings and the consensus. Thank you.
Thank you, Dr. Vincent. I'd like to invite Dr. Tomoya Okamoto to give his talk. Outcome of thrombectomy for ATBI cases at our hospital.
Thank you for introduction. I'm going to speak about outcomes thrombectomy for ATBI case, especially ICADO, intracranial arteriosclerotic disease related large vessel occlusion and parenchymal hemorrhage, parenchymal blood volume. Recently, recognition rate of mechanical thrombectomy is improved, but there are still several problems in this field. ICADO elbow, intracranial arteriosclerosis disease-related large vessel occlusion has some difficulties for procedure strategy and its management. ICADO elbow is responsible for 12 to 30% of elbow, and clinical outcomes after thrombectomy are similar to embolic cases, but they have some problems for treatment. They have high re-occlusion or restenosis rate, and procedure strategy is sometimes complicated to need to decide whether PTA or stenting is required. And they have residual stenosis after procedure, so we have to decide timing of complete procedure and need for additional treatment such as PTA or stenting. And after procedure, post-procedure management is also complicated. It also needs to antithrombotic agent or blood pressure management. There are several studies about perfusion status after thrombectomy, and previous studies using these modalities will decrease CBV or CBF is the factor of clinical outcomes. But these previous studies about only embolic cases, so to review the perfusion status after ICAD cases, we could optimize procedure strategy and postoperative management. The modalities that previously reported difficult to evaluate immediately after procedure, so after thrombectomy cases. So we evaluate PBB by flat panel detector. PBB is the imaging technique similar to CBB evaluation by DSA from autography. The merit of this method is PBB analysis is performed on angio system, so we could evaluate during procedure. But this method could only assess CBB, could not assess CBF and MTT. How assess PBB value is explained in this slide. Flat panel detector is used autography by 4 French pigtail catheter with the tip above the aortic valve is performed, and we got 3 rows on 3 slides. PBB value is defined as mean of ischemic site against mean of the contralateral site, and increased ratio of PBB, post-PBB against pre-PBB value. To use this value, we analyze post-perfusion status for thrombectomy cases in this period. And occlusion site is intracranial ICA, M1, and M2 occlusion. Finally, we got 63 cases included. In for analysis of clinical outcome, MRI aspects and NIHSS, puncture to recognition time, and angiographical final good reperfusion is the factor of good outcome. Mean of PBB value has no significance between good and bad outcome, but post-PBB divided into quartiles Q1 to Q3, Q4. Poor outcome is usually in low PBB value and strongly high PBB, so good outcome is more frequently in Q2 and Q3 group. This is the analysis of hemorrhagic event after procedure. Increased post and increased ratio of PBBs are predictive factors for parenchymal hemorrhage. This is the embolic case, 83-year-old woman with right M1 occlusion. In this case, we do combined technique 2 times and achieved good reperfusion. But after procedure, post-PBB did not increase. And after that, infarct area growth, and this case had bad outcome. And another case, embolic case, 81-year-old woman with right M1 occlusion. In this case, we achieved good reperfusion with 1 pass. And after procedure, post-PBB strongly increased at reperfusion area. And in fact, growth and parenchymal hemorrhage occurred after thrombectomy. And this case also had a very good, bad outcome. And after that, we compared between non-ICAD and ICAD cases in patient backgrounds. There were no significance about these factors. This is a comparison of non-ICAD and ICAD cases in clinical outcome. ICAD elbow case had longer P2R time and lower post-PBB ratio. In this case series, 1/3 case needed PTA session, but there were no cases that need emergency stenting case. In ICAD case, post-PBB tend to be higher in good outcome without significance. This is a subgroup analysis about good outcome and PBB value. There was difference in the extent to how much PBB increased and less prominent elevation case in the ICAD cases. This is a representative ICAD case, 76-year-old woman with left M2 occlusion. In this case, we could achieve good angiographical reperfusion with combined technique without PTA session. And after that, post-PBB is slightly increased to be normalized. And in case, in fact, size was not increased and the patient had very good clinical outcome. Post-PBB value assessment is associated with functional outcome. In this study, the dynamics of PBB changes in good prognosis differs between ICAD and non-ICAD cases. Significantly high post-PBB cases also tend to be poor outcome, not only decreased post-PBB. Several studies reported increased CBF post-thrombectomy is a prognostic factor of poor outcome and hemorrhagic event. IQD elbow case usually need their antiplatelet therapy after procedure. So, and previous reports demonstrated that the rate of parenchymal hemorrhage was about 5% in IQD cases. This is our IQD case with parenchymal hemorrhage. Post-PBB is significantly increased, and after that, parenchymal hemorrhage occurred. So, post-PBB can be related to parenchymal hemorrhage. And IQD elbow tend to have good collateral than embolic cases, so alteration of tissue reperfusion and ischemic tolerance to it may differ. And PBB evaluation could be performed during procedure, so if the optimal range of post-PBB was identified, it may be helpful to optimize strategy and post-operative management. And in this study, the IQD group included had a small number of cases, and the reperfusion of IQD case may be depend on treatment strategy. So this is a limitation of this study. And this is the conclusion. Tissue reperfusion status and corresponding prognosis may be different in IQD cases than in embolic cases. To establish optimal treatment cases, further studies about reperfusion status about IQD cases are needed. Thank you.
Thank you, Dr. Tomoya. The last speaker down the line is Dr. Batuk, who will speak on high flow bypass.
So I'm going to share my experience with the high flow bypass, relevance in the era of flow diverter. We all know now with the availability of the flow diverter, more and more patients are going for the endovascular treatment. So I'm just going to share my experience with the high flow bypass in few cases. Matsukawa has given indications for a high flow bypass whenever there is a large complex aneurysm, giant aneurysm, blister aneurysm, dissecting aneurysm, when the aneurysms with a branch arising from the aneurysm sac, calcification and extensive thrombosis inside the aneurysm. But with the availability of the flow diverter, that has revolutionized the treatment of such aneurysms like exclusion of the aneurysm from the blood circulation with the remodeling of the parent artery is the principle of flow diverter. So this is a case of almost like a dual aneurysm arising from the cavernous carotid symptomatic that was managed successfully with the endovascular treatment in the form of the flow diverter. Again, like with the giant cavernous carotid aneurysm symptomatic that was managed with the flow diverter, one can see the pre and post flow diverter. Again, in the posterior circular aneurysm, actually the role has significantly increased in the form of like, because some of these aneurysms are extremely difficult. One cannot identify, this is the post-op images like where the aneurysm was preoperatively. Many of these cases like superior hypophyseal aneurysms in these locations can be based to manage microsurgically. However, when the aneurysms are multiple, like here there were 3 aneurysms, cavernous carotid, superior hypophyseal, as well as the ophthalmic segment and the ventral wall aneurysm that were successfully managed with the flow diverter. So I'm going to show a few cases of high flow bypass, this was my first case. I will just, before that, we have 2 options for the high flow bypass, either radial artery, or it's always a better choice, or the saphenous venous graft. In my case series, I almost use a saphenous venous graft. We know about the advantage and disadvantage. Radial artery is the best, but there is always a prone for a spasm, and there is a discrepancy in the case of when you use a saphenous venous graft. Surgical technique, always first do the craniotomy and Sylvian fissure and identifying the M2 branches, and first do the anastomosis cranially, and subsequently pass the graft in the subzygomatic plane and bring into the in the neck region and do the anastomosis with the external carotid artery branches. Finally, the aneurysm is isolated. First, you successfully do the bypass, and then the aneurysm is isolated from the circulation by either clipping or the trapping. So I'm going to show a case of 45-year male who presented with a mass lesion in the left caudate nucleus. Is a CT angio suggestive of a sort of aneurysmal outpouching. These are the detailed MRI pictures showed flow voids in the region of the left caudate nucleus. This is the digital subtraction angiography on both the sides from both the ICA that suggests a giant serpentile aneurysm of the azygous origin. And this was the rotational angiogram that showed a giant azygous aneurysm, and both the distal anterior artery one can see, and there was only single AACA. This patient actually waited when we explained about the treatment options, and they were reluctant and waited for almost 6 months. By the time the size of the aneurysm has increased and shunt was done because of the hydrocephalus, initially patient family agree with only shunt surgery. Subsequently, when patient came for the definitive treatment, there was almost about a 7.2 centimeter size supracellular sort of a mass lesion. And then we decided we'll plan for a surgery in this patient. The brain was quite edematous, one can see on this thing. So we did a high flow bypass from the ACA to the one of the branch of the ACA, and then the aneurysm was trapped and the mass was excised. And this is the intraoperative, some of the pictures like how the distal anastomosis done first, then the proximal anastomosis, and this is the postoperative angiogram. Immediately post-operative CT angio was done that was showing a normal flow in both the ACA territory, and this is the CT DSA that was showing a ACA territory filled by the high flow graft that was and the saphenous vein was used. So this is the post-operative clinical condition of the patient. He was but a bit dull, but he was moving all 4 limbs and following the commands. And we have almost 6 months follow-up for this patient, but unfortunately we lost him during the COVID time. My second case is a 57-year male presented with a massive epistaxis, 2 episodes. CT angio was suggestive of a subpetrous aneurysm. One can see this is the left IC angiogram. The right IC angiogram only showing a feeling of the MCA territory, while the left was feeling both the ACA territory, left MCA as well as the PCA territory. So in these patients, we consider for a high flow bypass because the diameter distal to the aneurysm was around 6 millimeter, and that time the 6 millimeter flow diverter was not available. And second concern was there was a significant proximal stenosis. So in this patient, we have planned high flow bypass, and in this patient, I particularly did both the bypass, low flow bypass as well as the high flow bypass. The first STMCA bypass was done, and then subsequently we did a high flow bypass using a saphenous venous graft. I think because of the shortage of time, I will just fast forward the video, but I'm not showing the video. So this is the post-operative clinical condition of the patient, and this is the post-operative DSA showing a successfully working high flow graft, and this is the again like AP and lateral view, and we have confirmed like both the grafts were functioning nicely, high flow as well as the low flow bypass in this patient, and this is the clinical condition of the patient. Again, my third case was a 44-year symptomatic patient with the left cavernous carotid aneurysm that was partially thrombosed. And one can see there was a significant proximal narrowing as well as the wide neck of the wide neck of the aneurysm. So in this patient, we first did a balloon occlusion date, but patient failed. So and finally, we decided we'll go for a high flow bypass in this patient. So the bypass procedure was performed. And then subsequently in the same sitting, we have not occluded because of the previous experience. So this patient was again like taken and the ICA was ligated after confirming the flow in the bypass, and this was the clinical condition of the patient. My last patient is a 29-year male. He presented with a subarachnoid hemorrhage. One can see there was a large aneurysm in the right MC area. So now we know about with the availability of the endovascular treatment, and patients' relatives are many times in dilemma what is the best treatment in a given patients. We have explained about considering the nature of the aneurysm. We have discussed about the high flow bypass and microsurgical option. But however, patient family were in a double mind whether to undergo surgery or to arrange the fund. And meanwhile, while waiting for the fund, and he developed this is this digital 3D rotational angiography. Patient developed a massive subarachnoid hemorrhage, and in emergency we did this high flow bypass for this patient. One can see this is the graft, and that was attached with the MCA distally, and this was the post-operative image. However, patient succumbed at the almost after a month. So endovascular procedure and device evolve over a period of time, and however the indications are limited for the bypass. High flow bypass may be the necessary in management of some of the complex intracranial aneurysm, and the microvascular anastomosis, it's learning and learning this technique requires thorough training before indulging in these procedures. Thank you.
So the session is open for discussion. Questions? So by the time the floor asks questions, Dr. Batuk, I was just curious to know as to what are those cases where do you find flow diversion better than the other way around, the high flow bypass better than the flow diversion?
So now almost all the aneurysms, like we have endovascular option. The first case, there was no option of endovascular because it was a serpentile giant aneurysm around 8 millimeter width. Available flow diverter right now is around 6 millimeter. And the length of the segment that was aneurysmal was around 10 centimeter. So in the first case, there was no option of endovascular treatment. In the second case, as I have mentioned, this was done almost like 3 years back. That time, 6 millimeter flow diverter was not available, and there was a significant proximal narrowing. So we were concerned about whether that it will work or what. And the third case, again, like there was a significant narrowing of the ICA. You must have known.
So as far as I understand, and to the House, there were technical shortcomings for the flow diversion. That is why you used your high flow bypass in those cases.
Yeah.
So with the recent technology emerging and newer flow diverters appearing in the market, then this art will be a lost art soon in the field of aneurysmal surgery. Am I right?
Yeah. But as you know, like I'm also doing endovascular treatment for these vascular cases. Like, so still we have a limited number of cases that endovascular treatment
Yes,
is
exactly.
not.
That is what my question
Yeah,
is.
yeah.
So what are those cases still, despite other than the shortcoming of technical aspect, you will still like to do a high flow bypass?
So the cases I have shown you, and my first slide, there were indications I have mentioned about. But today's time, let me tell you, when the size of this sort of a giant serpentile aneurysm of around more than 6, because we have a flow diverter of 6 millimeter size available right now. So more than that size width aneurysm, we cannot do endovascular treatment. Fund is a major concern in our practice where we work. So even though patient wants to do the flow diverter, sometimes we cannot put a flow diverter in these patients. And some of the recurrent cases, recurrent cases, we have an option of this.
Paritosh, you want to say something?
There is a Y-shaped.
Yeah, those things you can do, but those things are probably have worse result than doing a high flow bypass and proximal occlusion. So I think complicated MCF fusiform aneurysm is probably one indication where these things are there. But otherwise, in most of the proximal IC aneurysms, the other ones, flow diversion is probably better results than the high flow bypasses.
Yeah. So I have a comment here.
Yeah, Nathan, please.
So basically, what we are discussing is where are the situations where we are planning for a high flow bypass. See, currently the indication as we are progressing towards better endovascular options, flow diverter, as I just mentioned in my talk, we have tailor-made flow diverters. If these patients are having chronic, we can wait unless there's an emergency. We can get up to 8 millimeters of flow diverters. We can go beyond that also. And we can do telescoping in these patients. But the problem even today remains is economics. Finance is a big issue. because these are costlier devices. And definitely the indications of bypass are getting lesser and lesser. Our experience, expertise are going very less. So is the outcomes. As we don't practice it too much, obviously the results are going a little negative as compared to the easy options of endovascular, and it becomes very straightforward.
I understand. I mean, it's all a question of technology emerging. I don't think that, I mean, it's more of an indication which is required by the pathology per se.
Absolutely.
So, any comment from the experienced seniors here regarding the endovascular vis-a-vis high flow bypass? I can see many sitting out here. Professor Mehta, what do you think about the usage of, I mean, high flow bypass current scenario in the era of endovascular?
I think it's very limited now in the era of flow diverters. As Paritosh said, if the fusiform aneurysm of MCA, I think there may be a useful.
I just want to ask Paritosh and Batuk, Nitin, what do you do if the flow diverter migrates? We had a problem with the flow diverter migrating. Then what do you do?
So I don't know what happened to the patient afterwards, like whether it was functioning flow diverter or the vessel was occluded.
It migrated, vessel got occluded, and that was the end.
Yeah, so you know the answer. It is possible, it will migrate, and I have seen a case where we have lost the patient and we have seen the PM and the flow diverter was lying outside the ICA.
So I would like my Japanese friends to share their experience. This is a Indo-Japanese meeting, so if any experience from Professor Ohata. So what is this stage of bypass versus flow diversion in Japan? We would like to know. Some Japanese experience, please come forward. Yes.
So in Japan, so most of cases can perform flow diverter treatment, but I think the blister aneurysm, it is sometimes difficult to cure, but previous study shows a very nice result. But in Japan, so I think the blister-like aneurysm is unsolved aneurysm. And so I think we need a high flow bypass for the blister-like aneurysm.
So you all do it for blister aneurysms more?
Yes, another aneurysm we can do using the flow diverter stent. But blister is I don't know the result. Some cases recurrence and some cases relapse. I think we need a high flow bypass for blister-like aneurysm.
So one more question as far as the bypass goes is for children with moya less than 2 years old. The clip which is there, the temporary clip, sometimes becomes too heavy and it tends to rotate the vessel, which we have also experienced. So what is your experience? Do you have a special temporary clip for children, or you use the same clip which is used for adults as well as children?
Thank you for questions. So about Moyamoya disease, yeah, we actually use the same small clip using the bypass, but the thread is a little bit thin one, 11.0 or nylon use, but the clip is the same one.
Clip is the same. This is what you mean to say?
Yeah, it's I don't know. Yep.
Because I mean that clip which we applied proximal and distal, even if you apply a mini clip, it's sometimes too heavy, too weighty, and it turns this thing upside down sometimes. Yes, Paritosh, please.
Yeah, Mizuho has very small clips which are there.
Yes.
A lot of people I've seen use aneurysm temporary clips. Those are very big. But Mizuho has a very small clip, which is like.
So do we
AVM
have
clip.
those clips
Yeah,
available?
Yeah.
in
You should
India?
use those. Those are excellent.
So are they available in India?
Yeah. The clips that I've used was Mizuho
Oh,
clips.
okay.
Those are very good.
So thank you, Dr. Batuk. And thanks all the speakers for that wonderful, lively session on cerebrovascular surgery. And before we close this session, I've been instructed to ask for everyone to gather here for a group photo before we proceed on to the next session. Thank you so much.
kind attention, please. We are continuing with our sessions to stay on time. You can collect your tea and probably join us back in here.
ये फर्स्ट टॉक है इसका HDMI है ना स्क्रीन आएगा
A very good afternoon once again. We'd like to continue with our sessions. May I invite the chairpersons for this session, Dr. Dilip Panikar sir, Dr. Prakash Shetty, and Dr. Manabu Kinoshita from Japan. The discussants for this session would be Professor Aliasgar Moyade sir and Dr. Yuta Saito.
Thank you. Welcome back, everybody. This is a session on intrinsic brain tumors, quite different from the previous sessions on vascular surgery. The first speaker will be Dr. Aliasgar Moyade, who will be talking on chasing the residual tumor, the why and how of it.
Yeah, good afternoon. Thank you, chairpersons. And in this 10 minutes, what I'm going to do is describe, with the help of 3 illustrative cases, the value of resecting gliomas radically. So I think as neurosurgeons, all of us acknowledge the prognostic value of the extent of resection. And this, in gliomas, be it low-grade or high-grade, is one of the most, and probably the only modifiable prognostic factor that is available. The others cannot be changed. There has always been a controversy about how much of a resection is enough. The bottom line is that whatever you resect has to be safe maximal resection. Okay, sorry for that. So the bottom line is that whatever you resect has to be done safely, because neurological worsening is not acceptable. It's not just resecting, complete resection, gross total resection, and there is enough evidence for that, but also that for subtotal resections, every incremental improvement in your extent of resection has a prognostic value for a given patient with a combination of other prognostic factors. Therefore, the more, the better, again, as long as it's safe. And then there is also a large body of evidence in glioblastomas and malignant gliomas where resecting beyond the contrast enhancement has a prognostic value. And this is something which has been seen a lot in the ALA literature. And more recently, we have enough evidence and large studies to show that resecting T2 flare component in glioblastomas, which are not enhancing, is important. And that has led to the very recent RANO resect criteria, which shows that the best prognosis is in patients where you resect all contrast enhancing tumor as well as a majority of the non-contrast enhancing tumor, which means the target for resection has moved beyond just contrast enhancement in high-grade gliomas. However, as neurosurgeons, we generally tend to overestimate our resection intraoperatively, as this study shows that in almost 70% of cases when neurosurgeons were asked after a surgery and they said it's gross total resection, but MR showed residual, which leads us to acknowledging the fact that there is a big gap between what we set out to do and what we pessimism, in the sense that many would think that what is the point in resecting gliomas more? At least we've not caused any harm to the patient. But in light of this evidence, actually not resecting most of the tumor when it could have been resected is doing more harm to the patient. So if we all agree that radical resections are important, then we go to the next step as to how do we achieve that. So, of course, not all tumors can be resected radically. You have to select the right case, use the right technique, and then, of course, apply an appropriate adjunct, which differs in different cases, and I'll try and show them. So the technique, as we know, a radical en bloc resection, and we heard Dr. Goel talk about it, is oncologically more sound. It is more elegant. It has an oncological basis and also leads to lesser complications. However, technique alone may not suffice, and I'll try and show that in one or two cases. Therefore, you have these adjuncts, and this is a combination of strategies which help you improve your resection by visualizing the tumor better, as well as complementing them are techniques which help in IONM or awake surgery in the form of mapping and monitoring. So I won't kind of dwell too much upon this slide, but there are many factors which come into consideration when you're deciding what to use in which cases. But what I want to highlight here is that we should never be prejudiced that the tumor is not completely resectable, both in terms of its delineation on the MRI, which sometimes may or may not be well delineated, as well as its proximity and involvement of eloquent structures, because this presumed resectability, presumed eloquence may not necessarily always be correct. So the first case that I'd like to show is an enhancing high-grade glioma in a non-dominant eloquent region. Now this is a tumor which was a typical glioblastoma. You can see that there is, I'll try and run through it. It's contrast enhancing, but there is T2 flare component. I always like to do an ultrasound, in this case a navigated ultrasound. You can see there is tumor, but there's a lot of edema around it. This may or may not be tumor. We're using ALA in this case. And we've also, you're going to use intraoperative monitoring because it's just anterior to the motor strip. And in case the edema is infiltrating tumor, which I'm going to chase, it needs to be monitored. As you can see, the fluorescence helps you delineate the enhancing tumor, but you do a gyral resection, which means even if there is non-enhancing tumor or non-fluorescing tumor, you remove it. A gyral resection in the gyral plane, but at the banks of the sulcus, you then come into the white matter, where essentially what you are chasing is the fluorescing front of the tumor. And under white light, it will be almost impossible to differentiate it from normal surrounding gliotic tissue. In the vicinity of the corticospinal tract, which is anterior, in the subcortical plane, you do a dynamic subcortical mapping because here your functional boundary is important. Remember, we said that you want to have safe maximal resection. As long as you're maintaining all the MEPs and there is complete removal of fluorescent tissue, you have achieved the optimal resection for this patient. So this, I always do an ultrasound at the end. And in a lot of papers, it has been shown that at the end of surgery, you've resected volume, which is much more than the contrast-enhancing tumor. So what do we learn from this is that to remove the contrast-enhancing tumor, if you have an intraoperative guide like fluorescence, it's very useful. But the surrounding flare T2 component is likely to be less fluorescent or sometimes not fluorescent, and then you need some other modality, ultrasound in this case, because visual impression may or may not always be accurate. And then you, of course, combine it with intraoperative mapping and monitoring to maintain your functional boundary, which cannot be compromised. The other example I have is a non-enhancing low-grade glioma, non-dominant hemisphere. Here we are not going to use ALA. This is just coming close to the hand knob area. And this one, we are going to use a simple 2D ultrasound. We do the ultrasound to delineate the tumor margin, and it's important to do it before you start the resection to gauge the landmarks and the extent of the tumor. You go ahead, and then we would do the resection. Of course, you can use multiparametric ultrasound, but the idea is to resect it, and in this case, we've used subpile resection. Can I ask for a minute more than that between? Yeah. So what we've done is then we've repeated the ultrasound because we thought we removed it completely, en masse. But you see that the ultrasound is showing us something there which is not evident. There is some doubtful residue here. It's not easy to pick it up just on the ultrasound. So what we do is we compare it with the pre-resection ultrasound, and immediately you can make out that yes, there is residue. We go ahead, we resect it. It's not functional because we are already mapping and monitoring. And we then finally get a post-resection ultrasound, which is, again, I'm highlighting here. It's important to compare serial ultrasounds because now you can see our resection cavity has reached the ventricle, which means we've removed all the tumor, comparing serial ultrasounds. This is the value of doing an intraoperative imaging. So to remove non-enhancing tumor, the fluorescence won't work. You need something else. 2D ultrasound is useful, of course, along with IONM. Navigated ultrasound may have some benefits, and I won't dwell upon that too much because of the lack of time. The last case that I wanted to discuss was a dominant side premotor glioma. This has been done awake along with ultrasound, and this was a recurrent case. This was a young lady who came with a tumor which was a grade 2 astrocytoma, radiated many years back with a recurrence. You can see that it's in the premotor area, just coming into the opercular area. It's an eloquent area, dominant side, so we decided to do it awake. Now, generally in these cases, the problem is there's distortion of landmarks. This is very close to the pars opercularis, and it's speech motor area. You have to be very careful. So we did it awake, and you can see that we are mapping. This is the posterior part where we expect the hand area, which rightly so is picked up. We were expecting the ventral precentral gyrus or the VPMC area close by there. But surprisingly, we found it much more anterior. The tumor had completely splayed the pars opercularis, and this would not have been evident unless we had done it awake in this case. Once we get the functional boundaries, because remember, our aim is to remove all the tumor, to chase all the residue also. We now know what the delineation of the tumor is. That's what the tumor was. And then we go ahead doing the subpial resection en bloc, and at the same time monitoring the patient and using subcortical mapping. In this case, we had a series of responses all along the posterior margin of the tumor. What I want to show you here is that after you've resected it, there was a small residue left in the eloquent area. And this was residue, not that we were not aware of it, we knew it. But the value of intraoperative imaging is highlighted here where, and this is where we use navigated ultrasound, where we did an ultrasound and we were able to exactly pinpoint where this residue is. This is the one, the green arrow. And knowing it is an eloquent area, but knowing exactly where it is, we were able to remove it under awake monitoring and achieve a gross total resection with the patient without any functional deficits. So I'll just skip this. So what I want to highlight and summarize is that if we want to optimize resection in gliomas, we first of all have to be convinced that resecting them radically is required, and evidence says that it is. Not all gliomas are amenable to complete or gross total resection or radical resection, so selecting the right case is important, and once you've decided that with that intent, then a combination of techniques and in certain cases suitable adjuncts is important to resect them radically and achieve that aim. This, of course, comes with experience, with training, but that's very important if we have to bridge the gap between our intent and the outcomes that sometimes fall short of our intent. Thank you very much.
Thank you, Dr. Ali. I think questions we can take after the end of the session. So calling the next speaker, Masazumi Fuji. His talk will be on neural basis of spoken and written language.
ब्लिंक हो रहा है
Good afternoon, everybody. My name is Masazumi Fuji from Fukushima Medical University. Today, I'm going to talk about neural basis of language, but especially focusing on the written language. This is Japanese written languages. Maybe you may know. Those are the ideograms, kanji. Kanji is ideograms. So those letters directly, gives you the meaning, okay? And this is kana. Kana means just the phonograms, like maybe English words. So I think it gives you the pronunciation anyway. So we have two different, kinds of characters. And then this is one case of left temporal lobe glioma, low-grade glioma. And this is a left temporal lobe. Here, this is a lateral fissure. Here, so this is a middle temporal gyrus. And blue circle, which task would you use? Okay, we use this reading task. This is kanji. I think he cannot, correct the right answer. It's impairments occurs when stimulation, this kanji task. And here, this is kana task. This is phonogram. And no problem during stimulation. Those phonograms are okay, but kanji, there is a reading problem. So anyway, in social life, the written language is also very, very important language function, and Japanese has two types of script, kanji, ideograms, and the kana, phonograms. And this study focuses on the errors made by patients who exhibited written language impairments after brain tumor surgery, and the localization of the lesion and related fundamental white matter fiber bundles are analyzed. And method, we utilize 19 cases of glioma surgery. This is a kind of preliminary study. And the types of errors in written language were classified neuropsychological, simply neuropsychologically into three groups. Number one, semantic morphological system errors. Number two, phonological system errors. This is written, of course, written language errors. And number three, motor morphology system errors. So, and tumor localization is defined as a resection area. And the degree of white matter damage was analyzed. And I don't have enough time, so anyway, we have used those kind of image analyzing system to clarify overlap lesion mapping and also tracked disconnection severity. Okay? And we have three groups of errors, patients, 4 cases, 12 cases, 6 cases. And this is the result, overlap lesion map. So number one, semantic morphology system located mainly in the temporal lobe, middle temporal gyrus in the posterior part, okay? And then this is the second one, phonological system errors. Patient has mainly in the supramarginal gyrus and also surrounding areas. Okay, and number three, this is motor morphology system errors. They have lesions in the angular gyrus and the intrapalliatal sulcus areas. And then in summary, this is, I think it's a kind of striking, those three errors has three distinctive areas of brain affected. So green one, red one, and blue one. Okay, so I think those neuropsychological errors have some neural basis, corresponding neural basis. And in terms of the so fiber bundles, damaged fiber bundles analysis, semantic morphological system, left IFOF, ILF, and the splenium of corpus callosum is mostly damaged. So this is a threshold of 50%. That means those IFOF, 50% or more fiber bundles are damaged in those patients. Okay? And next, number 2, phonological system error patient shows damage in left arcuate fasciculus, SLFTP, and the splenium of corpus callosum. And number 3, motor morphological system patient has those kind of fiber bundle network connecting between left temporal lobe and intraparietal sulcus, and also splenium of corpus callosum. So, our data suggests that at least existence of 3 distinctive systems involved in Japanese written information processing. So number 1, semantics morphology system, phonological system, number 2, number 3, motor morphological system. So, but I think it's important, this study has important message. One important message is commissure fibers are very important. All 3, damages involve the commissure fibers of the especially corpus callosum splenium. And so that means probably those written languages has a recruitment of bilateral cerebral hemisphere. And next, so let me summarize the neural basis of language. First, spoken language. So as you know, dorsal phonological stream, mainly supported by AF system, and then ventral semantic stream are supported by mainly IFOF, ILF, temporal lobe networks. And then there is another one inside the frontal lobe. This is related to driving with speech, like frontal S1 tract. And let's talk about the written language. So semantic morphological system flows like this from visual cortices to the temporal lobe, inferior temporal lobe, fusiform gyrus to the anterior temporal area to reach semantic information. And then next one is a phonological system. This is mainly utilize, those acute fascicular system, perisylvian cortices. Those are related to phonological system. And then the third one, motor morphological system, as you may know. Here, this is angular gyrus to the interparietal sulcus to the anterior frontal lobe. Posterior frontal lobe. Like this. So written language has neural basis just around, spoken language neural basis, and there is 3 distinctive circuits. Okay, so I think we have shown the 3 distinctive systems, and those task evaluation during awake surgery should be tailored depending on sites in the brain, and the findings of this study will lead to more effective written language evaluations. Thank you for attention.
Thank you, Dr. Fuji. Can I call upon my co-chair, Dr. Kinoshita, to talk on brain plasticity and low-grade glioma surgery?
Nope, it's not working. Now it's working. Okay, now, sorry for the, okay. So it is my great pleasure to be here, to be invited to give a talk about brain surgery. So from Dr. Fuji, we have heard the static situation of the function and white matter and the cortices. But now I would like to present you how we can use brain plasticity to extend our resection for low-grade gliomas. So rather than by looking just into the statics, but looking into how the brain function dynamically changes by surgical intervention. This is just a illustration showing you one of the key landmarks that we have to be aware of when we do intraparenchymal brain tumor surgery, like the central sulcus or the precentral sulcus or the inferior or superior frontal cell side. And underneath it, we know that there are several key white matter fiber tracts, such as the cerebral cortical spinal tract, or the IFOF, just like Dr. Fuji mentioned, which is very much important for language functions. So when we want to extend our resection deep into the brain, we have to be aware not only of the function of the cortices, but also the function that the white matter fiber tracts has, and how they will be interrupted if we go deep into our resection cavity. I would like to show several cases that really taught me how the brain dynamically changes its way of function. So this is a 29-year-old female who had 2 surgeries on her primary motor cortex, the preessential gyrus. The initial surgery was done about 10 years before the second surgery. And the histology was an oligodendroglioma, but as you can see, she had a biopsy, a really small targeted biopsy at the preessential gyrus. And post-operatively, she suffered from a very severe movement disorder, a hemiparesis. Fortunately for this patient, the rehabilitation worked very well, and she was able to recover most of her motor deficits. I was observing this patient after she had undergone chemoradiation therapy, but as you can see, the tumor regrew, so we had to discuss with the patient whether she was willing to go for a second surgery or not. I myself, being a surgeon, was very much reluctant to doing a second surgery because we knew that the first surgery had led to a very severe hemiparesis. And secondly, the location of the tumor was in the pre-central gyrus, so that was a pretty much eloquent area of the brain. What was astonishing for me was that when we did this patient awake, of course we did a lot of functional imaging, which indicated that the function was shifted posteriorly from the usual location. But I was still very much suspicious of whether these imaging findings were correct. But what was fascinating was during surgery, when we were doing this patient awake, the motor function of the patient was pretty much preserved all through the surgical procedure, even though we were removing pretty much all of her precentral gyrus. And this is an image taken 2 weeks afterwards. You can see that her fine motor movements were not disturbed. So this patient told us that, of course, we knew from the literature, but if you really observe these patients, we see that the dynamic changes of the neuronal function of the brain, which was triggered by the first surgery. This is another case. This is another precentral gyrus tumor case. This was an oligodendroglioma again, And this was a recurrent case. So she had 2 surgeries. The first surgery, she suffered from a very severe hemiparesis, just like the first case that I showed you. And this is a much larger precentral gyrus recurrent tumor. But knowing from the clinical course learned from the first case, we were pretty much sure that this tumor is resectable. Again, we did this patient awake. The central sulcus and the precentral sulcus is located like this. This is on the left side. So the right side of the picture is the anterior direction of this patient. And during surgery, we saw the very similar phenomenon from the face compared to the first patient. So even though we are removing pretty much most of the precentral gyrus, the patient did not have much difference in her motor functions. This is the post-op MRI, and you can see that most part of the precentral gyrus is removed. This is right before and after surgery. She had a mild to moderate hemiparesis on her right upper limb, and for the lower extremity, the motor deficit was not that different before and after surgery. This is 1 year post-op, 1 year post-second surgery. You can see that, of course, her fine movements are a little bit disturbed, but it's still usable in her daily life. If we go into the language area, we might be able to do more. So this is a left-sided temporal insular glioma. This was an astrocytoma. So we know from a fact that even though Japanese have a very complex, or maybe every language has complex grammatical or structural structures, but this patient, we were pretty much sure that if we do a stage surgery, we can resect pretty much most of the tumor. But the key is to do multiple surgeries so that we can push the changes of the brain function by intervening surgically. So this is one of the pictures that we have been taken during surgery, and we knew that we are leaving this portion of the tumor behind, but the patient started to experience verbal pulse separation. So verbal pulse separation is a state where, as we all know, that the patient cannot reset her language and keep on repeating the same words even though the questions are asked differently. And that is one of the initial signs that we have to stop the resection while preserving a room for the patient to recover her language function. This is the area that we have intentionally left over at the first surgery, and this patient will suffer from a very severe sensory language deficit. Within about a week or 10 days, those deficits will recover by rehabilitation, and so that we can come back to the same surgical field afterwards. And when we start to remove the same portion where the patient was suffering from verbal pulse separation, it is interesting to know that for the second surgery, the patient will not exhibit the same deficit as we see in the first surgery, so that we can dramatically extend the resection cavity into the deep side of the brain. And so we can do that similar thing in the frontal lobe. Like here, we have stopped the surgery at some point of for the first surgery, that because the patient started to have a speech deficit. But after rehabilitation, we can go back and extend more so that we can achieve more resection even if the location is on the left frontal lobe. And so the lower grade gliomas, we know from the diagnostic point of view, the CNS4 to CNS5, WHO CNS4 to 5, has been able to stratify the patients that do much better, even though the grade are the same grade 2 or grade 3. And currently, the standard of treatment of care is that for grade 2, we observe the patient if the resection was well done. But for grade 3, we do chemoradiation therapy regardless of the extent of resection. The question arises, is this still a possible treatment strategy at this point when we can stratify patients who do well, even though the histologic diagnosis is grade 3? So now in Japan, we have just started a prospective randomized clinical trial of defying or delaying chemoradiation therapy even for grade 3 astrocytomas if the treatment if the surgical resection is well done. But to accomplish this, we have to be able to extend our resection more and more by using these kinds of brain plasticity. Thank you very much for your attention.
Thank you, Dr. Manabu. So coming to the next talk, it's by Dr. Sridhar, the new concepts in DIPG, an operable subset of patients.
नहीं सर का
Good afternoon. Thank you very much to Professor Atul, Abida, and the entire team for having me here, and especially for giving me this talk, which I think is a little close to my heart. The problem with DIPG, and I'm sorry for using the term DIPG because it's now been thrown out. The pathological classifications of gliomas are becoming something like the iPhones. It can change whenever you want at the blink of the eye. So I'm very sorry, but I'm going to continue using the term DIPG. The problem started somewhere here, where with the CT classification of brainstem gliomas, where it said that the diffuse intrinsic non-enhancing tumor has a very bad prognosis, don't operate, and it almost nailed the coffin on surgery for these tumors. So much so that nobody really thought of actually operating, and the diagnosis was made only by imaging. The mainstay of treatment was only focal radiation. And then even when biopsy came, from 2007, the first paper with a series of biopsies, and then later on, 2015, it still never opened the door to actually looking at whether surgery can be done. Because as late as 2024, from NIMHANS, I think Dr. Dwarka is here, we have this paper looking at whether biopsy is safe. We all know brainstem surgery is safe. We operate on multiple things in the brainstem. So the question of safety of operating on the brainstem is now out of the window. So we need to look at what happens in brainstem gliomas, especially in the diffuse intrinsic pontine gliomas or the diffuse midline gliomas as we now call it. So what happened is that as we were not operating, the focus moved completely to molecular biology, to molecular the insights, looking at whether there were any chemotherapeutic agents, but none of it really works. What we have is what we know from not doing anything, what is the survival of these children. My interest in brainstem has been there for some time, but it really got peaked when this patient came to us, this child, referred directly for radiation because it looks like a DIPG. became bedridden, and when we came to us, we did a contrast scan, and this is what it showed. We operated, and it was a tuberculous lesion. So the diagnosis does not, you cannot presume diagnosis just based on radiology. So that is the first thing that we learned from this. Our interest also came into diffusion tensor imaging, and we started looking at FA values in brainstem lesions and as well as other lesions in gliomas and things like that. So we started measuring FA values, and we also looked at the tractography, and we started getting normative values, especially in the transverse pontine, medial lemniscus, etc., in the brainstem. And we also then started looking at how these meant, what these meant as far as the tracts concerned, to whether they were deviated, edematous, infiltrated, or destroyed. And anything more than 25% lowering of FA values meant that they were probably infiltrated. So classically, the DIPGs we came across this sort of a picture here, where it showed the disruption of the corticospinal tract, some disruption of the transverse pontine fibers, and this was it. And we knew that in these sort of patients, probably we could biopsy safely, we could remove some tumor, but not really something which could help the patients with, because the tracts were already destroyed. And then this child came along, 8-year-old, progressive weakness, slurring of speech, difficulty in swallowing. And then when we did the DTI and the tractography, this is what we found. If this were the normal, how the tracts look in the pons, this is how it was in the patient. Everything pushed back. And therefore, no fibers anteriorly. So also in the white matter tractography, it showed the majority of the corticospinal tract was pushed back and preserved. We then looked at the FA values in these tracts across the CST, both in the upper pons, mid pons, lower pons, and the transverse pontine and medial lemniscus. The last two, as you see, were equal to the normative values. The corticospinal tract were not much reduced, but not too much, which meant that probably they were edematous and not infiltrated or destroyed. So we went in and operated on this child. We went to the classical retromastoid approach. We did a peritrigeminal approach into the tumor using navigation. This is the first time we were trying to remove such a tumor, so we were worried about what we would do. So we stopped at midline. Patient made a remarkable recovery. She started swallowing, she started doing, and at 3 months, she was as good as normal. Effect of DEXA, she was put on weight, but otherwise she was normal, and we are still following her up 3 years now down the line. We published this, diffusion tensor imaging, a subset, and the determinant of resectability. And I think this is what I would like to present to you, that diffusion tensor imaging and tractography should be done in all these patients. Another child, left-sided weakness, bed-bound on presentation, headache, diplopia, regurgitation. This is the MRI scans, and once again, the tracts being pushed. This child again was operated upon, again, right in a retromastoid approach, infratrigeminal, and maximal excision. The child did extremely well in rehab, trying to move about. She's got a tracheostomy because of her low cranial nerve problems, but quality of life improved tremendously. She received radiation, and the tumor is stable on follow-up. This is the post-op scan. There is no perfusion-enhanced area in the post-op scan. Of course, it shows a H3K27M mutant tumor. This is what has come recently to us. We have not yet operated an adult DIPG, probably. Again, the tracts being pushed posteriorly. So what I'm presenting to you, ladies and gentlemen, is that if you see on MRI what looks to be a diffuse infiltrative pontine glioma or a diffuse midline glioma, as they now call it, please do the tracts. If the tracts are pushed posteriorly, if the FA values are maintained, this then is a candidate for surgery, because surgery is going to help improve the quality of life of that particular patient. We don't know about the future, the survival rates, because we don't have a large enough series. There is nothing in literature on this, but please do not send the patient for direct radiation. Not anymore. This is a novel concept that radiological DIPG is not a single type of lesion. It is essential, DTI is essential in decision making, and recognition of this operable subtype is important, and surgery is possible. Fact that we are still looking at whether it is complication rate in brainstem is, I think, should not be spoken about anymore. Survival benefits, like I said, needs to be further evaluated. Thank you very much.
Okay, so the next speaker will be Dr. Shah, and he'll be talking about the matter of white matter in glioma surgery. Dr. Shah.
So good afternoon, everybody. So I'm going to be talking about the impact of white matter and how it is influencing our glioma surgery. So as we all know that glioma surgery is advanced. In high-grade glioma, there is advances in terms of resectability due to the availability of dyes. In low-grade glioma, because of monitoring and intra-op imaging and a lot of other concepts, we are looking at supratotal resection. And a lot of these papers show the benefit of going supramaximal, or at least, going for a radical resection even in these low-grade gliomas. Imaging has changed. You have these kind of high-definition tractography images. You have functional MRI, which has enhanced the understanding of glioma surgery. Intra-op imaging, intra-op ultrasound has also changed how we perform surgery. But before we go to all this, let's go to the basics. Let's go back to anatomy and how this anatomy can influence our glioma surgery with or without these adjuncts. That is what my talk is. So before, only cortical areas were supposed to be eloquent. Now we've all realized that subcortical white matter is more important than the cortical eloquent cortex. And this is the effect of damage to all the major fiber bundles. It is listed in this table, what can happen if these fiber bundles are damaged. And as you are aware of this paper, we divided white fibers architecturally into these 5 groups. I'm not going to go into that. What we don't talk about, we're talking about surgery, we're talking about adjuncts. Have you ever thought about where the glioma originates from? There are not many papers based on this concept. This was a paper in Yasargil's textbook, or published by Yasargil, where he said that the glioma grows along vascular territories and goes towards the ventricular system or migrates through the corpus callosal fibers. Basically, he said it follows the vascular pattern and it is like a wedge-shaped area of growth. Now we know that neural stem cells arise in the periventricular zone and they migrate. Where do they migrate to? Some of them go and land up in subcortical areas in the white matter of the subcortical white matter, subcortical of the short arcuate gyri. And this is probably the site of origin of these gliomas as we believe. So what we now believe is that gliomas are confined to a named white matter tract. It might be the short arcuate fiber, it might be a named long association fiber, it might be the commissural fiber, but they are confined to this named white matter fiber tract. The other tracts will be displaced around this, they will not be destroyed. The involved tract, of course, might be disrupted or destroyed. So we studied this based on a lot of radiological images, as you can see here. So this one tumor is arising from the short arcuate fibers in the region of the superior frontal gyrus. Be it high grade or low grade, they follow this pattern of growth. The growth rate might differ, but the pattern, the anatomical pattern of growth is similar. So this is arising from the region of the supramarginal gyrus. This one is arising from the cingulate, actually. It's not arising from any gyrus. It is arising from the long association fiber that is the cingulum and its connection towards the precuneus, which you can see in this anatomical image, how this fiber is, the glioma is actually growing in this direction. You can clearly see it in the radiological and anatomical image. So this is how we look at gliomas, and this is how we've classified them. If they arise from the short arcuate fibers and they are restrained to this gyrus, we call them localized. They might go to the other gyrus by means of these short arcuate connections. If they follow the path of the long association fibers, we call them diffuse. So they can be of two types. One is going across along this long association fibers, or they might grow along the commissural fibers, and when they do that, they tend to be bilateral, as we see in corpus callosal gliomas. So based on this concept, we devised a surgical strategy. Professor Goel devised this surgical strategy. Is en-masse tumor resection a safe surgical strategy for low-grade gliomas arising from the short arcuate fibers of the, of the brain? And this has been published in many papers. So look at this image now. This is the tumor. It is arising from the short arcuate fibers in the region of the superior and posterior frontal gyrus. So here you see the tumor. You can see that it is well defined and it is localized. You see this tractography showing that the corticospinal tracts are pushed posteriorly, and this is the anatomical area that it corresponds to. And of course, we used monitoring in this video, but the concept has changed and our need for monitoring is becoming less and less. We do use ultrasound. Neuronavigation need has decreased. Now you see this image. You can identify first by your naked eye that there is a line of demarcation between the normal and the abnormal. If you're not able to do this initially, you can use the help of ultrasound, which shows you a clear, well-defined demarcation of the low-grade glioma, as I might show in a subsequent image. And now you can make this plane of resection. There is a distinct feel of boundary between this normal and abnormal, and you can go around the tumor and resect it in an en-masse fashion, as you will see in this video. I'll just go forward. So now you can see only the tumor is coming out. And this is the whole tumor that has been resected. And when you've done fiber dissection, you know from the depth where actually the eloquent fibers will come, or where the long association fiber bundles start. That is also an important part of doing white fiber dissection, because you have form a rough judgment of where the long association fibers will be. And this is the whole tumor that has been removed. You see that there has not been any coagulation, because you're not actually damaging or causing any problem to the normal blood vasculature. So this is the extent of resection where you see it has been removed. This is the specimen, and you can see the motor evoked potentials are completely maintained. This is just an example of another en-masse resection. Another en-masse resection. We used to do a lot of functional and tractographic, but the need of this has reduced because the anatomical understanding has increased. Now look at this tumor. We also removed, this is going right up to the base of the cingulum. Just a little bit has gone to the corpus callosum, a high-grade part of it. And here you can see the tractography images. We did an en-masse resection in this patient. You can again make out, there is a distinct boundary. You can make out, you can actually feel the tumor when you're removing it. But this patient developed a supplementary motor area syndrome. And then we got into thinking, why does supplementary motor area syndrome occurs? And we published this based on white fiber anatomy. And we've just, in this paper, we have said that if you manage to, not damage the cingulum, the frontal echelon tract, as someone mentioned previously, this is where it is. This is the frontal echelon tract. It arises at the same level of the cingulum. If you manage to preserve the cingulum, you will preserve the frontal echelon tract, and you should avoid going up to the corpus callosum. Then again, you will avoid the incidence of a supplementary motor area syndrome, as we have published in this paper. Coming to the insula, there are many important fiber tracts that come in that region, the arcuate, the IFOF, the uncinate. I have shown all these yesterday. The other important factor while considering insular gliomas is the MCA. This is a region, this is a tumor in the region of the, in the operculum, in the region of the frontal operculum, the inferior frontal gyrus, pars opercularis. This patient we tried to do awake, but he was just not cooperative for an awake surgery. So of course we did it, and based on our understanding, did an en masse resection. I won't have time to show this, but this is the patient after surgery. Day 1. We've actually gone in the actual Broca's area and removed the tumor. This is in Indian language. I'll just go ahead. But you can see we've removed this. Again, another patient that I recently did, again in the region of the operculum. Now look at this image. You can actually make out the tumor. This is the region of the pars opercularis, and this is my resection. I've just followed the boundary of the tumor by the field. And here, as I was saying on ultrasound, you can actually make out how well defined this low-grade glioma is. And this is at the end of the resection. This is the tumor that has been removed in an en masse fashion, and you can see the post-op MRI images. This is again another tumor in the insula, which we've removed, not completely en masse because of the eloquence, but a majority of it en masse. Coming on the medial aspect, I don't have time. You've seen these images yesterday, the Pape circuit dissected in situ and then brought outside. This was our paper. We defined this point yesterday where you can make an entry into the temporal horn and go to the mesial temporal structures. And this was we used this for epilepsy surgery. And we also use this approach for medial temporal tumors. As you can see, this is a tumor arising in the region of the amygdala. So going all the way, using this approach, we have actually removed the tumor completely. Again, another tumor involving both the amygdala and the hippocampus, as you can see in the anatomical image. And this is the resection after surgery. This is a higher grade tumor, but again, it follows the pattern. And if you understand this pattern, you can go ahead and remove it. This is the tumor of the isthmus of the cingulum. It is not arising from the corpus callosum, it is unilateral, and it is from the isthmus of the cingulum. You understand where it is arising from. That will help your approach and that will help your resection. This is another paper that we've written based, how do you approach tumors that are in the base of the frontal horn, in this region, There is a short trajectory. You can come contralateral from ipsilateral side or from the contralateral side and reach the caudate head. But there's another trajectory, another safer trajectory at the base of the brain from this orbital cortical surface, and you can come laterally or medially and you will straight hit it without damaging any white fiber bundles. So this is the tumor, and we've come from this lateral orbital trajectory, as you can see, and removed the tumor. The last part is the corpus callosum. This is a beautiful structure. It developed, it came into being in placental mammals. Before placental mammals, there was no corpus callosum. Information was transmitted by the anterior commissure. Just 1 minute, please. And we studied the corpus callosum, and we've divided into these multiple radiations, the dorsal, anterior, posterior, and the ventral callosal radiations. So basically, the corpus callosum envelopes the whole ventricle within its radiations, and this was the study. And this helps you devise a strategy for corpus callosal tumors, which I don't have time to get into. This is not a bizarre tumor. It's arising from the corpus callosum, and you understand it, and you'll be able to resect. Lastly, we've also studied the brainstem, and these resections have been performed by Sukhdeep, and you can see how beautifully all the fibers have been delineated. Based on this understanding, we've actually classified also fibers of the brainstem and defined our safe corridors of entering into it. And all this information is available in this book. I thank you for your attention.
Thank you, Dr. Abida. Can I call upon the next speaker, Dr. Saito, to speak on intraoperative awake brain mapping for the patient with diffuse parietal gliomas.
Okay, first I'd like to thank Dr. Goel and the organizer for giving me a chance. Doesn't work. Sorry, I'm now distorting the computer.
Okay, could we call the next speaker, please?
I'm sorry, I'll come back right away.
Dr. Nakajo, to speak on dissection technique in malignant brain tumor surgery. Is it coming?
Yeah, thank you. I appreciate you invite me. I'm first trip to India. I really enjoyed this conference and also the cadaver dissection and this meeting. I'm from the Osaka Metropolitan University, so my mentor is Ohata and the Professor Goto. Especially Dr. Goto taught me the, how to dissect the benign tumor and craniotomy. But I mainly how to dissect the glioma. Dr. Maruyama, Tokyo Women's Medical University, I really appreciate them. Principle in dissecting glioma, most important thing is discrimination of tumor is the most important, I think. I try to discriminate the healthy brain and tumor. In case of a low-grade glioma, T2 flare hyperintensity area is a tumor itself. But high-grade glioma, T2 flare hyperintensity area is edematous brain or sometimes a tumor invasion. But fundamentally, I at first find out the tumor and the healthy brain and trace the border between the tumor and the healthy brain. This is a fundamental technique in resecting a glioma. But I didn't have a contradiction about the usefulness of supramarginal resection about the glioblastoma. In Japan, the study of the flarectomy or supramarginal resection is started. And then we found out the border tumor between tumor and the normal tissue. We have to dissect between tumor and the surrounding brain. Bipolar melting technique is very useful to dissect and discriminate of the tumor, but sometimes the lower grade glioma, there is a function into the tumor, so monitoring and AWACS surgery is mandatory to the glioma surgery. This is a bipolar melting technique. This is a tumor originated from the SMA. When we coagulate the tumor here, the fragile tissue is spontaneously sucking the like this, and yeah, and the appearance is very important. The tumor is relatively in this tumor is soft, and vascularity is relatively high, and this is a grayish tumor. But outside of the grayish tumor, when we coagulate and use the bipolar melting technique, the fragile tumor is sucking. In this area, we stimulate the brain. The patient difficult to stop the moving upper extremities, and also the anomia is detected. So this is a symptom of the frontal ascending tract. This is a deep-seated glioblastoma of the parietal lobe. We cannot choose the awake surgery because of his age and symptom. So we try to find out this tumor and the brain, healthy brain here. Right side is a tumor, but the white one is a healthy brain. This is a feeder. We coagulate and trace this border between the tumor and the healthy brain. Of course, the surrounding tissue, in case of the glioblastoma, there is invading some tumor. But this is a general anesthesia where we don't need to flarectomy, supramarginal resection. This is a total resection, and this is a relatively giant tumor. The tumor daughter region is located the deeper side of the Heschel gyrus. But we follow the using this melting bipolar technique, and we can resect safely, and the total resection was performed. This is our result of glioblastoma. The 20 years have passed since the STUP regimen, temozolomide using and concomitant radiation therapy, but our result is median overall survival is more than 2 years. This is a big insular glioma. He didn't have any deficit. And insular glioma, the lenticular striatal artery and the long insular artery is a critical issue to avoid the postoperative motor weakness. The zone 2, this is a Sanae-Berger classification of the insular glioma. Zone 2 is the posterior part of the insula. This is a long insular artery arising from the superior peri-insular sulcus of zone 2. So this is the most dangerous part of the insular glioma. We choose the awake surgery. Before the wake-up condition, we open the Sylvian fissure widely. But we cannot get to the enough surgical corridor. Number one is the pars opercularis of the inferior frontal gyrus. And we internal developing of the tumor, and this is the olfactory nerve. So medial side of the olfactory nerve, there is a rectal gyrus, and this is we found out the gray matter. This is a sorry, the name. Lateral side of the abdomen. So we stop the surgery. Deeper side of this area, there is a LSA running. This is a zone 4, temporal side of the tumor. We use the melting bipolar technique and spontaneously open the inferior horn of the lateral ventricle. This is the final part of the tumor. We rarely use the QSA. Yeah, this is the final view. We remove the pars opercularis and triangular part of the inferior frontal gyrus, so we can get the wider corridor. We intentionally live behind the tumor at the most posterior part of the rectal gyrus and the orbital gyrus. But we achieved the gross total resection of the tumor, and the patient showed transient aphasia, but no eternal deficit. We have no time. This is a temporal huge grade 3 astrocytoma. Already this tumor is herniated, so we planned a staged surgery. Initial surgery, we resected the anterior part of the temporal lobe. Then the patient improved her condition. So this is there is a sagittal stratum. There is a lateral side of the trigon part of the lateral ventricle. There is many crucial fibers such as arcuate fascicle and the inferior frontal occipital fascicle. So we chose the awake surgery, and we detected the IFOF. And postoperatively, she didn't show any aphasia, and then no homogeneous hemianopia. Of course, she showed quadrant hemianopia, but this is a grade 3 astrocytoma, but there is no recurrence more than 6 years. This is a controversial case, very difficult supramarginal gyrus and angular gyrus grade 2 astrocytoma. She is a truck driver, so we would like to prevent the postoperative hemianopia because of the driver's license. We choose the awake surgery, and anteriorly at the supramarginal gyrus, we detect the arcuate fascicle, and inferiorly we detect the optic radiation. And postoperatively, she showed only the quadrant hemianopia, but the most part of the tumor is leave behind, especially the inferior part of the tumor. So there is a controversy. Conclusion: the bipolar melting technique is useful to discriminate and dissect between tumor and the normal brain tissue. Thank you for your attention.
Can we call Dr. Saito? So he'll be talking on intraoperative awake mapping for patients with diffuse parietal gliomas.
Hopefully it will work. Looks like the resolution program. Thank you for giving me the second chance. It was a problem with the resolution. My talk today is about the intraoperative awake brain mapping for the patient with diffuse parietal gliomas. I have nothing to disclose. And when we think about the dysfunction of the parietal lobe, there's a lot of symptoms. These are the representative symptoms. If it's the left side, it's if the dominant side, conduction aphasia, Gerstmann syndrome, and many much more. And if it's the non-dominant side, you need arteriospatial agnosia, dressing apraxia, and many things. So there's a lot of things we have to care about when we perform the surgery for the parietal lobe tumor. And during the surgery, we use the awake surgical mapping. And if it's the dominant side, we use the task like in the right side of the slide, language task, writing task, reading task, line bisection task, and so on. But we already know that awake functional mapping helps us preserve the brain function. But the clinical question here is, does the task we use for awake surgery helps us to preserve higher brain function because we cannot check everything during the awake surgery. So we retrospectively analyze our data of patients we use awake craniotomy to remove parietal gliomas. First, I'll present our representative case. This is a 40s male, right-handed patient with the tumor at the left inferior parietal lobule. There's a T2 high signal. It's a glioblastoma, so there's an enhancement inside here. And in this patient, just the difficulty in calculation was found. Only multiplication was somewhat impaired, and there was no dyslexia, no dysgraphia. And we did the neuropsychological testing, Wesley, WMSR, and SLTA. The number here is somewhat preserved, so there was no major deficit. But we just found a slight disability in calculation. Just the multiplication was disturbed. No other obvious decline was observed. So this is a tumor, and this is a finding from the fibers, inferior frontal occipital fasciculus. SLF was running at the bottom of the tumor. So this is the result of the cortical mapping. At the cortical mapping, this light size is anterior, posterior, and the body. So there's the end of the Sylvian fissure here, and it's a parietal lobe. So the tumor was around here. We found some language symptoms around here. So this is just showing our mapping. We did our, the sound is not coming, but picture naming. We're now doing the picture naming. I don't know. I'm sorry, there's no sound here, but so with the stimulation of the brain surface and also in the deep subcortical stimulation, we found some disability, and this is a leading task, and also we are doing the writing task. But I skip here. But this is a result of our subcortical mapping. At the fiber, there was a fiber running in the bottom of the tumor, but at this number 31 here, we found disturbance in the naming task, leading task, writing tasks. No any other symptom was found, and we finished the surgery here. So, from 2012 to 2023, we operated 257 cases with the awake surgery method. And among these, 27 cases of parietal glioma were analyzed. Items investigated was resection rate, post-op neurological deficits, pre and post neuropsychological testings. And these are the characteristics of the patients. Age was around 44. Many was grade 2 or grade 3 gliomas, and left side was dominant. And there was a parietal lobe distribution of the tumor, and the resection rate was quite high like this. Even we removed the most part of the tumor, there was minor post-op neurological deficits. Only some transient deficits were found, but many of them were doing fine. And the problem is the neuropsychological testing. Here's the data of our Wesley. We just found some decline in the performance speed in the very bottom of this table. And any other items we found any difference between the pre and post-operative. And this is WMSR, and these are not damaged. So here is the conclusion. Surgical strategies against gliomas needs to consider from oncological aspects and the functional aspects. Preservation of higher brain functions by awake brain function mapping is effective for parietal gliomas. The parietal lobe has a variety of brain functions, so accumulation of knowledge is important. Thank you very much for your attention.
Okay, so next I would like to invite Dr. Solanki. Is he here? Oops. Nope. Then it can be Dr. Panika, glioma involving the supplementary motor area.
Okay. Thank you, Professor Goyal, Dr. Apida, for inviting me, and it's good to meet a lot of familiar faces. Nice to be here. My talk is on the gliomas affecting supplementary motor area. As we know, the supplementary motor area was described as an area that is just anterior to the primary motor cortex, but functionally distinct, where as described by Penfield and Welch, it was a supplementary representation of the motor homunculus in that area. The SMA is divided into a SMA proper and a pre-SMA, and is located at the medial edge of the posterior part of the superior frontal gyrus and extending down the medial surface of the hemisphere. So why is this important? The frontal lobe, as we know, has a great propensity for development of gliomas, with 40% of gliomas in the frontal lobe, and many of them do affect the SMA. And it has been reported that up to 10% of de novo glioblastomas and up to 27% of grade 2 gliomas occur in this region. What is important about this area functionally is the fact that the behavior can be a little bizarre. When we talk of the goal of treatment, that is the radicality of resection, as we know, that is very important in gliomas, the radicality of resection versus preservation of functions. In the SMA, you have this very peculiar phenomenon of a sudden loss of function, which can be delayed but has a tendency to recover. Now, this was initially described by Laplaine as early as 77, where he described in a set of patients as a sequence of 3 events that characterize the syndrome. One is an immediate post-operative hemiplegia or severe hemiparesis, followed by a motor improvement, and long-term sequelae that involves mild dysfunction of especially of coordinated movements and alternating hand movements. Now, this is a case of a young gentleman, a high-functioning individual. He's a banker, right-hand dominant, who presented with a single seizure and on imaging had this large lesion. He had normal higher mental functions and no deficits. Now, he underwent an awake craniotomy and tumor resection with cortical and subcortical mapping. The primary motor cortex was identified posterior to the lesion and was stimulable, and he underwent an uneventful tumor resection. However, at the end of resection, during hemostasis, he developed a sudden drop in power on the left side, the upper limb deteriorating to 355 and the lower limb to 0. However, the reflexes were preserved, the tone was preserved, and the plantars were flexor. The primary motor cortex was still stimulable, and twitches were elicitable on direct stimulation. So this was classically the SMA syndrome. The histopathology showed this to be an oligodendral glioma. The transformation to grade 3, he underwent chemoradiation. This gentleman recovered, took time to recover, a complete recovery, almost 9 months, and it took him a year to return to work. A cognitive assessment at 15 months showed mild memory disturbance and some difficulty in multitasking, some coordination difficulty, but he had a good quality of life and reasonably intact function. He remains disease-free at 6 years post-treatment. Now, when we talk of the supplementary motor area, what is the spectrum of abnormalities that we can encounter in them? You have motor, you have speech, you may have no deficits in them. The motor involvement, there are a whole set of them that are described. They're very similar to the corticospinal tract lesions, except for the fact that they have preserved tone and normal reflexes. There are a variety of other abnormalities, especially the important thing being a delayed motor weakness. And initially, you have a slowness of movement in coordination, difficulty in dual responses, alternating movements. So these are the hallmarks of the SMA syndrome. The speech abnormalities are largely on the dominant side, which present with a difficulty in initiation and maybe going on to a transcortical motor aphasia. Now, the interesting thing here is the delay in the onset of the deficit. And why does this happen? It has been postulated that there are parallel loops, and as the tumor is resected, as the SMA is resected, these loops continue to function. And the residual activity prevents the deficit, but does not allow any new activity. And that is why, as these die down, the deficit appears. The incidence of SMA syndrome has been postulated by various authors and to be linked to different issues. It could be the increased extent of resection of an active supplementary motor area. It could be the distance from the resected area to the SMA, the proximity to the precentral sulcus, and so on and so forth. The greater the extent of resection, the greater the probability that this person will, that your patient can develop an SMA. How does a SMA syndrome recover? As I said, 90% of the patients recover in a time span ranging from weeks to months. The persistent paresis has been linked to the resection extending into the cingulate gyrus, into the corpus callosum, and the tumor invading into the primary motor cortex. The mechanism of recovery, again, different mechanisms have been postulated, including activation of the contralateral supplementary motor area. And this is where the callosal loops are important, because the activation of both the SMAs, the role of the uncrossed corticospinal tract, and the crossed frontal Aslan tract, which has been described as a possible mechanism for recovery here. So this is where the issue with the resection extending down into the corpus callosum comes in, where the crossed fibers and the activation of the uninvolved contralateral side can impede the recovery. Having known all this and since we all consider that the SMA syndrome is reversible, can we discount it? I don't think it can, because functionally, many of them do experience a fairly long-term deficit, and the impact on their quality of life can be significant, even though they may recover a fair amount of movement, but do they remain functional? The recovery may also not be complete or even predictable. And persistent deficits, especially in bimanual tasks and fine coordination, can remain to be an issue. And this has been shown in multiple studies, where it's shown that up to 20.3% of patients suffer from permanent symptoms, both motor and language. This is another patient. Similarly, a large lesion, a high-functioning individual, young lady, a dentist, who was very, very particular that she did not want any deficit whatsoever. She was counseled about the fact that there's a large tumor, possibly aggressive, and we should try to get the tumor out as completely as possible, but she was very particular that she did not want any deficit. And this is where the value of detailed intraoperative mapping comes in, where using tractography, we were able to study the tracts around the tumor, and we were able to find the Aslan tract that was skirting around the posterior edge of the tumor. And she underwent an awake craniotomy using a series of tasks, which I will talk about in a bit. And there she had deficits which corresponded to the location of the frontal Aslan tract. And at that point, the resection was stopped, and she had the small residue of tumor that is exactly around where the frontal Aslan tract was, but she was intact. I think this is the important thing, that if you know and understand the SMA syndrome and what causes SMA syndrome, you can map the functions and you can prevent a lot of these deficits. So this again comes with the question that you want to extend the resection, and the surgeon often decides to extend the resection, but it's a choice of the patient whether they are willing to accept even a deficit or not. And this is something that has to be discussed with the patient and understood, and the plan of surgery has to be understood very, very clearly by the entire team. So we had a number of patients with this. I will just go, and these are the protocols that we follow for mapping the SMA. We use central sulcus mapping in all cases, motor cortex mapping using positive activity. The SMA mapping is generally negative stimulation mapping, where you ask the patient to perform a series of programmed tasks, especially the dual tasks, which may involve language and motor, or alternating tasks, and look for a motor arrest during that time, and that combined with the subcortical mapping. So a whole series of intraoperative tests are also used that can elicit, identify the functional deficits in this region. So these are some of the tasks that we do. The dual tasks, the patient is relating a story and at the same time doing a motor movement and looking for an arrest during stimulation. Alternating hand movements, where you look for discoordination or a breakdown in the movement with stimulation. These are things that will tell you that you are in a functional area, that you're in the SMA. So this is another example of a person who improved very rapidly in a week. So again, when the SMA, so again, the extent of resection is important, and the time taken to recovery is often, can be hastened by early onset of rehabilitative measures, both language and motor rehabilitation. And again, the role of the cingulum and the callosum is very, very important, because you damage them, the deficits tend to persist longer. So in summary, lesions affecting the SMA can have this unique clinical behavior. Proper mapping can tell you about the functional deficits and the functional status. It's very important to discuss with the patient beforehand so that everyone involved has a very clear idea what is the goal of surgery and what to expect. And early rehabilitation is very important. Thank you for the patient here. Thank you.
Okay, now next I would like to bring Dr. Salanki up to the stage, and he'll be talking about cerebral mutism in medioblastoma surgery.
Thank you, Mr. Chairman. I appreciate your ability to flip things around. Yes, so, okay, I'm going to stand here. So I'll be delighted to present our experience. So this is a study that the Children's Hospital in Birmingham carried out with the National Children's Hospital in Washington, D.C. So the two groups, so that Roger Packer, who works at the National Children's Hospital in Washington, and his neurosurgeon, Bob Keating. So we agreed to do this study together. And the idea was that we would look at the practice of two large units doing medulloblastoma surgery, and what are we doing to improve the outcome of these children in terms of reducing cerebellum mutism. I think I won't waste too much of your time. Everybody knows what medulloblastoma is. You know, the survival is not 100%. We're still getting there. The currently available therapies is still maximal tumor resection, so that is still the gold standard, even though there is some variations now appearing. Radiation therapy of the entire brain and spinal cord, particularly in children above 3 years and above, and aggressive chemotherapy supplemented by bone marrow transplant is a very aggressive malignant tumor that requires aggressive therapy. Now, it's not always easy to diagnose an MRI scan. If you see here, there are 5 examples of tumors of the posterior fossa in the midline. And in fact, when you look at the diagnosis there, only the second one is a medulloblastoma, but they all look the same. So we cannot, with absolute certainty, make a radiological diagnosis of medulloblastoma. Then, of course, the WHO has been trying to grade the medulloblastomas. The main definition that we knew so far was the classic histological definition of 4 grades: desmoplastic, medulloblastoma, classic medulloblastoma, anaplastic medulloblastoma types, and grade 4 medulloblastoma, essentially. And then in 2016, the genetic classification came in about Wnt, sonic hedgehog, non-Wnt, non-sonic hedgehog tumors, which was then added to the 2007 classification, as you can see here. And then since then, of course, further molecular work has demonstrated that, in fact, even the 4 groups, the Wnt, sonic hedgehog, group 3 and group 4, are subgrouped now into 12 groups. So there are 12 subgroups. Each one of them has a different outcome. And that is why it's so particularly important. So the 2021 classification now includes a layered report structure that includes the genetic classification, whether it's Wnt, non-Wnt, non-Wnt, non-sonic hedgehog, or Wnt or sonic hedgehog tumor, classic medulloblastoma as the histological classification, then the WHO grade, and then additional molecular information on the MYC amplification and chromosomal copies and so on. So for us, we're interested in, right now in this presentation is the risk groups. So we know that medulloblastoma can be classified in 3 risk groups: high, standard, and favorable, depending on the presence or absence of beta-catenin. For example, a tumor that is in a child more than 3 years old and is a Wnt tumor, then we know this is a standard risk. And the high-risk tumor is those under the age of 3 with metastatic disease, high-risk histology, MYC-C or C-MYC amplification, group 3, group 4, and sonic hedgehog TP53, which provides very poor risk and makes radiotherapy difficult. This is another risk classification for infant medulloblastomas. It's very similar. And then there is the surgical considerations. What are the things that we do during surgery that might increase or decrease risk? So we looked at those things as well, positioning and all of that stuff. The tumor, I'm going to jump the video because I think everybody here knows how to do posterior fossa surgery. But essentially, I do a midline approach, simple arachnoid exposure. I usually go to the telovular approach there, and then expose the tumor. You can see the tumor coming there. And then I take some tumor out for a biopsy, and then open the telochoroid to create more space, lift the uvula up, and once the uvula is then lifted, the tumor then comes into view, And then once the tumor comes into view, you can quite easily remove the tumor, protect the flow of the fourth ventricle, usually with the patty, and then take the rest of the tumor out, and that's it, okay? So this is a highly videoed, choreographed image just to show you it was mostly for trainees. So once we move on from there, you get postoperative complications. The commonest one, of course, is posterior fossa syndrome or cerebellum mutism, 20% incidence in the literature. 1 in 5 cases will get it. And the suspicion is that it's damage to the dentate or dentato-thalamo-rubrocortico frontal tract. So some people call it cerebellum mutism syndrome. And then if the features are more consistent with posterior fossa features, like ataxia, emotional ability, cranial palsy, poor swallowing, then they call it posterior fossa syndrome, which seems to be a more extended definition of not just mutism, but other features as well. So this definitely have neurocognitive issues, feeding difficulties, cortical blindness in some of these cases. In fact, it could be that it's under-described because cortical blindness seems to improve before mutism improves, so they're not actually able to tell you that they're blind. But it's cortical blindness and it's temporary and it resolves. And then, of course, the pathophysiology is a matter of great debate, but we believe that this is because of focal decreased cerebral and cerebellar blood flow. When you think about how does it explain what happens in the frontal lobe, the commonest and the most likely explanation is that it's cerebello-cerebral diaschisis. What does that mean? It means we have done something to the cerebellum, and as a general response that the brain has of causing vasospasm to a whole brain as a protective mechanism, you get cerebral response. And this response, which is further away from the point of injury, is called diaschisis. So cerebello-cerebral diaschisis. And as you can see here, there's a cacophony of symptoms affecting pretty much every single part of the brain activity, neurobehavioral, motor, linguistic, everything is affected. Swallowing, speech, ataxia, and so on. So how does it happen? So the common explanation and the most agreed explanation is that while we're doing surgery in the cerebellum, we somehow cause white matter tract injury. It's certainly not permanent because all patients recover. There's not a single reported case of cerebellum mutism not recovering. So it's temporary. And it must happen suddenly because immediately after surgery, the patient, within 48 hours, shows evidence of quite profound mutism and stops talking. And the suspicion is that something happened during surgery, and surgery is the culprit. Right now, there's no data that we have that something happened before the surgery. So, for example, nobody's assessed for mutism before surgery, so we can't tell. But the suspicion is that it was a surgery. And if it was a surgery, what was it? What did you do? Where is the evidence? So we then looked at the radiological data, preoperative, postoperative. We looked at what do we do intraoperatively. We looked at blood loss and all sorts of other features. And the presentation today is based on that. And of course, this is recovery. I will jump this because this is not important for what we're going to look at. So if you look at the literature, these are the potential factors associated with cerebellum mutism. You can see age, the size of the tumor, location, surgical approach, tumor size, tumor type, injury. If we look at our clinical study, so what we got here is that Bob Keating and his team reported their sequentially acquired data and the reducing incidence of cerebellum mutism over 20 years. And they've reduced the incidence from 36% to 10% in the States. We didn't have detailed data going back that long. We didn't actually know how much mutism we had 20 years ago. But what we had is a very real-time database that goes back about 15 years, from 2007 to 23. So we use that data to look at current practice. So we have overall, over the 15-year period that we studied, 18% incidence of cerebellum mutism, We only looked at one tumor, medulloblastoma, so it's 16 cases out of 88 had cerebellum mutism. And we looked at all the other factors there. So what we found, essentially, I think this is going back, isn't it? So my apologies, I'm pressing the wrong button. Yeah, so this is the data in detail. So you can see that males were 2.5 times more affected than females. And what we found in our data was that midline tumors which were large, more than 4.5 centimeters, medulloblastoma, high-risk patients, patients presenting with metastasis at presentation and brainstem invasion, they were at the highest risk of developing cerebellar mutism. These are all features that are preoperative. We can see it on a brain scan, okay? So that means that this child already came with the potential for developing cerebellar mutism far more than any other child that, for example, had a lateral tumor, so sonic hedgehog tumors. So in our series, Chairman, can I have some additional time to finish? Okay, thank you. So in our series, we do not have a single child with medulloblastoma, sonic hedgehog, or Wnt that develops cerebellar mutism. Only midline tumors. So that's a very important preoperative feature that we can talk to the family when consenting. They say, your chances of getting cerebellar mutism are more important. So this is the relevance of double hit theory. So what's a double hit? A double hit is somebody that comes already has got the first hit. And the first hit is this tumor that's in the midline, is invading the brainstem, presents with metastasis, is a high-risk medulloblastoma. That means less than 3 years, and the features are described before. And the tumor size is more than 4.5 centimeters, more towards 5 centimeters. So this is the first hit. This patient has arrived likely to develop cerebellar mutism. Then we looked at interruptive variables. So on the interruptive variables, the common belief is that the Vermean approach causes cerebellar mutism. So we looked at our series, and over 15 years, I got my senior consultant colleague, Mr. Walsh. He only does Vermean. He had never learned to do televelar, and he's not interested in doing it. So he only does a Vermean approach. He does it very well. And I only do a televelar approach. So I was really happy thinking, I'm going to get a good result, and Mr. Walsh is going to get terrible kid. But in fact, it's exactly the same. There's no difference. And that data has been validated in multiple studies where the whole procedure, for example, departments where only the televelar approach is performed, they still get 20% incidence of cerebellar mutism. So it can't be the approach. And then, sorry, the second feature that we identified was the blood transfusion. Now here we found a statistically significant finding in that patients that underwent blood transfusion in our hospital had a far higher chance of getting cerebellar mutism. Now, why is this important? In the UK, you only get a blood transfusion, so you can't, as a surgeon, say, can you transfuse some blood? The blood is looking thin. The anesthetist won't transfuse the blood, because they have something called the National Restrictive Blood Transfusion Policy. You can only transfuse blood if certain features are met. One is the HB has dropped below 8. Second, if there's been a very rapid blood loss of blood where the blood pressure is catastrophically dropped, the patient becomes hypotensive and is a risk of going into hypovolemic shock. Third, the patient has lost the ability to coagulate, means it's lost hemostasis. So there are very specific features that result in the anesthetist urgently transfusing blood. So those are the patients that get blood transfusion. Every medulloblastoma is going to bleed. Most of them might need some blood, but what we're talking about is the rapid blood loss that forces the anesthetist to transfuse blood immediately. So in those cases, you have to believe that this must be an arterial bleeder. That means you've got an arterial bleeder. And it's the same situation like in subarachnoid hemorrhage. When an arterial bleed happens anywhere in the brain, what is the first thing that happens? The patient goes into vasospasm. So we believe that a posterior fossa pediatric cerebellar mutism is akin to the development of acute vasospasm secondary to an arterial bleed. We're not talking venous bleed, arterial bleed. That's why lots of patients will bleed but will not get cerebellar mutism. when we looked at postoperative variables, none of those were significant. So we were not able to consistently identify any of the T2-weighted hyperintense changes that we normally see in the middle, superior peduncle, or even the inferior peduncle with the inferior olivary nucleus. We have not been able to confirm that, so we didn't find any statistical significance. So therefore, we can say that in our study, midline fourth ventricular tumors, large-sized tumors, brainstem infiltration, were associated. This was the first hit with cerebellar mutism. None of the postoperative features were actually associated with cerebellar mutism. Therefore, when we talk about the double hit theory, we talk about patients presenting with this preoperative MRI findings and that suffered exsanguinating hemorrhage intraoperatively, and that is the double hit. That means during surgery, you did something else, which was the bleeding, that resulted in the potential cerebellar mutism. Now, the Children's Hospital in Washington felt that in their series, they felt that the telovular approach made a difference, and second, the use of CUSA. So this is a surgical tool. So they stopped using the CUSA. So more than 10 years now, they've not used the CUSA because they believe that the heat produced by the tip of the CUSA could be contributory to this. So since they've stopped using CUSA, they believe that the incidence of cerebellar mutism has dropped. But we know that the regulation, the cycle period, the work period for the CUSA is 5 minutes, and then you get 5 minutes of stoppage. And what happens is, I think we inappropriately use the CUSA for 15, 20 minutes non-stop, and that is when the heat is produced. So it's important to take breaks when using the CUSA, flush irrigation to reduce the temperature in the tip. So, and I'm just going to finish now. So essentially, intraoperative blood loss is the main cause, in our opinion, of the double hit. And there is multiple evidence coming out from other studies as well that when you suddenly lose blood, you lose blood flow to the white matter. The arborization of the arterial blood flow to the brain comes from the surface of the brain. As the blood then trickles down like a tree, from the top of the tree down to the roots, if you have enough blood, the white matter, which is in the center of the brain, will get the blood. If you don't have enough blood, all the blood is necessary, it will stop at the cortical level. So the cortical gray matter is the critical matter. The brain will preferentially send the blood there, and then it will stop sending any more blood down to the white matter. So this is how, if you suddenly lose blood, you're going to get the white matter injury, and the longer the tract, the more likely the tract is to suffer ischemia and vasospasm with decreased cerebral blood flow, which we can identify now on FLAIR imaging using the hyperintense vessel sign, and we're currently carrying out a study looking at that. So because of these results, I then asked other databases, and the Nordic European CMS study database is a huge database with thousands of patients. So I wrote to them and I said, have you also noticed the double hit theory where your patients have also suffered bleeding? So they looked into their database of 565 patients, much more than my little series of 88 patients. These are all medulloblastoma cases. They wrote to me to say that in patients where, so this is data given by the surgeons, where the speech means mutism. So the estimated blood loss, they felt that that was statistically significant. Excessive bleeding, definitely significant, and so was blood transfusion. So they believe that there is an association in their data as well. So that kind of makes the point that this is probably a significant finding. I would encourage you to look at this and avoid losing as much blood as possible. And next step, of course, would be to try and treat vasospasm with nimodipine on children that you believe could be at risk of CMS, and consent parents for that possibility and provide treatment for that. So that's one thing. And the second thing, of course, is try to, on highly vascular tumors, try to devascularize the tumor either by embolization or preoperative chemotherapy. And then, of course, postoperative therapy for vasospasm. And I want to thank you for your patience.
Okay, we are calling on the next speaker. He's Dwarkanath. He will be speaking on operative approaches to brainstem cavernoma.
Thank you, and I'd like to thank Professor Goel sir and Abida for inviting me. So, just a brief introduction of brainstem gliomas. This basically is more of a utility of how to the various skull-based exposures in treating brainstem cavernomas. Finally, at the end of the day, you need to have a good exposure of the location to actually take out a brainstem cavernoma safely. Thank you. So why operate on brainstem cavernomas? There is enough data to suggest that those cavernomas, brainstem cavernomas, which do not present with ICH or focal neurological deficits, chance of bleed was around 8%, the risk of ICH over 5 years. But those which presented with either ICH or focal neurological deficit, there was a 31% chance of bleed for brainstem cavernomas, which was much more significantly higher than that of supratentorial hemangioma, cavernous hemangiomas. The median time to rehemorrhage in brainstem was less, around 11 months. And therefore, it was proposed that observation is probably a good modality only in those incidentally detected cavernomas or asymptomatic unbled brainstem cavernomas. So there was a trial of propranolol in treatment of familial CCMs, but the role is still unclear at present. Some centers use it, some don't. So what are the controversies? One is, of course, the indications of surgery due to complexity and lack of expertise. Evidence of surgery after single hemorrhage in supratentorial is weak, but it's probably more stronger for brainstem. So some authors do advise resection for symptomatic CCMs, while repeat hemorrhages and clinical deterioration, mass effect caused by hemorrhages are an absolute indications for management. Again, a debate on the timing as to whether you would like to do it on the acute phase, subacute phase, or a chronic phase. Most of us, including me, prefer the subacute phase where the patients have stabilized neurologically and the hematoma liquefaction has started occurring. Of course, the principles remain the same. You identify the best trajectory to approach the cavernomas and do the complete removal. Associated DVAs should be preserved because these are quite commonly associated with cavernomas, and you need to identify the safe entry zones. So basically, cavernomas can be divided into those which surface posterior or posterolateral and anterior or anterolateral. Of course, various approaches have been described, and each of them have their own surgical techniques which you need to be well versed with. So I'll just go through some few examples of how we approach the tumors. So this is a classic pontine cavernoma which is surfacing onto the fourth ventricle, and this is a standard prone position, telovelar approach. The important thing is here is to have good monitoring of the, do a SSCP, MEP as well as cranial monitoring, because you need to identify the safe zone. I will not go into the these things, but what I will do is I will just show you the importance of monitoring, because monitoring actually decides, monitoring actually decides where you make the incision on the where you make the incision on the brainstem and avoid the. So here we are mapping the seventh nerve. So once you map the seventh nerve, you know where is the approximate entry, and then try going lateral to it and then entering the brainstem. So here actually, even though this was the shorter route, you could see a slight yellowish discoloration. You go lateral to it because that's where that's where it is silent, and then evacuate the hematoma and then evacuate the cavernoma. So this is the cavernoma excision. You could either excise it in piecemeal or in toto, depending upon the cavernoma and depending upon how easy it's easy to dissect from the surrounding tissues. One important thing is, unlike this is a hematoma, this is a cavernoma of the tectal plate, and these patients need a little bit more of monitoring. This we do in the sitting position. Of course, sitting position needs a lot of important adjuncts, including the transesophageal echo, where you can see that to monitor whether the air is entering the heart chambers or not, and probably you need a CBP line to aspirate the clot. So this is the cross-eyes approach. Again, I'll just quickly run through it. This is a supracerebellar infratentorial approaches, and here again we are going to this is the posterior third ventricular region. You can see the vessels over there. It's important to preserve them as much as possible, and then again use navigation guidance to find the optimal entry zone, and then enter the cavernoma. One important difference between, you can see, start seeing the yellow discoloration over here, and you can see the fourth cranial nerve here. One important distinction between supratentorial and infratentorial is that supratentorial, because they are epileptogenic, you generally have to remove the yellowish discoloration, while in brainstem you don't have to do it because they are non-epileptogenic. So this is an important thing, that you should not be chasing the yellowish discoloration on the surface of the brainstem, because it leads to unacceptable deficits. So once the again, this is a standard dissection of the cavernoma. Go around the tumor, and this is the cavity. Initially we used to do it microscopic. Now we have started doing endoscopic assisted or purely endoscopic, in which we use the endoscope as an exoscope and remove the tumor, remove the cavernoma. So this is the inspection of the cavity. So similarly, this is another patient with a tectal cavernoma where it's been removed in toto. Then again, there are different variants. So the tumor can still surface laterally. This again would involve the modification of the midline approach. You would do the lateral supracerebellar infratentorial approach again in a sitting position. So the important thing is, like what I would like to say, is the steps remain the same. You identify the yellow zone, make sure that you're entering at a smaller the trajectory, do the monitoring, see whether it's safe to enter, and once you enter and excise the cavernoma, so this is what I was saying. Then we use the endoscope to inspect the cavity, and you can see the complete excision of the cavernoma. So this is the post-operative image of the video of the patient at the time of discharge. So what about medullary cavernomas? Medullary cavernomas are slightly more difficult because the respiration is a major issue here. This patient, we got total excision. The patient did well, but had to be with a tracheostomy for almost 2-3 months. So then we were successfully weaned him off and sent him home. The anterior and the anterolateral surfacing cavernomas are slightly more difficult because they need a more extensive skull-base approaches. If they are pointing upwards over here, you could either use a subtemporal approach, a transtemporal approach, or combine it with an anterior petrosectomy. But if it's below the internal acoustic meatus, then you'll have to probably use a posterior petrosectomy, and if it is surfacing even further down, you'll have to probably use a far lateral approach. So this is a patient. If you can see the anatomy over here, it is around the tent. So this is a patient would be an ideal for a subtemporal transtentorial approaches, which is what we did. This is the tent being cut, and once the tent is cut, you can see the cavernoma surfacing. This is the fourth now over here, and this is the evacuation clot, and this is the post-op imaging. These are slightly more difficult. You probably need to do a Cavazes approach because the cavernoma is surfacing much below the tent over here compared to the previous patient. So, which is what we did. These are even more inferiorly and anterolaterally coming out at the level of the internal acoustic meatus. So, if you do an anterior petrosectomy, you will not be able to reach these surfacing lesions. So then you'll have to do a retrolab posterior petrosectomy pre-sigmoid approach, which would be a combination of a retrosigmoid subtemporal craniotomy, then do a tentorial cutting. And once you do the tentorial cutting, this is the skeletonizing the transverse sigmoid junction. This is the sigmoid sinus, this is the Trotman's triangle. This is the temporal dura being cut, sorry. So this is the temporal dura. Once the temporal dura is cut, this is the tent which is being coagulated and cut. The petrosal sinus is of course ligated and cut. And once you cut the tent, you get a direct access to the fifth nerve and the superior cerebellar artery. So this is where we are dissecting around the fifth nerve and the superior cerebellar artery. Here the navigation is very important because it gives you where the cavernoma is surfacing, and also neuromonitoring because it identifies any possible areas where stimulation can occur. So this we are dissecting around the fifth cranial nerve to see where we can identify the cavernoma. Again, it's very important to remember that where it surfaces is probably the safest area, but there might be occasions in which it might not be very safe. So then you use a navigation. It's 2 minutes. So, and once we have localized the lesion, we are doing a corticotomy here, and then the lesion is excised in toto here. That is the cavernoma coming, which is excised in toto. Now, these are a little more complicated. This is an anteriorly superiorly surfacing in which it's going to the midbrain and then coming up. So this would be difficult to come from a Cavazes or a subtemporal approach. So we did we came like this. We came through a transcallosal transventricular approach and excised the cavernoma completely. So the important thing about cavernomas, so our patients, we have the Lawton's grading. I'll not go into that. Unfavorable risk factors include size, preoperative status, compromise of low cranial nerves, and hemorrhagic recurrence before surgery. These are some of the big series in literature. Steinberg's favorable predictors included good preoperative MRS ranking and single hemorrhage. Our experience, we have managed around 37 brainstem cavernomas, and we had 3 deaths and persistent morbidity in 8 patients. There has been, this is the last 2 slides, these are the controversy on gamma knife in cavernomas. We generally don't give, but there has been evidence that over the past decades, there was a mistake in giving high doses of cavernomas, treating them as equivalent to AVMs rather than treating them as more benign pathologies. So there have been newer studies in which the doses has come down to around 11 to 12 gray mean marginal dose at 50% isodose line, which says that the risk of bleed has shrunk. So, but it has its own pitfall. This was a patient who was given SRS of the cavernoma. They just burned the brainstem. This was done outside. The patient came with severe tremors, and we had to do a lesioning for this patient to control the tremors. The problem with SRS is that apart from the rates of rebleed which do not come to 0, there's also the risk of radiation which range from 7 to 22%. So it's a cumulative risk of both a rebleed as well as a radiosurgery risk. But there has been increasing data, and of course they're not comparable because microsurgery rates, actually the deficits or the morbidity and mortality are only at the time of surgery. Once the surgery goes well and the patient recovers, there's always going to be an uptrend in his recovery. While radiosurgery, apart from the rebleed rates which can occur within the first 2 to 3 years, there is also the risk of post-radiation changes which range from 7 to 22% depending upon the dose. So, we would nowadays prefer incidentally detected on follow-up, while surgery remains the gold standard for accessible lesions which have either bled or symptomatic. Gamma knife has been debated. There have been changes in how we plan for gamma knife. For example, and these have been now reserved for small symptomatic lesions which are inaccessible to surgery or carry an unacceptably high surgical risks with a slightly decreased dose, and these have been shown to decrease the rebleed rates in cavernomas. And with either good surgery, I think the patients have quite excellent outcomes. Thank you.
Thank you, Dr. Dwarkanath. Can I call upon Dr. Vernon to talk about the management of intraventricular tumors?
Thank you, Professor Goel, for inviting me for this conference. I'd like to thank Abida and Apurva also for doing a wonderful job on this mammoth conference. Great going, guys. My topic for today is management of intraventricular tumors. Just to start with, this is the place where I work. And just to go about the embryology, you can see that. Okay. If you see when the ventricles develop, they are the biggest part of the brain, and it is the foundation on which the rest of the brain, parenchyma and the brain matter forms. So many times you're going to get tumors here which they grow to very big sizes, and that becomes challenging for the surgeon. It's not moving. It's not going forward. Can you do it from there? You can do it from there. Okay. So they're basically C-shaped cavities which communicate with one another, and they can go up to the fourth ventricle, and then the circulation takes place. I wouldn't go into detail. And then coming to the surrounding anatomy, it is very complex, and the ventricles are protected well by very important and also very crucial and critical structures which one has to preserve once getting into them. I wouldn't go into the detail because this itself is a big lecture, and what we have to know is the surrounding anatomy, because we have to enter normal anatomy to get into the ventricles and then tackle the tumor. So what we have to be very, very careful is when we are dealing with the area of the trigone, because most of our approaches would be for lateral ventricular tumors would be transtrigonal, and we have to understand what would be the difference on the right side and the left side. So coming to arterial relations, they're very important because when we are tackling tumors inside, we have to first tackle the arterial supply, and we have to know which is the supply, whether it is anterior, lateral, or posterior. I wouldn't go into detail of this. And what we have to preserve is the veins. So you can handle the arteries, but as far as possible, do not fiddle with the veins. Preserve as much as veins as possible. So coming to these tumors, they're not very common. They're just 0.8 to 1.9%. And they can grow to big sizes, and there are two types. One can be primary, or it could be secondary, which are already been classified. And you can have a variety of tumors, and some of the tumors which come from outside can go inside into the ventricle and behave like intraventricular tumors. Now coming to approaches, there are various approaches depending upon the site of the tumor, the size of the tumor, and the lie of the tumor. But the important thing here is that the approach has to be chosen in such a way that you have to immediately see the tumor once you open the ventricle. If you have to wander into the ventricle to look for the tumor, then you can get into serious trouble. So these are the approaches for the third ventricle, the anterior approach, the mid approach, the posterior approach, and it depends again, varies upon which tumor you are handling and where. Coming to the fourth ventricle, already discussed, it is the telovela or the Wormian approach, but the telovela is the preferred now. We have to do proper radiology, which involves the CT scan, CT angio, the MRI, the MR angio, and of course today we have to do DTI imaging and also see the fiber tracks which can lie and how we can preserve these as we enter the ventricle to get to the tumor. Angiogram also plays an important role because there are bridging veins which one has to preserve, especially when going for the interhemispheric approaches. So here we see the arterial supply, and we also can see the tracks, especially in the temporal horns, which one has to preserve while doing these surgeries. And then one has to choose the different approaches. Sometimes you might have the unilateral approach, or you can go from the contralateral side, depending upon getting the maximum size of the tumor into your vision. Surgical planning, very important, and you have to first plan these surgeries, especially plan the position, and also plan your trajectory.
The goals: most favorable trajectory, adequate exposure, resection of the entire lesion. Leaving half a lesion or a quarter of a lesion in the ventricle is dangerous. It can lead you into severe problems. And preserve as much as venous drainage as possible. Avoid too much of retraction, because sometimes you get carried away looking out for the tumor and can create more damage than the tumor by retraction. So this is a patient, this is an anterior type of lesion, which is a colloid cyst, and this is a classical approach which one can do. So what we do here is we don't use retractors, we use these pieces of marrow cell. If you see here, one marrow cell anterior, one marrow cell posterior, and inflate it just like you do it in the nose, and you will have a good amount of retraction. We place silicone patty on one side so you don't put a self-retaining retractor, and you have good enough retraction to enter the corpus callosum. Don't open the corpus callosum to more than 1.5 centimeters. It is less than 1.5 centimeters, and get into the ventricle. And the position should be such that you are bang on the foramen of Monro, so then life is very, very easy. Most of the times you will get the choroid plexus and the choroidal vessels which are adherent to these colloid cysts. So try to get the tumor in toto. Many surgeons are doing it endoscopically, but we have moved on from endoscopic to open now because that gives us a complete removal. And you might have the choroid plexus of both sides getting adherent to this tumor. Be careful of larger tumors which can also splay the septum pellucidum as well as the fornix. So here no retraction, no self-retaining retraction is required once you're in the ventricle. You can slide this silicone paddy, it is available with Surgiwear company, and you can use this as a protection as well as retractor. So that is the floor of the third ventricle, and if there is any vein, you do not coagulate, even if there is a slight bleeding. This is what we use, a hemo patch, which will preserve the vein without any coagulation. This is the post-op, that's the patient. So another central neurocytoma, here we use the transcortical, transtrigonal approach. So this is the ultrasound which helps you to plan your incision. So most of the intraventricular tumors we do with intraoperative ultrasound. Navigation is of not much help because the whole coordinates change because of the brain shift. So the intraoperative ultrasound is the best. So open the ultrasound tells you exactly how much of cortisectomy you require. And these tumors have to be debulked. You cannot remove them without debulking them. Again, no retraction. If you need to do retraction, it has to be dynamic retraction. No need of self-retaining retraction. And here you have to debulk these tumors. Preferably don't use CUSA too much because the CUSA is a powerful tool and there's no better tool than the suction. Suction is under our control. We can use the CUSA for tougher lesions and keep the choroid plexus as your guiding light. Because the problem is in the ventricles you get lost. You have to keep on reorienting, going to the scan, seeing where you are, and in a lateral position again, you aim for the choroid plexus, which gives you the guiding zone for you to handle and tackle the tumor. So you gradually debulk, debulk, debulk. There is a lot of vascularity which comes from these tumors, but you got to keep going till you see normal anatomy all around and preserve the veins. So that's the most important thing, where you have to preserve the veins. So you got to keep debulking till you reach the end point, and that's the vein which has to be preserved. So these are the thalamostriate vein close to the foramen Monro, which has to be preserved. So that's the post-op scan. So this is an ependymoma, which we went transkilosal. Again, no retraction, no self-retaining. So due to want of time, I will show you the same technique which we use for the colloid cyst. That's the post-op scan. Glioma, I think glioma is already discussed, so it's an en bloc resection. There are gliomas which can go into the ventricle. This is a frontobasal glioma, so which can be excised in toto. So this is a meningioma. which are tough lesions. So here again, one can use the ultrasound to localize and then do a corticectomy. And these lesions grow to big sizes. Sometimes you got to use a knife to cut them. No QSA will work here. And they're pretty big, so intratumoral decompression and a gradual excision. Also have a count of the cottonoids which we use, because there are a lot of cottonoids which are used intraventricular. One should have a count of this. So this is the post-op scan, that's the patient. So this is a large choroid plexus papilloma which look like a meningioma. These are the tumors where you have to go ready with a lot of blood in store because papillomas bleed and there is no stopping. Once you enter these tumors, there is no stopping. You got to get the tumor out. That's what. If you leave a tumor like this inside, it is going to bleed post-operatively. So we can excise these tumors, gradual debulking, and see to it that it comes out in toto till you reach the other end and see normal anatomy. You're not done. So due to want of time, I will not show the rest. So there are different, this is another craniopharyngioma we did, transventricular, no time. Another intraventricular epidermoid, which was done. Cavernoma temporal, which was done. And the posterior third ventricular pineal lesions, which were operated. This is the post-op. These tumors, when you operate on them, they're going to have post-operative problems, so you have to be ready for them. So we use this lateral sitting position for pineal tumors. We do not use the normal sitting position. Post-op. Another fourth ventricular epidermoid post-op. So just to conclude, there are technical difficulties because once you remove the tumor, the ventricles, they collapse and the brain collapses on you. So one has to be careful. You can prevent that collapse by using cottonoids all around. Now we use Merocell. It is much better. And complications, one has to be ready. You get complications like this. You don't get spared, especially EDH, intraventricular bleed. So we leave a drain for 48 hours, and especially doing large tumors. So they are challenging technically, but the aim should be to get to the tumor and get most of the tumor out. Thank you.
Thank you. We'll have the next speaker, Dr. Toshiki Endo. He'll be talking about the surgical management of intramedullary tumors.
No connection.
Thank you very much for the opportunity, and thank you very much for the invitations. And last night we had a great time, and we had felt India, and it's a great opportunity. Thank you. And I would like to talk about intramedullary spinal cord tumors. Before that, I just want to introduce my university, which is in Sendai, northern part in Japan. And there's a big disaster in 2011, and then after that, government decided to build a new university. It's in the Sendai district. So it was 2016, 5 years after the big disaster, that they built a new university, new medical universities. So now we are the very small numbers of the members, but we are trying to do the good job. And there's also the foreign neurosurgeons, residents coming from Indonesia, short term. Then he had a very good experience. So if you have a chance to come to Sendai, please visit us. And Sendai is a nice city, sushi. And you may know Moyamoya disease, which the former Professor Jiro Suzuki had named the Moyamoya disease in Sendai. So my background is I had a fellowship in Mayo Clinic 2003 to 2005, and I had a research fellow, Karolinska Institute, and I did spinal cord injury research. So which gave me the chance to pursue my career as a spinal cord surgeon. Then today's topic, I would like to touch upon intramedullary tumors. So consensus in the treatment, it's not necessary to the spinal cord, but all the neurosurgeons. We have to do the maximum resections if it is a tumor. Then we try to preserve neurological functions. So that's the key. Then it's very important to make balance. Then, as you know, spinal cord, it's like your little finger, very small. So try to take the tumors out and try to, have the neurological functions preserved. Is very difficult, I think. So as we know, there's a safety entry zone into the intramedullary spinal cord tumors. This is one of the posterior median sulcus. So you find a midline, then you go into the posterior median sulcus. So this is the example of the ependymoma, and I cut the spinal cord in the middle, then try to pursue the border between the tumors and the spinal cord. And we have the monitoring. We try to save the MEP and SCP in a good conditions, and we have take it out. And this is the intersigning green to make sure there is a perfusions preserved, then the neurological function preserved. So the lower part is the dorsal entry zone approach. This is a carcinoma. This is a hemorrhage. Then the patient had bad pain. So we decided to take it out, but it's relatively deeper size. So the echo ultrasonography is very effective. So we took it out, and this was the complete resection and the preservation of the neurological functions. So I was just curious how the neurosurgical experts in Japan, how they do in treating those difficult tumors. So the Neurosurgical Society, Spinal Society in Japan, have organized a multi-center study, 58 centers. So we have collected 1,000 intramedullary tumor cases with the various pathological diagnosis for over 10 years. So 1,000 cases. Then, as you know, as you may expect, at the ependymoma we have 360 cases. That's the most abundant. Then followed by the hemangioblastoma, cavernous malformation. I don't know if a cavernous malformation is a tumor or not, but astrocytoma and other 148 cases. So this is the neurological functions. How we do? Japanese neurosurgeons, experts. We have surgeons have more than 10 years experience. And, we have McCormick score. You see the blue and orange bars, which, the patients can walk independently. So it was 59% before the surgery, they walk. But after that, at discharge, they have a hard time, meaning the, proportions that independent walker decrease to like 50%. So, but after that, it's encouraging. Rehab and outpatient clinic, chemotherapy or other those would help the patients to recover well. So eventually, 24 months after the surgery, 72% patients can walk independently. So we have a hard time after the surgery, soon after the surgery, but we have to be, try to do the good job, and we have to encourage the patients. So, we have many cases. I just cannot touch upon all those cases, but this is the left side is the example of the hemangioblastoma. You have a vascular tumor, so we have to cut the arteries and try to save the veins, drainers, and try to take it out. So from the time matters, I just go to the right side is the cavernous malformation. This is the front of the ventral lesions. So we had a corpectomy, and we go inside. So this is the top part is the midline. So we have anterior spinal artery and a spinal vein. Then we try to take it out. And all those cases, we do the MAP, SCP, try to save the neurological functions. If you can see the margins between the tumors and the spinal cord, which mostly, successful, meaning that we can take it out and we can save the neurological functions. So closure on the right side is a corpectomy, so we have a, bony reconstructions. Then the left side, we take it out and we make sure that there is no remnant of the tumors by the intersigning green. So this is actually the series of papers from the 1,000 cases of the intermedullary tumors. Japanese neurosurgeons and, we try to do the sub-analysis, meaning we have ependymoma case, 360 cases. Dr. Naito published a paper in neurosurgery last year, hemangioblastoma cavernous malformations. So we have 12 case papers, a series of papers from our analysis. So if you want to refer, how we do, especially the rare cases like intramedullary schwannomas, intramedullary subependymomas, intramedullary metastatic tumors, how we should do, then you can refer those papers. This at least 10 years Japanese experience is here. So these are the cases. But, we still have many problems and the difficulties who I should be at least we have to tackle on, which is malignant astrocytoma in the intramedullary spinal cord tumors. Meaning, degree of tumor removals as a whole, we can take 65% cases total removal. But if you see astrocytomas, only 10% of the intramedullary tumors, we can take it out. See the hemangioblastoma, 91%, we can take it out all. But astrocytoma, whole WHO 1, 2, 3, 4, and we can take only 10%. So on the right side, this is a Kaplan-Meier of overall survival, astrocytoma, grade 4, median survival, 11 months. We have 33 cases from the 1,000 cases. So there's a rare cases, but the clinical results is really, really devastating. So now in Japan, I'm organizing the clinical trials to help the local control of those cases using the photodynamic therapy. So this is approved in Japan, photodynamic therapy, for the brain glioma, malignant gliomas. So we have tumors, then we take it out, trying to take it out all, as much as we can. Then after that, we have a tumor bed, and we are going to have a photosensitizer and a photo laser, to the areas. So we are hoping there's a local control better. So this is a clinical trial. So we try to see if the result is better by comparing from the historical cases. Like I said, the astrocytoma case, the patients can live like 1 year. Then if we have this one, how many patients can live longer, how the neurological functions preserved. So we have to be very keen on those results. So this is still currently going on. And this is 6 universities collaborating with us, the Nagoya University, including Professor Saito, and Hokkaido to Osaka. And we really try to focus on those, difficult case and try to do better things for the patients. So this is actually the Taj Mahal where I visited 2 years ago. It's 2022 NISCON. Then really, thank for the friendship in Japan. Then, we try to exchange the knowledge and the techniques, and I really appreciate it. Thank you very much.
Okay, thank you very much. So next speaker will be Dr. Rakeshi Jalali. Oh, he's not here. So last speaker will be Dr. Nagai. Nagai sensei is here, okay. And he will be talking about glioma-specific and highly glycosylated tyrosine phosphate, PTPRZ. Okay.
Thank you. PTPR zeta are glioma-specific and highly glycosylated tyrosine phosphatase. This content was originally published in Journal of Biological Chemistry, basic research report. Original title is Brain-Specific Glycosylation Enzyme GNT9 maintains levels of protein tyrosine phosphatase receptor PTPR zeta, thereby mediating glioma growth. So today I will talk about PTPR zeta and GNT9. PTPR zeta, protein tyrosine phosphatase receptor type zeta, is highly expressed in glioma cells. So the PTPR zeta is known for target, stereotypical target for glioma. PTPR zeta is modified with various glycans, especially with HNK1. HNK1 is specifically in CNS. HNK1 is a brain-specific glycan. This glycan generated by GNT9. GNT9 is glycosyl transferase. In this study, loss of PTPR zeta or GNT9 in glioblastoma cell, LN229, suppress tumor growth. PTPR zeta and GNT9 can be therapeutic target for glioma. PTPR zeta is a membrane tyrosine phosphatase. This is the structure of PTPR zeta. PTPR zeta is expressed specifically in the central nervous system. And oligodendrocyte precursor cells, astrocytes, and oligodendrocytes. Recent reports suggest that PTPR zeta is highly expressed in glioma and involved in tumor growth. And PTPR zeta has various glycosylation, such as chondroitin sulfate, HNK1, keratin sulfate. In general, abnormalities in glycosylation can be cause disease, such as cancer. So we focused on human natural killer 1, HNK1. HNK1 structure is this. This sugar chain generated by GNT9, B4GAL-T2, group ATP, HNK1-ST. In this study, we examined is a loss of GNT9 suppress tumor growth. First, we generated a glioblastoma cell line, delta PTPR zeta LN229. Look, this loss PTPR zeta. And we inject it into mouse's brain, and glioma growth was suppressed. This was already known previously. And PTPR zeta is glycosylated like this. And this is an antibody to detect PTPR zeta. Phosphocan detects PTPR zeta's protein part, and CAT315 detect protein part and HNK1 epitope. So we use this antibody to know what glycan PTPR zeta have. So PTPR zeta have chondroitin sulfate, keratin sulfate, stearic acid, HNK1. In xenograft mouse models, in mouse's brain and glioma cells detected by CAT315. So glioma cells in mouse's brain have PTPR zeta and HNK1 epitope. HNK1 is this structure and generated by GNT9. In vitro model, in vivo model, between in vitro model and in vivo model is very different at GNT9 or other glycosyltransferase level. So in vivo model is very important. We generated in vivo model, xenograft mouse model. And in human malignant glioma cases, we tried immunostaining for GNT9 and PTPR zeta. In human glioma cases, GNT9 is expressed, and PTPR zeta with HNK1 also expressed. So GNT9 can be therapeutic target for human glioma cases. So we generated GNT9 LN229. Look, this cell line lost GNT9. And we inject this cell line into mouse's brain. So this data shows glioma proliferation was suppressed. So GNT9 can be a therapeutic target for glioma. This is discussion. Recently, our research group reported that PTPR zeta is a potential diagnostic marker for glioma. But PTPR zeta has been reported to be involved in growth of gliomas. Therefore, PTPR zeta can be a safe therapeutic target for glioma. Our research group reveals GNT9 can be a therapeutic target for gliomas. GNT9 is a safe therapeutic target. So mouse lacking GNT9 develop normally. Loss of GNT9 suppressed tumor growth. So both PTFPR zeta and GNT9 are potential therapeutic targets for glioma. Thank you.
Okay, thank you very much. Yeah, any questions or any discussions that we would like to do within this session? Someone?
Dr. Solanki, can I ask, did you go for pre and post of detailed sequences to understand who will go under mutism and what is the prognosis of these patients?
When you mean, when you say pre and post-op
Yeah,
details,
details you can say.
we looked at all the clinical details as well. But of course, within 2 days, the patient develops cerebellum mutism. So all we can do is to look at preoperative and intraoperative details and then wait for recovery. So the good news is they recover on average 2 weeks. And on the intraoperative details, that's what we could find. Bleeding is the only thing that appears to be different in our study. But the Children's Hospital in Washington, they think that it's the 3 things. One is retractors. So we don't use fixed retractors as well. We only use flexible retractors. So they've stopped using retractors. So definitely retractors, one thing that I think everybody agrees should not be used during surgery. The second thing was accuser. So they've stopped using the accuser. They only use suction. And the third thing was the Vermian approach. So the 3 things that they identified. For us, the only thing that made a difference was the bleeding. The telovelar approach and the Vermian approach are the same. We don't use retractors, and we use accuser, and we didn't think it was that different.
Good, thank you.
Hope I answered the question.
Girish, hi. Girish.
Yes. Sorry.
Just same thing, but just want to know what happens to the kids and how do the parents cope and what's the support group? It's very important because, you know, if they were talking before, suddenly stop speaking, and because you manage a large number of cases with Washington group.
So this is such an important question. I mean, essentially, there are 2 things. The first thing that happens is they think that something has gone wrong. And in fact, for us as well, so we always do an MRI scan because I think there is also an association between postoperative ventriculomegaly and cerebellum mutism. Although there is no sufficient data for us to be certain, we always put an EVD if the ventricles are large. So that's the first thing we do. So I think the first thing is we are the culprit. So we try to take every possible step to reverse anything that could have happened. So EVDs, or in some cases even shunting, which we try to avoid in medulloblastoma because of other reasons. The outcome is worse with shunting, but EVD for sure. Then the discussion, ensues about nasogastric feeding. So all of these children, because it's not just they can't speak, they also have difficulty with swallowing. So to avoid aspiration, other things, they start nasogastric feeding. The parents are usually all of this is done preoperatively, so they know during the consent that there's a chance that they will get cerebellum mutism. But even then, postoperatively, there is a lot of difficulty. So we have speech and language therapists that come every day. They take part in the recovery of the child. So they would probably be in the hospital for about a month at least. So play therapy, school, everything that happens in the hospital.
But I mean, what percentage of kids start speaking normally and
so about 50,
functional recovery? It's
right.
Does the disease take over the time left, unfortunately,
So 50% of the children roughly recover in about 2 weeks. But there are some children who can take several months. So children who presented in a worse situation, for example, they came in, so we had a child who came in with a bleed in the tumor. That child already presented with a dilated pupil and had emergency surgery. So even though there was a gross total resection, the child developed cerebellar mutism postoperatively, and it took 3 months to recover. But then at the end of the 3 months, it was playing the piano. So it recovered really well.
But do all of them recover?
So far,
Only
in the
50%.
literature, there's not a single report of failure to recover. And the longest recovery, I think, was 183 days. So it can take quite some time.
Thank you.
Thank you. So, well, I think we are running out of time and we have to close this session. Thank you for the whole discussions. I would like to close the session right now. Okay. Thank you very much.
Thank chairpersons for taking us through this elaborate session. I've been asked to convey this message that we need to regroup around 7:45-8 for the felicitation program and the Indo-Japan Friendship Program. So I request you all, if possible in your traditional attire, to regroup at 7:45 and 8. Thank you. Thank you very much.
नहीं ये वाला नहीं है, ये नहीं है, वो 4K लिखा हुआ है। एक तो एक ये दे देंगे फिर। ठीक है वो दे देगा हाँ।
Yes. Yeah, I'm speaking. Yeah, talking to the audience like that. Yeah, it's coming nicely. Yes, sir. Very good. Yes. Okay. Here also, this is coming. Yeah.